Clinics Conference 2025. At Idea Clinics, the Institute of Diabetes, Endocrinology and Adiposity. Our focus has always been on reducing the burden of non-communicable diseases through specialized, preventive and accessible care. Since our founding in 2014, we have grown into a national network of super specialty clinics. Our hybrid model combines clinical expertise, data and technology to create a healthcare system that patient-first, efficient and less dependent on hospitals. This year's conference theme, Building for Bharat, India's Healthcare 2030, invites us to reflect on the future of healthcare in India. How do we shift from reactive care to preventive models? How do we build systems that work beyond urban metros? And what does meaningful integration of AI, robotics, and digital tools look like in everyday clinical practice? We are joined today by leaders from across medicine, public health, research, and entrepreneurship, each bringing valuable perspective to these questions. To all our speakers, guests, and participants, thank you for being here. We look forward to a day of thought-provoking discussions and new ideas. Welcome once again. Firstly, we would start up today's event with a panel discussion. And the first panel discussion was on thyroid truths and nodule insights. I would like to invite panel members onto the dais. Dr. Siddhartha Chakravarti. Dr. Siddhartha Chakravarti, currently affiliated with Idea Clinics and Apollo Hospitals, Jubilee Hills. He was a consultant in the Department of Endocrine and Breast Surgery at CMC Vellore from 2015 to 18. And he also awarded first prize for poster presentation. Is it necessary to perform a routine preoperative laryngoscopic examination before thyroid? 11th postgraduate endocrine surgery, 2013 from Lucknow. Next, I would like to call Dr. Ranjani Chakravarti onto the dais. Dr. Ranjani was Managing Director of CPAT Labs, Hyderabad since 2015 and also Director of Clinical Operations at Yuha Medical Data since 2022. Over a decade of training and practicing in the UK, specializing in histopathology, her areas of expertise include oncopathology, lymphoma, breast, gastrointestinal and pulmonary pathology. She has presented several clinical audits across disciplines, authored 20 plus national and international publications. Next, I would like to call Dr. Samantha Satyakumar onto the dais. Currently, she is working as an endocrinologist at Apollo Hospitals. She has done her DM in endocrinology and senior residency from CMC Vellore, and also worked as an assistant professor at Department of Internal Medicine, CMC Vellore. Next, I would like to call Dr. Arun Kumar Reddy Gola onto the dais. He was a consultant and head of nuclear department at Sindhu Hospitals, Hyderabad. He has done an MD in nuclear medicine from Chandigarh, PG. He was also fellow of Asian Board of Nuclear Medicine from Japan and also Spain. He was a member of Indian College of Nuclear Medicine and he also was a silver medal during his MD postgraduate residency. Now I would like to call moderator of the session, Dr. Brinda Agarwal, onto the dais. Dr. Brinda has done her MBBS and American Board Certified in Internal Medicine, American Board Certified in Endocrinology, Diabetes and Metabolism. She was also endocrine faculty for the Franklin Health System in the United States. She has trained at prestigious MD Anderson Cancer Center in Houston, US to manage endocrine-related cancers like thyroid cancer and adrenal cancer. And currently, she is affiliated with Care Hospitals, Hyderabad, and also with Idea Clinics. She has published in peer-reviewed journals and is also active member of many international professional societies. Over to you, Dr.
మరి ఎక్కువ వస్తాయి ఎక్కువ వస్తాయి
సరే అయితే జనాలు ఉన్నప్పుడు జనాలను బట్టి ఫోటోలు కూడా
నేను చూసుకుంటా ఇక్కడ
my good mother. Let's just.
Hi, good morning everyone. So it's a nice Sunday morning and I think you know begin on a little academic note here with the thyroid session here. So thank you all the panel members for being here. So we, without any delays, we'll further, without any further delays, we'll start with the presentations here. So I thought that we could have like a more case-based discussion. So we've put in a few cases and then I'll ask all the consultants, experts here that what their opinion would be about handling each of these cases. So starting away with the first case. This is a 36-year-old male with a progressive swelling in front of the neck for about 6 years. He complains of a foreign body sensation in the throat, looks clinically euthyroid. He doesn't have a history of radiation to the neck, no family history to suggest thyroid disease or cancer. When you examine the patient, he's noted to have a 6 by 5 centimeter firm swelling in the front of the neck on the right side, which moves with deglutition. It doesn't seem to have a retrosternal extension on palpation, and it is freely mobile, and the left lobe was not easily palpated. There was a chest X-ray available, which showed, I hope you can appreciate that the trachea was deviated to the left side. I'm not sure if I can point it out, but I hope you can appreciate it. And the carotid pulsations were well filled, they were not displaced, no cervical lymphadenopathy was noted, no signs of hyperthyroidism were noted. So, before I move on, I'll ask Dr. Samantha to, as an endocrinologist, I'm sure these cases are frequently being seen in the clinic. So, how would you approach this patient?
Good morning, everyone. I hope I am audible. Physicians and endocrinologists among us, we would usually be the first point of contact when you are thinking that they have any problem with your thyroid. So, just like any other case in medicine, it is better to use a step-by-step approach to look at their history, and it's a physical examination, you look for high-risk factors, and then you recommend a set of tests for them. So, the historical details here were reasonably complete. So history-wise, what are the things that we look for when someone presents with concerns of swelling in front of the neck? So if we think it is a thyroid nodule, of course we will be interested in whether it is growing. So it's the basics of any swelling anywhere in the body. How long the patient is having, how fast it's grown, is it painful? And coming to certain thyroid-specific points, are there any obstructive features? Is there voice change? Is there difficulty swallowing, difficulty breathing? So things like that to give us a clue as to the possible nature of the problem. Family history would again be important, especially in younger patients. This patient was in his early 30s. So we would ask for a family history of any probably cancer syndromes or for a family history of thyroid nodules or thyroid tumors. Past history would be relevant with regard to exposure to radiation or a history of head and neck radiation for some other cancer management in the past. Examination-wise, the size of the
examination is done. Investigations would be generally biochemistry and ultrasound. So two things which are definitely needed for all patients are, one is the TSH. So in case the TSH is low, the approach would be slightly different. In case the TSH is normal or high, the approach would be different. So followed by thyroid profile, we would also go with an ultrasound. So yeah.
So Dr. Samantha, you pointed out that if the TSH was to be low, then we would have a different approach. So Dr. Arun, I'll ask you, like if there is a patient, let's say here the TSH is within the normal limits, but let's say the TSH was suppressed at say 0.01, then usually how would the approach be in these cases, particularly talking about the role of nuclear medicine in these patients?
Hello.
Good morning, everyone. In the case of thyroid nodule with clinically patient not having any obvious hyperthyroid symptoms, but however the biochemistry revealing hyperthyroid status, thyroid specifically we usually call as the particulate scan.
దానిలోకి ఎట్లా ట్రాన్స్లేట్ అయితే అట్లా వస్తాను దానిలోకి ఎట్లా ట్రాన్స్లేట్ అయితే అట్లా
Hot nodule or a warm or cold nodule. But in this case, we usually expect a hot nodule. However, the size wouldn't be fitting factor for this. If it was a suppressed TSH, yeah, definitely thyroid might help in characterizing the nature of the nodule.
And this is mostly for the audience to know that if the TSH is suppressed, then we seek some sort of thyroid scan just to appreciate if it's a hyperfunctioning nodule or a hyperfunctioning gland. So thank you, Dr. Arun, for that. So we then went ahead and got a thyroid ultrasound for this patient. Based on biochemistry, the thyroid profile was normal. The thyroid ultrasound features are here. Dr. Siddharth, can you help us describe these nodules as seen on the ultrasound?
Yeah, ultrasound for a thyroid surgeon or an endocrine surgeon is like a stethoscope for the cardiologist. So we can't see any patient without doing the ultrasound. It's very important. So when we look at the ultrasound here, what we can see is the nodule looks predominantly a solid nodule. We can see a few cystic spaces, and the nodule also seems to have peripheral vascularity. And probably it is hyper to isoechoic compared. There's only a sliver of normal thyroid tissue though. So what I understand, it means, it looks like a neoplastic lesion when it's a solid lesion. If it was if it had more than 50% cystic component, then I would be happy, okay, most likely benign. But sometimes this minimally invasive follicular carcinomas can have this solid appearance. So when I look at it, I am a bit concerned and I would ask for the next investigation, that's a final aspiration cytology.
Right, sir. So we this is the thyroid ultrasound report. A large, well-defined hyperechoic solid nodule with some central cystic degeneration and peripheral halo measures about 3 by 4.7 centimeters. Left lobe was normal, no cervical tumors. But just based on the radiographic imaging, the thyroid ultrasound features, this was classified as a thyroid 3 nodule. So as Dr. Siddharth said, we would like to have an FNA done, and on the FNAC was performed, and it showed its mildly cellular. This is the FNAC from the right, 4.7 centimeter nodule. So, Dr. Ranjani, can you walk us through this cytology report that is shared on the screen?
Yes. The initial disclaimer would be, even as a pathologist, the first thing we of course do is to look at the clinical features, like the size of the nodule, the ultrasound report, the TSH. Before we even look at the smear, we have some idea on what's going on with the patient, and it's with this background that we actually look at the smears. In benign smears, I mean, this for instance, this is a single sheet. It's more or less uniform pattern. There is no cytologic or architectural atypia, which is what we're looking for. We're looking for cellularity, we're looking for the presence of colloid, and we're looking for cytology and architectural features. So benign smears usually, minimum to moderate cellularity, usually abundant colloid. In most colloid nodules are adenomatous nodules, macrofollicular sheets, and regular rounded nuclei. So this is not showing any distinct microfollicular pattern. I mean, it is a single slide, but these are the features that we are looking for.
Ma'am, this is just out of my inquisitiveness. How do you ensure that the prep or the smear that we made is adequate?
Yeah, we do have adequacy criteria. So over at least, I mean, even if not just on one slide, over 2 or 3 slides, we get at least 12 groups of cells with 10 to 10 cells in each group, then we call it out as adequate. I mean, the actual published guidelines are up to 6 groups, but that's really not adequate. We try to see that there are at least 10 to 12 groups with 10 to 12 cells in each group.
So that's on the same lines, just a word about what is this thyroid scoring system?
Thyroid scoring, each ultrasound feature is given a score. Like if you look at the consistency, and the consistency, if it's a solid lesion, and whether it is solid or cystic lesion, or it is purely a cystic lesion, that's one. And then you look at the echogenicity. If it is isoechoic, you give only 0. If it is, say, hypoechoic, then you give a point of 1. So every suspicious feature is given a score. Like if the patient is having any echogenic foci, particularly if a patient is having microcalcifications, then we give a score of 2. If it has macrocalcification, it also is given a score of 1. So every suspicious feature in the ultrasound is given a score, and when we add up all these scores, like there are several thyroid classifications. The first one, which was described, was the Korean by the Kwak and et al. So he was the first person to describe this, and they used the 5 common things, and if it is thyroid 4 and above, then they recommended a fine needle aspiration cytology. And now we have others, like the commonly used one now is the ATA, American Thyroid scoring for thyroid. It helps us in deciding which patient we can keep them on follow-up. If the thyroid score is low, thyroid score is 2 probably, and we can keep them on follow-up without FNAC. If the thyroid score is high, 4A, 4B, 4C, then you recommend a fine needle aspiration cytology, take it forward.
That's helpful to know, sir. So we'll move on. This is the second case. A 59-year-old male gradually progressive swelling in front of the neck for the last 3 months. Occasional dysphagia for solids. He's clinically euthyroid 2, no family history of thyroid cancer or disease. On exam, about 6x4 centimeter firm swelling in the front of the neck, more on the right side, moves with deglutition. Left lobe was palpable with some small nodularity. The trachea was central, unlike the previous case. Carotid pulsations were well felt. No cervical lymph nodes were noted, and signs of hypothyroidism were absent. Now, this is the thyroid ultrasound of this gentleman. Again, coming to you, Siddharth sir, how would you describe this ultrasound to us?
And go back to the previous image. Yeah, the previous image, you can see it's a solid cystic lesion, predominantly looks cystic, and few areas of hyperechoic. And the next. Yeah, the next image looks like a hypoechoic lesion on the left side, though the margins are well defined. So yeah, that's what it will be called.
And so this is the initial report for this gentleman. Right lobe is replaced by a well-defined cystic nodule with internal septations, and it measures about 3.6 by 4 by 4.9 centimeters. There are multiple cystic nodules with internal echoes in the left lobe as well, the largest being 1.3 by 1.1 centimeters. Lymph nodes were not present, low lymph activity was present. And so again, the impression was TIRADS 3 in both these lobes. So again, as Siddharth sir had already mentioned about the thyroid scoring, the 1 and 2 largely being left alone, benign. So 3 and 4 probably in the category where we are concerned about these nodules, and we usually take the next step of doing an FNSE. So again, for the biochemistry, thyroid TSH was 2.3, euthyroid patient, and FNSE showed atypia of unknown significance. Ma'am, so this is something which I also always kind of get in a fix about. Please describe us, help us understand this AUS category. We talk about the Bethesda system, Bethesda 1 to 6, and then 3 and 4. How do we judge between 3 and 4? Which nodules, would be concerning for malignancy? What is the risk of malignancy in these nodules?
It's good you brought that up. I did want to briefly talk about the Bethesda system, which is the cytology equivalent of the Thyroid system. And again, from 1 to 6. 1 is usually inadequate, and we used to have an earlier category of 1C, which was if we saw only cysts, macrophages, and colloids. 2 is benign thyroid lesions, like the earlier one, where there is no architectural or cytologic atypia, cellularity is moderate, plus there is a benign colloid. 3 is, of course, the contentious area. It's a gray area essentially. In the current Bethesda categorization, which is Bethesda 2023, so we recently had an update. There is a lot more information on how to deal with category 3 of Bethesda. Earlier, informally, we used to categorize it as AUS uncertain significance and AUS follicular. Right? So based on cytology or architecture. But now they have kind of formalized this, and you have 2 categories of AUS. Category 1 is where there is cytologic atypia. Category 2 is where there is architectural atypia. And we say uncertain significance because these the features do not add up to a diagnosis of say category 4, which is follicular neoplasm, or of papillary carcinoma, which would be a category 5 or category 6. So these cases have atypia, but the atypia is insufficient for an actual categorization of malignancy. So these smears are categorized as uncertain malignant potential. Again, based on either cytology or architectural atypia. For cytology, we are looking at maybe diffuse atypia, mild nuclear enlargement, irregular nuclei, maybe subtle features of papillary carcinoma, occasional grooves, occasional nuclear overlap, or irregular nuclei. So those are the cytologic features. In terms of architecture, we are looking for a microfollicular pattern. Right? And again, like I earlier mentioned, always there isn't much colloid in this smear. When we see a lot of colloid, we're usually reassured. It's usually not atypical or malignant. It's more likely to be an adenomatous hyperplastic nodule. So now current AUS category 3, that is of Bethesda, includes AUS C, which is with cytologic atypia, and AUS A, which is with architectural atypia. And these are categorized according to what we say is risk of malignancy. So there is evidence to show what is the risk of malignancy with each category, and further, at least in the West, they've used extensive molecular profiling. So the risk of malignancy is higher in the cases with more cytologic atypia, where you see crowding, or you see enlarged nuclei, you see some subtle features of papillary carcinoma. And many of these cases are actually NIFT, which currently, it's just again a gray lesion. Do not really consider it malignant. So a significant number of cases with Bethesda category 3, which which are called out because of cytologic atypia, are actually NIFT. The other category are the ones with microfollicular pattern, similar to this one. It was called a category 3, but it turned out to be nodular hyperplasia. So nodular hyperplasia should usually show only macrofollicles. But if it has, say, subtle microfollicular pattern, then it will be category 3. If the architectural atypia is more, there are sheets of microfollicles and with unrecognized atypia and a lack of colloid, then that will be category 4.
So, Dr. Samantha, suppose what would be your approach in the clinic? Would you contact Dr. Siddharth, or what would you tell the patient?
So this particular patient had non-specific ultrasound features that was also sort of intermediate risk, and now we have an FNAC report which also is somewhere in the intermediate risk. So I would have to tell the patient that he'll ask me what was the risk of malignancy. So it is not much, it's between 5 and 15% or something like that. So follow-up in these cases depends on a couple of factors. So starting from history, so the lesion is large enough here. The patient
Would be
has
like the risk factors, how you would risk
the patient has significant obstructive features here. Ultrasound again was indeterminate. The FNAC had certain features which were concerning. The patient is in his 60s. About 59 or 60 is his age. 59. So if it was a younger patient, we would advise closer follow-up. The patient preference would also be in favor of definitive management as opposed to long-term follow-up. So in patients more than 60, the chances of malignancy in these sort of patients is on the lower side. So one approach would be to keep the patient on follow-up, repeat an ultrasound, and ideally another FNAC. Okay, the second FNAC might give us direction. It might either be benign, or in case it comes as suspicious for malignancy or any of the other things, we could go for surgery. So one approach would be to look at the patient's wishes, and if he is alright with follow-up, we could advise an ultrasound followed by an FNAC at a reasonable interval. However, if it was a younger patient, or in this particular patient, the concerns are the nodule is on the larger side, he has compulsive symptoms. One approach would be to repeat another FNAC at the same point. Molecular mechanisms of diagnosis are not yet widely available in our setup, so if available, that would possibly be an approach to help us decide whether to go for surgery. So either way, considering the size of the lesion here, indeterminate features of ultrasound and FNAC and obstructive symptoms, I would possibly refer him for surgery at this point.
And Siddharth sir, what would be your
Dental only.
approach?
Dental
Usually you're
mic
looking
audio
for like a one-stage completion thyroid situation.
It is, now this patient has lesions on both sides of the thyroid. So both the right and left have lesions. So if I have a feeling that it is benign, and I will discuss with the patient. We end a frozen analysis and then take an on-table decision whether to do a completion thyroidectomy or not at the same setting. That would be the approach.
So thank you so much, panel members. I think we'll move on. So this is the third case. A 47-year-old male, progressive swelling in front of the neck for 2 months. No compressive symptoms, euthyroid, no past history of radiation to the neck, no family history significant for thyroid disease. to that point, could you tell us like some ultrasonographic features of thyroid nodules which make us more suspicious of them having malignancy?
Yeah, so one is whether the patient, whether the solid component, one thing we have to see is if it is hypoechoic. So this looks hypoechoic, one. And then you look at the margins of this. These margins are sort of irregular margins. And then we look at the point of contact of the solid component with the lesion. So if it has an acute, another important thing is whether they have any microcalcifications or not. The punctate echogenic foci, these sometimes are like samoma bodies on the pathology. And yeah, these are the main important features based on which we upgrade this lesion and looks like a suspicious lesion on the ultrasound.
That's very helpful, sir. And for the audience, we do have a thyroid ultrasound workshop later in the day, so I think there'll be more to learn about the same. So I think more images from the same ultrasound, and as sir was talking about the vascularity patterns here, we see more internal vascularity on the Dopplers. Anything else to add on these images, sir?
Yeah, I think the contralateral lobe also has a lesion, and which again is hypoechoic, and it has irregular margins, and there is a foci of calcification, probably a macrocalcification. So hypoechoic nodules are suspicious of malignancy, around 40 to 50% of them. Right. So yeah, this also need to be addressed in this patient.
So we do have the report here, right lobe, solid cystic lesion with microcal, internal vascularity, Thyroid 6, left lobe with hypoechoic rounded irregular lesion. Internal vascularity was not there much. And again, this was a Thyroid 4 lesion. No significant lymph nodes were noted. Again, euthyroid patient, FNSE was done as a next step. And this was suspicious for PTC. So coming back to you, ma'am, Ranjini ma'am. So like what is suspicious for PTC and what is PTC, ma'am?
Again, going back to Bethesda, suspicious is a category 5 and actual PTC is a category 6. Usually with papillary carcinoma, we give it a category 5 when there is insufficient material. Supposing, like we're seeing in the picture, we just, the top one, if you just had a single fragment, say, with minimal nuclear features, if cellularity is low, then obviously we cannot go ahead and call it a clear-cut malignancy. So it is in those cases where it does show features of papillary carcinoma, but the cellularity is low. These are the patients that are categorized as Bethesda 5 and suspicious of PTC. Whereas when we say category 6 and we call it out as a papillary carcinoma, it has all the features. Again, like I said, we're looking for cellularity, colloid architecture, and cytology. In papillary carcinoma, we're looking for, the bottom picture shows those large papilloid fragments. You can see that the fragment is rounded, and you can imagine that that's a papilla, with a central fibrovascular core and covered by PTC cells. So we're looking for monolayering, we're looking for papilloid fragments. And in terms of cytology, we're looking for all the classic features of papillary carcinoma, which again is nuclear irregularity, overlap, grooving, cytoplasmic inclusions. And then some soft features, bubblegum colloid, occasional samoma bodies like Dr. Siddharth just mentioned. So all these would actually go towards a category 6. In category 3, right, if we see just samoma bodies and we do not see any nuclear features, then we tend to call it a category, Bethesda category 3.
Understood, ma'am. Okay. So, of course, there was the suspicion this patient underwent total thyroidectomy. And then the final report said it was a classical papillary thyroid cancer, multicentric. With extrathyroidal extension present and no lymphovascular invasion was there. Coming to you, Arun sir, so this patient underwent total thyroidectomy, and now Dr. Samantha is wondering about, I need to probably talk about radioactive iodine treatment for this patient. So, like, if this kind of a case comes to you, sir, what would be your approach in terms of, radioactive iodine treatment, with what dose? What are the expectations, sir?
Whenever a patient, a post-surgery patient comes to us, we first want to categorize them as per the ATA risk stratification, so that we can explain to them that this is the actual rationale of giving the therapy. So in this case, classical PTC, though it's a multicentric lesion, less than 4 centimeter, except for the presence of extrathyroidal extension, there are no high-risk features. So it would still fall under low risk. This extrathyroidal extension feature alone raises it to intermediate risk if it is limited to the strap muscles. And so in a intermediate risk category, we would definitely want to give some adjuvant therapy to address the whatever remnant tissue that might have been left over post-surgery. So we maintain the patient on hypothyroid state for the next few weeks and raise the TSH. Would want the TSH to be at least more than 30. And like regarding the post-surgery pre-therapy diagnostic scan, it's a case-to-case basis. It's tailored based on the need. In this case, if we're going for a 30 millicurie adjuvant ablation therapy, that's pretty. We plan it based on the. Again, the decision is based on sometimes. In the next case, we can discuss. We had a case where the thyroglobulin levels would also matter. The pre-treatment thyroglobulin levels would also give an idea regarding how much of disease burden is still left over. So based on the risk factors, the stratification, and the thyroglobulin levels put together, we stratify the dosage to the patient.
Okay.
And,
that's helpful to know, sir. So basically, we should have a post-op TG, TSH level, and of course there is stratification to guide us through the dose of adjuvant RAI. All right. So moving on, fourth case, 28-year-old female with right neck swelling. On an ultrasound, she has a 6 centimeter solid isoechoic thyroid nodule. FNSE was done. As ma'am taught us about Bethesda system, it was Bethesda 2, so benign. And right lobectomy was done because of the sheer size of the nodule. For the surgical specimen, the right lobe was about 6.5 by 4.5 by 4.4 centimeters. Encapsulated nodule was found with focal calcification. On microscopic features, it had macro follicles with colloid, encapsulated neoplasm, 2 foci of intracapsular, 1 focus of extracapsular invasion, no angioinvasion, no extrathyroidal extension, margins were negative. So it was labeled as a minimally invasive follicular carcinoma, the tumor size being 6 centimeters unifocal. The pathological stage was put as PT3A. Ma'am, this is something purely I would ask you, walk us through this diagnosis of minimally invasive follicular carcinoma. What are the features? How do we actually, label a nodule as follicular carcinoma? So just help us with this, ma'am.
Well, actually on cytology, it should have gone as a category 3. Purely macrofollicular follicular carcinomas are very, very unusual, very rare. So I'm sure it would have focally shown microfollicles. So at least it should have gone out as a category 3. If not as it wouldn't have been a category 4 because they were macrofollicles in the histology. So by definition, follicular adenomas are well encapsulated. Yet we know the age-old definitions of well encapsulated, separate from the native thyroid, and a difference in histology between the outside of the nodule and the inside of the nodule. So that's an adenoma. So for a diagnosis of follicular carcinoma, we are looking for essentially 2 features. We're looking for capsular invasion and vascular invasion. So when we say minimally invasive, we are looking at lesions which have capsular invasion but which are not angioinvasive. Also, with time, I mean, it's a function of time. I guess more and more of the capsule is breached, right? So then it is widely invasive. As long as it's well encapsulated and it has less than 4 foci of invasion, that would be minimally invasive. But with time, if it has breached most of the capsule, it's extensively infiltrating the surrounding thyroid gland, and it also has angioinvasion. That would be a widely invasive follicular carcinoma. Here, cytology, it could still look bland. It does not really have to be atypical. It could still look bland. But like I said, we're looking for capsular and vascular invasion.
Understood, ma'am. Okay.
Yeah, this patient had 2 FNACs, and both were reported as benign at 2 different centers. And this patient had come to us, and she wanted microwave ablation. So she was not keen of removing a part of the thyroid. So again, as I said, it is not just an FNAC which helps us in making the decision. So you have to look at the ultrasound also. So the ultrasound is a solid lesion. It doesn't have colloid cystic spaces. So that says that, okay, this is a neoplastic lesion. Either it could be a follicular adenoma or at least a minimally invasive kind of a thing. And then, as I said, it's not, and how it feels to the firm. If it is a soft, freely mobile, then more chances that it might be. Yeah, it is subjective, I understand. But when you put your finger, you know, okay, it's a firm nodule, has a bit of a restriction. And when we take all these things, the clinical examination, then the ultrasound features, and then the FNAC, then we make, and what exactly the patient wants. So these are the things. So when we did it is a classic what you call a minimally invasive follicular carcinoma. And the next question comes whether she really needs completion thyroidectomy or not. Yeah. So, and she, as I said, doesn't want to lose thyroid. So how are you going to manage her? So ideally she will need a minimally invasive follicular carcinoma more than 4 centimeters will need completion thyroidectomy as per the guidelines, because there's a 5 to 15% risk of distant metastasis coming up over the future. But again, can you individualize in this patient? So if the patient has more than 4 vessels which are involved, more than 4 vessels, vascular invasions, these are the patients, when you follow them up, might come up with a metastasis later. This patient had only 1 foci of capsular bulge. So taking this into consideration, she wants to be on follow-up. We can keep them on follow-up. We monitor serum thyroglobulin and then keep her on follow-up. With an intact thyroid gland, is it going to make much? How can you assess this? That's a controversial topic. Whether you can, with an intact gland, can you assess the thyroglobulin? So usually each gram of thyroid produces 1 unit of thyroglobulin. So we monitor, and post-op after 3 months, if the thyroglobulin is say below 50, I am happy. If the thyroglobulin is say 200, then I am doubtful, and I would recommend for a completion thyroidectomy.
And that's very helpful to know, sir, I think, because I was going to ask you that if you have half of your thyroid, then how do you follow the TG actually? Sir, Arun sir, role of radioactive iodine?
First, I would like to discuss regarding the follow-up with TG. I've been recently attended one of the ATA new guideline chief who gave a preliminary draft on a webinar, and they did a study where post-surgery, in cases of hemithyroidectomy, whether thyroglobulin levels are reliable in following up those patients. They say that there might be simultaneous Hashimoto's that happening, and there definitely, as Sir said, if there is a marked increase, that might help in being alert and addressing that. But for subtle changes, we may not be picking up early. So that is one thing. And regarding radioactive iodine therapy, these are the patients. So when we are contemplating a follow-up, and when the patient doesn't want to undergo surgery again, there is a option of ablating the residual remnant lobe of the thyroid with low dose 30 millicurie radioactive iodine. And ideally, it would be, we would want a completion thyroidectomy to be done when the patient comes to us, so that we don't need to give multiple episodes of radioactive iodine.
I understand.
So if I do the completion thyroidectomy for this patient and post-op TG, stimulated TG is less than 1 and anti-TG is normal, and you do a 3 millicurie scan, it shows only a uptake in the thyroid bed. Would you ablate it? Are you okay to keep the patient on follow-up?
You want me to bite the bullet? So that low risk category is always a debated entity, and like to give the perspective to the audience. So the trend of radioactive iodine was somewhere from varies. We give the dosage somewhere from 30 to 200 based on the various factors like the risk categorization and the level of thyroglobulin that we see, and also the findings that we see on the diagnostic scan. And after 2015 onwards, the last ATA guidelines were released in 2015, and the next edition is expected in this year. So in the 2015, there was a trend of de-escalation where the low-risk patients can be followed up, is a statement given on ATA. And after that, we significantly saw the surgeons not sending the patient even to nuclear medicine. But yeah, however, this needs some validation with the data. And previously, it was about more a debate on whether we should give 30 versus 100 millicurie in a case of low-risk case. And there were 2 trials conducted in that context, the HILO trial and the Estimable 1 trial. These 2 trials have proven that whether I give a 30 millicurie for ablating the remnant or 100, the difference was not much, like the results were the same. So there is a trend that came from 100 to 30. So in all the low-risk cases, unless we are doubtful about the histopathology itself, or if the thyroglobulin is very high, or if there is a aggressive variant or something, we usually tend to go to 30 millicurie. Now again, there have been further trials, the Estimable 2 and as well as the ION trial, and the ION trial got published last week with a follow-up of almost 6.8 years. And Estimable 2 published the 3-year and 5-year results, where non-inferiority of surveillance alone was documented as compared with the 30 millicurie radioiodine ablation. So, we as nuclear medicine physicians, we are always would want to give that 30 off and want the TG to be more reliable marker, so that once we ablate all the tissue that is there, any increase in thyroglobulin would be a very sensitive parameter for a further evaluation. We can pick it up early. So, and even the recent ATA, it's yet to come into publication, but the main author, the chairman, also says that they studied similarly a large set of patients where post-op without radioactive iodine, whether they can have a specific cutoff, but I think they're coming up with a cutoff of 2.5 to 5, that range, as the cutoff value in those who are not treated with radioactive iodine. So once these guidelines publish, I think there will be more debate, and there even this stratification of low, intermediate, high is going to be more complex with the low category, low to intermediate, intermediate to high, and high. They are introducing one more category in the newer system that is going to come. So I think we may be having more panel discussions and more debates going forward.
That's wonderful, sir. I'm sure there is a lot in...
Fortunately, the biology of the disease has not changed. We keep changing the terminology though. Thanks to PTC, it's still, it's a good tumor and we can
that is true, sir.
Reassure the patient at the end of the day.
Right.
Thank you.
So in the interest of time, we'd like to close now. And I thank again all the panelists here. And it was a wonderful discussion. I got to learn something too. So just would be open for 1 or 2 questions. If anybody has any questions, they can raise their hand towards the panelists.
trending question these days is with the GLP-1 analogs. So recently I had a patient with a small thyroid, incidental thyroid nodule. The question is she at risk of medullary carcinoma thyroid, and should she get calcitonin checked and all that stuff? So where do you stand? This is going to happen to all of us in the, Samantha and Vruda might be able to.
We have actually had, all of us would have had patients, especially endocrinologists, come up to us with calcitonin values. They don't actually wait to ask us and then get values. So I think I would not use GLP-1 analogs if I thought the patient had a family history of a MEN syndrome, history of medullary thyroid cancer in the family. However, if they actually come with a calcitonin value and it is sort of less than 30, we can reassure them probably and send them off. In the interest of reassuring the patient, we could also probably do an ultrasound and have a baseline check on the features of the nodule. So in most cases, calcitonin would not be indicated in someone we are considering for GLP-1 therapy.
I agree with Dr. Samantha. I think routinely I wouldn't recommend it. And usually starting out a GLP-1, I would just simply ask them, any family history of thyroid cancer, and that too, like specifically I'd ask for medullary thyroid cancer. The rarity of this, association is like there, which I think doesn't warrant that we are checking calcitonin yet on every patient we are starting out with a GLP. Thank you. All right, so thank you so much for a patient listening. I think we'll pass on the mic.
Thank you, doctors, for the wonderful discussion. Next panel discussion was on future frontiers in diabetes care. I would like to invite panel members, Professor Dr. P.V. Rao onto the dais. Dr. P.V. Rao was director at Diabetic Research Center, Hyderabad, and also a patron of RSSDI. Next, I would like to call Dr. N.G. Sastry onto the dais. He was a medical director at GVK Health Club and also Mohan's Diabetic Specialty Centers, Hyderabad. I would like to invite Dr. R.N. Mehrotra. He's a senior consultant at Apollo Hospitals, Jubilee Hills, Hyderabad. I would like to call Dr. Betri Sani. Currently, she is a professor and head of the Department of Endocrinology at NIMS, Hyderabad. Next, I would like to call moderator of this panel, Dr. Smita Nalla, onto the dais. She was a consultant endocrinologist at KIMS Hospitals. Over to you.
Hello, good morning, everyone. Good morning to the panelists. So our session today, this morning, is about future frontiers in diabetes care. We are going to keep it a little bit semi-formal, as in we don't have any slides. We'll keep it an open discussion. And we have a few topics we were hoping to discuss. Then once the session is complete, I think we'll be open to take questions from the audience. So we'll get started. I think the initial topic we can start with Professor P.V. Rao sir, who wanted to talk about the latest ADA guidelines, standards of care in the management of diabetes.
Actually, I don't want to talk in detail about the ADA.
No, sir, just the some salient highlights, and then we'll do that way. Every topic we'll talk a few salient highlights, and all of us can contribute to the session.
Actually, last few years we have been following ADA guidelines. Whether we follow the guidelines in clinical practice or not, we just go on reading about what they have been writing and what they are prescribing. So we are gradually being told that all the medicines which we use routinely in our practice in Hyderabad are being outdated. So they say, irrespective of the effect of metformin, you have to give GLP-1 for most of the patients. They have given some parameters how to decide on people with anybody above 55 years, obesity, smoking, microalbuminuria. A diabetic should be, the first line treatment is GLP-1, which most of us don't like, I don't like, but anyway that is what is being prescribed by GLA. And recently, a few weeks back, I went to China on a government visit. There I saw the Chinese people seem to be blindly following Americans, which I never expected. That they are blindly, I told them openly, they are blindly following Americans. They are giving GLP-1 even in renal failure and in people with liver problems also, they are giving GLP-1. So anyway, GLP-1 seems to be very popular nowadays. So gliflozins are not very popular in China, but gliflozins also seem to be. So the first line treatment in diabetes right now, according to ADA, not according to what myself, is that we have to decide whether your patient is going to get cardiovascular or renal problem. If somebody is going to get cardiovascular, you have to put them on GLP-1. Is going to get a renal problem, he has to put them on gliflozin. Or if somebody is going to get a congestive heart failure, like that. It's basically they are trying to decide on which medicine is good. So first line drugs are always GLP-1 and gliflozins according to ADA.
True, sir. I think the algorithm has very much shifted in the last few years, where the treatment has gone from just being centered around glycemic control to looking at all the comorbidities of the patient. And but ADA does very nicely also provide guidelines for countries with affordability issues also. So that we have to very much keep in mind, especially in a country like India. So, sir, what is your stand about now that we know that GLP-1s, incretins and SGLT2 inhibitors are very much favored, not only in patients with comorbidities, but other patients also, they are being trumped as the first line or even second line treatment just after metformin. So, do we still have a role for the other molecules in the treatment of diabetes?
I don't prescribe them so often, but basically now, though it's not accepted by government, you can give GLP-1 in many other conditions, non-diabetic obesity, GLP-1 is prescribed all over the world. In India, it's not acceptable. Similarly, GLP-1 is given in Alzheimer's disease, GLP-1 is given in sleep apnea. I'm seeing many ENT doctors in Hyderabad are prescribing GLP-1 first line in obstructive sleep apnea. So similar like that, they have been prescribing GLP-1, especially the semaglutide has become a sort of an established drug right now in India, in Hyderabad. People seem to know a lot about semaglutide. I'm talking about non-endocrinologists, non-diabetes doctors, so ENT doctors and other doctors. They seem to be well aware of good things and bad things of semaglutide. So it is being used in many other conditions also nowadays. It's not my opinion, but that's what is happening everywhere.
True. I mean, we now have patients coming and asking, we have been asked to start that molecule by the other doctor, and they are asking me why you didn't prescribe it for us. So things are going round. When we think about trying to match everything, but still, I don't think enough thought process is being given to all the adverse effects of the molecules which we are introducing in these patients. Beatrice, do you want to talk a little bit about
clarify
adverse
about the indications approved in the Indian setting as of now for GLP-1 RAs. So if you look at semaglutide, the oral form is approved for treatment of type 2 diabetes, not for obesity. Injectable, yes. we have approval for treatment of type 2 diabetes as well as for obesity. And the twin creatine, that is tirzepatide, has approval for both diabetes, type 2 diabetes, as well as for obesity. So this is the current stand when it comes to approval in Indian setting.
Yes, I think we definitely need to bear that in mind, especially when we are counseling patients. So if we are giving oral semaglutide to these patients for obesity, especially non-diabetics, they need to know that we are doing it off license so that we cover our bases, and they also know how much of weight loss, etc., to expect from these drugs. I'll touch a little bit more on the obesity side, because I think there's another session going on for obesity, so I'm not going to ponder too much on that. But just a quick note about the adverse effects, what we need to counsel the patients. I think one was brought up just earlier towards the end of last session about having a thyroid nodule, especially with more and more patients being put on GLP-1 agonists. Shastri sir, any comments on the adverse effects of GLP-1 agonists that we need to counsel patients that should at least be documented in our notes as doctors?
Okay, as per the guidelines, as per the thyroid, the things, it's medullary thyroid carcinoma and men's, which is very rare. Okay, so rare things are very rare, why unnecessarily we should break head, that's first point. Second thing is, if there is any doubtful lesion, there is a problem. For example, family history of, say, even papillary thyroid carcinoma, or 2-generation family history, or somebody has the PTC or something like that. In such case, it is prudent on our part to avoid GLP-1. So, and routine checking of calcitonin levels and other things not necessary. But what we have to do is, nothing wrong in the interest of the patient. Sometimes nothing wrong in getting an ultrasound neck. They're morbidly obese people. It's very difficult to palpate and try to figure out. Nothing wrong in getting a thing, and if there is any lesion or anything like that, we can look after. But generally, I counsel my patients as per the tirzepatide as well as semaglutide uses, always about the gastrointestinal side effects which are common. And with tirzepatide, I found that diarrhea is much more common than nausea. They're tolerating the medication very well as far as the nausea is concerned, but they're complaining about loose motions. So, which we have to address and think. And semaglutide, I think it's more nausea rather than loose motions. There's one observation which I found. Maybe other people can...
Some people are reporting constipation also, but that's variable. Yes. I think I saw more of constipation with tirzepatide. But I think it's just patient dependent.
People are losing weight. I'm happy, the people are coming and thanking us. Youngsters are tolerating well when compared to more than 50 plus. Any 50 plus, like you say that, they come and they say that, oh, you have given this medication, after that I'm feeling so uncomfortable or something like that. 55, that type of group, whether women or men. Yeah. But youngsters, 20, 25-year-old, mainly when indication is for obesity, I think they're tolerating well. Maybe because they're motivated, they want to lose weight, that 145 kg person and 125 kg person, that type of people whom I'm seeing, those people, they're very happy about it.
Absolutely. And also we are yet to see the effects of the higher doses of tirzepatide in India yet. So there's also a lot of talk about the non-arthritic ischemic optic neuropathy. Mehrotra sir, to shed any light. A lot of talk about amongst us diabetologists.
There's one published study which has shown that the risk is more. The decision, I think, is still yet to be taken by the FDA regarding that, but they put a label on that now. The GLP-1 analog having a label of the risk is rare, but it is there. And the main thing basically is to control the risk factors of dyslipidemia, hypertension, and obesity. Again, the same thing come back to that. The primary disease itself will be disposed to anti-rescheduling autoneuropathy, or the drug is causing it. That debate is still on. But the risk is there, has been documented by FDA. So we should warn our patients in case you have a vision loss, definitely stop the drug and come back for an ophthalmic examination. For diabetic patients going on to the drug, we should have a baseline evaluation of retinopathy, because the sudden fall of the A1Cs can be disposed to increasing the risk of the progression of retinopathy. That's important.
I think the thing is, we're giving all these molecules. already the cost is prohibitive. If we start telling you have to go for this big list of tests before you start on them.
Complication, he will not leave us. Suppose tomorrow he had a PDR or he had a moderate severe NPDR and then he gets a PDR within 6 months of the GLP-1, he will catch a neck. Though basically it's the long history of uncontrolled diabetes which is causing the problem. But in case we are prescribing it, we will be caught.
True.
So we should have a baseline evaluation. Like a patient going for pregnancy, we do it, whatever it is. It is required, it is required.
So I'll move on to the next topic. I think we'll ask Beatrice, who's going to talk a little bit about the next frontier in diabetes care, which has already started up in India and hopefully much more coming up here. So this is closed loop management of diabetes.
So the closed loop pumps right now, so I'll pertain to type 1 diabetes because type 1 diabetes, if you treating type 1 diabetes is actually like walking a tightrope because you have hyperglycemia on one side and hypoglycemia. And that is their way of life. That's what we've always been looking at, the hyperglycemia and the hypoglycemia. And it's almost impossible to achieve a stable glycemic control with the sort of multiple daily dose injections that we are giving because it never can mimic the physiology. So children especially, they have different levels of physical activity. Their food habits are not really constant. So it really doesn't work that way, the multiple daily dose insulin. We may have a HbA1c of less than 7.5% as given in the guidelines. But if you take a closer look at what's behind that HbA1c, you will be documenting a lot of hypoglycemia. So if you look at the CGM monitoring, there is a lot of hypoglycemia, hyperglycemia, a lot of fluctuations. So I think ideally we should be treating the fluctuations rather than only look at the HbA1c. And that's when the closed loop pump technology comes into focus because the advantage is that definitely there is more time and range when you put the patient on a closed loop pump, especially the automated ones. So there is more time and range and even the time below range goes down significantly. And we at NIMS, we have actually the basic pump, not the automated pumps, but we give it free of cost from Government of Telangana. So we have about 100 patients on the basic pump, that is 700G. So again, there we found that monitoring is so important. We have written up a paper on that. The monitoring is so important because there, if you look at the basic pump, it's basically the advantage is that you're not going to give one shot of basal and stop there. So the basic pump will actually sort of, take care of the basal insulin needs very well. So you give the setting. So somebody may be having a dawn phenomenon. Somebody may be having a somyogi. So when you connect it with the CGM and you know what is the sort of pattern the patient has, you will be able to adjust the basal rate well. So it still works. So even though it is not automated, it still works. And we have documented that the time below range is actually coming down when you give even the basic pump. And then needless to say, the quality of life, it improves by leaps and bounds when the child doesn't have to take 4 pricks per day. Mm-hmm. So it really improves. And even the caregiver distress, again, we have written up a paper on that as well. Mothers whose children are on pumps, they have less caregiver distress compared to somebody who has to keep on poking. So again, the child can be trained how to take the insulin through the insulin pump. So in the school, again, going and storing the insulin and again, taking it out and taking, it's a lot of hassle, in fact, a lot of logistic issues and a lot of peer pressure and ridicule, especially for the child. So here the insulin pumps help in a big way. So these are the advantages of, having a closed loop. The disadvantages, we really have not closed the loop. Because still the kind of pumps that we have in India, the 780G, so still we have to give a meal announcement. So still we have to give the bolus by ourselves. Although the pump autocorrects, we have the sensor giving the information to the pump about the blood sugar values of the child. But still, the meal time, the bolus has to be taken. And it requires a high degree of digital literacy, a high degree of drive to use these pumps and take care of the pump. That again, we have had bad experience. Children not understanding the importance of the pump and not wearing it all the time. So these kind of problems creep in there. And not to talk about the cost. Because fully automated pumps cannot be afforded by everybody because it costs quite a bit. And the recurring costs are also more. So there we have a little issue. Right now in the Indian setting, probably closed loop or automated pumps may be a far dream. But of course, we should try and get all our type 1 children. That will be really good if we can get all of our type 1 children on the automated pumps.
Yeah, absolutely. So the main thing I think we need to counsel our patients when they are asking about a pump is it's not going to be a cakewalk. Just because they're getting a pump doesn't mean that they stop calorie counting, doesn't mean they stop checking whether it is by finger prick or it is CGM. They still need to keep track of things, what is happening. And as Dr. Beatrice has explained, this is not, so automated pump, the fully automated pump is still a long way away in terms of the economic affordability. It is very good at ironing out the hypoglycemia risk, especially with the with the suspension of insulin when there is any risk of hypoglycemia. But there's always glitches because the sensor is always 5 to 10 minutes late compared to the actual real-time blood glucose. And there is also the fact that it may overcorrect sometimes. I think it's supposed to be very good at giving corrections for hyperglycemia as well. But there may be, it is all patient dependent. The patient still has to feed in the number of calories they are taking, what activity they are doing. I think that's where they're trying to come up with more and more new things with what is called as wearables and all the algorithms, so that they can actually monitor the physical activity of the patient, the sleep of the patient. All those criteria will also be taken into account. I think there are some organizations here who are working with some of the doctors to try to make what is called a digital twin. I'm just hearing about it. Digital twin is, what they do is they provide you with a CGM and they provide you with these wearables. So it's all part of the package. And they they take all the data for the first few days about all the physical activity, the time you take your food, your regular meals, and the calories and everything. And they make artificial intelligence program, creates a twin which replicates what your sugar levels would be and which drug would be ideal for you. So it doesn't necessarily apply only to type 1 diabetes. I think they're using it more for type 2 diabetes. I believe there are some programs here, and I've spoken to a few consultants who use them, who say that it works very well for their patients. They have papers saying that the A1C, there is definite A1C reduction, there is definite hypoglycemia reduction with actual reduction in the number of drugs that they are taking for the diabetes. So a lot of frontiers along this, and as Beatrice, it's very nice that they are getting to do so much work with children who are being given these pumps. So CGM, do you give CGM to them as well, or only the pumps?
So we give only the pumps, and we take care of the monthly expenses for the quick set and the reservoirs. But CGM is something that they have to buy. Sometimes we do get sponsors for the CGM as well. Mm-hmm. So that again, we try to give it at least for, once in 3 months at least for a child, so that we see the pattern. Or if there is any variation in the blood sugar, we do get sponsors to give them the CGM. And now, in fact, the pumps are available even under Arogyasri. So we give the pumps under Arogyasri.
And one last question on that is, if the child or the adult that you have given the pump to, you obviously call them back for the A1C monitoring. If they're not maintaining that A1C, do you take the pump away?
No, we do not punish them. No, we just counsel. This has happened. This is what you say has really happened. Because over the years, the sort of drive and the enthusiasm comes down after using the pump, and they get used to it. So sometimes the drive comes down, and then there is the HbA1c goes up. So then that is the reason we have a peer support group. So we meet at least, we try to meet once in 2 months or 3 months, but all the children come, and then, we try to get in it's like a group consultation. So it's not like for each individual child. So we try to group in the children with the bad HbA1c with the good HbA1c. So we'll try to figure out what the problem is, but we do not take away the pump.
Okay. Sir?
I have quite some patients who are on pumps. I have quite some patients who are on pumps, like they're on, at least for the past 30, 35 years. In Madras itself, when I was practicing, I started on a first pump or something like that. I'm so happy about the 780G, like this sensor that gives real time. And after that, people are getting fantastic follow. Now, One thing what I found is those people who are using pumps, the follow-up is lost. They themselves, they check their HbA1c.
They do
and they say that, okay, like I'm good. And they won't come for follow-up. That's one thing which I have seen. I spoke to the only pump devices that is given in India, they are on Medtronic, even though I'm not supposed to name a company, but that's the only people. Like I told them, what actually happening, why those people are not coming for follow-up. Okay, let them have at least once in a year eye checkup, let them have at least counseling once in a year. So that's one of the biggest disadvantages what I have seen as far as using the pump. But they're doing very well. I'm so happy with the 780G, and that's fantastic. That is one of the nightmare as far as the earlier pumps is setting up the basal. It's not that easy to maintain the correct basal, like 3 or 4 permutations, combinations we are supposed to do. Now, like this automatically selects the basal, and your duty is carb counting and as well as giving the adequate bolus. That's it. Everything the 780G takes care.
Sir, are you using, sorry, I missed that part. Are you using it in type 2 diabetics as well?
Very few, but majority of my patients are on type 1 only.
So when
but
you use it in
type
type 2 diabetes, do you document insulinopenia in them, or is
Yes,
it
I
on
do.
clinical
like I
basis?
check, C-peptide, and duration of the diabetes is very long, and already on multiple doses of insulin, 3 or 4 shots per day, and they're worried about the number of pricks and they can afford. So these things I'll keep in mind, and if they can afford, like why not like give the benefit? But guidelines won't recommend that, like okay, give routinely. But if the affordability is there and multiple pricks are to be given in that particular patient, I think there's nothing wrong in giving pumps to them.
Sure. Unless anyone wants to say anything else about closed loop. So moving on to the next frontier, we'll pass on to Dr. Mehrotra sir, another interesting topic in type 1 diabetes. We'll be talking a little bit about islet cell transplantation and immunotherapy in type 1 diabetes. Very much upcoming therapy. So moving on from actually replacing the hormone to try to prevent the disease.
Yeah, thank you for the question. I think there's one more addition to it. I'll be like the 3-part. Vitamin D deficiency in type 1 diabetes is basically it's an upcoming role. There have been some studies which can link the vitamin D levels to the deficiency to the type 1. But exactly there is no cutoff level of vitamin D where we can say this is the level where the risk goes higher. The recommendation for vitamin D replacement is still the same, 400 for breastfed, 600 for toddlers, and after that 800. It's not that every child has to be given high dose of vitamin D to prevent type 1 diabetes. There's no definite correlation between if I give vitamin D, the beta cell will improve. But it has been said it can help you, but it's not going to replace that. After that question comes the question of the immunotherapy. As of now, the approved therapy basically is only the one, that is the, which was, Teplimizumab, and that has been used in stage 2 of type 1. That basically when the patient has antibodies positive, but not gone into the classical florid diabetes. There we can use it to prevent the further progression to stage 3. There has been a trial published for stage 3, but still not been approved by FDA for stage 3. So only approval is for stage 2. That is for patients with antibodies positive and a fasting sugar above 110 to less than 126, and a post-glucose between 142 to what we call as IGT. Now, the question in our country comes that we don't really track the relatives of type 1. We don't have a population who is already in a follow-up to say this is the population who is the relative of type 1 already having antibody positive, and what is their GTT. So that is the risk group where we can say this group is going to be benefiting from the immunotherapy. Coming to the other therapies, which have been all lot of experimental, coming to the role of transplantation, the main thing is the simultaneous pancreatic and kidney transplant. That is the thing which works very, very well. The patient already having a type 1 diabetes going for a kidney transplant. At the same time, you replace the pancreatic transplant. So these patients will be on lifelong immunotherapy. So there, the one immunotherapy can help you to both counter them both, and the outcome is better in these patients. Only pancreatic transplant is possibility in patients who are having a lot of morbidity of the diabetic fluctuations. Somebody having a lot of brittle diabetes, they can benefit, but provided they don't have the end stage complication. Coming to another subset, the islet cell transplantation. The one compound that the islet taken away from the cadaveric has been tried and has been approved by FDA. It's called Lenditra, and that has been approved for patients having frequent hypoglycemias. That can be used. It can be used in patients going for kidney transplant also, but again, because these patients will require lifelong immunotherapy. It's not that you do a islets and transplants, they will require immunosuppression for lifelong. The stem cell therapy is still very upcoming. The allogenic transplant is happening, and the stem cell therapy is happening, but again, it is in a very, very early stage of stage 2 or stage 3, yet to be approved by FDA. There was one report of last year which came in, where they have used the autologous transplant we use. That patient will not require a lifelong immunosuppression. I think we need to see more trial of that. As of now, if you look in our country, what we can look for is the simultaneous pancreatic kidney transplant, and it works quite well. We have a couple of patients who are doing very, very well after that. Transplantation alone, we have not tried that till now.
Thank you, sir. So, is islet cell transplant being offered anywhere in India? Not to,
I do not think so.
not to my
trial,
knowledge, yeah.
That is a different
We do
thing,
get the odd question about it, but not to my knowledge.
I think only one center has been approved in US also. That's the same thing which has been the Lenditra.
There was some talk about hospital in Chennai offering it, but I think because of lack of take-up of patients also and the costs involved.
Stem cell will take some time to come. It's not going to be easy. The autologous will take more time to come. The allogenic may come in some time. I think one company is already trying for approval. They already have finished phase 3. That's called VX880 compound. That may come in first.
Certainly, simultaneous pancreatic kidney transplants are being done, and they do have a good success rate of being able to come off insulin also. So that's a good option. Thank you, sir. I think our next topic, Shastri sir will be talking. Shall we do remission or? Yeah. So we're going to talk about the thing which many of our patients keep asking us. I have come now with diabetes, irrespective of the duration of diabetes that they have. But I have read in the newspaper or heard on YouTube or my neighbor told me, and now I want to get my diabetes reversed. Is it possible? How do I go about it? So over to Shastri sir.
Yeah, I'll give my experience. Recently, one patient walked in and with a fasting value of 200 and post-breakfast value of 300 is around 35-year-old. Okay. First thing what he asked, can I go for remission? Reversal of the diabetes. Can I go for the reversal of the diabetes? I said that the word reversal is not acceptable. Remission is a more scientific word. Anyhow, first, without passing examination, you cannot get university first. People, first you have to pass the examination. Simple basics they have to pass. After that only they have to think about getting the first class or second class, or after that university first. Now, see, the thing is, remission is possible. I'm not saying that is an impossible thing. Remission is possible. Evidence is there. Direct trial is there. But what you have to look into is the 3 or 4 factors which you have to look into. One is the HbA1c. The HbA1c is a very, say 7.2, 7.5, and if the body mass index is very high, in the sense like around 32, 33 or something like that, or if there is, if you check C-peptide, if there is adequate C-peptide reserve, and if the duration of the diabetes is smaller, and also if the particular person is enthusiastic, it's quite possible. But at the same time, I'll always remember Professor Bipin Sethi's words, like what he said is like, it's just like catching an oasis. Okay, it's possible. One person may get the oasis, but most of the people will be after mirages. So one has to first get the targets, after that talk about the so-called remission. So people are unnecessarily carried away, and they're actually first 2 years, 3 years of their diabetic life, which is very critical as evidenced by several trials, they're just not bothered, and they're just going on after mirages, and after that getting into problems. But at the same time, it's possible. The evidence is there. Direct trial showed that, yes, possible. And maybe my colleagues can add.
I think we still have time, sir, if you want to.
See, the pathway of control and the remission is same. I tell the patient very clearly. First you get the A1Cs down, maintain a good healthy lifestyle, then we'll talk about the remission. One, I think the mirage basically what they're saying is, if they, even the sugars come down, you may go off the medicine. but dietary modification has to remain in place. If you leave the dietary modification, the whole metabolic process will start, again the dysglycemia will come, and again the prime. So monitoring and the diet modification and lifestyle modification has to remain even if they go off the medicine. That is a very, very important thing to remember.
Yeah, by definition, at least 6 months without medication, if they keep getting HbA1c 6.5, probably we can call.
Absolutely. I think the actual presentation of the patient is very important, that they definitely don't have any symptoms of insulinopenia or osmotic symptoms, and their duration of diabetes is much lower, and they are of higher BMI. What about our patients who are with a strong family history, who are lean, and come with your A1C of 10%, 11%? Do you ever see them, envision them getting off medication?
Very, very unlikely. So they are insulinopenic, as you said, and sarcopenic obesity. And those people very unlikely to get into. They need to first start getting good diabetes control. After that only talk about remission. So we have to buy time. As a physician, I always say that, okay, like first start getting me good results. In 3 months' time, I'll give you, and see, this is the medication which I'm suggesting you. First, start getting into good targets. After that, we'll discuss about it. So down the line, 4 years, 5 years, you'll understand that it's not possible. So, like I think only a few percentage of people, it's possible, but at the same time, unnecessarily like going for certain diets and other things, and fat diets and other things, and getting into serious problems, which is not warranted.
Used for the remission of diabetes. I've seen colleagues are using it, and it's very expensive, it's not cheap, but it's possible to do it.
I think we have to remember about the legacy effect concepts also, that we know from all the big trials that all this time you are buying by saying, I'm trying to reverse my diabetes, I'm trying to go into remission, is going to catch up as you go longer in your duration of diabetes. So you're better off taking some medication and keeping your levels okay rather than waiting for the diabetes to reverse. Sir, P.V. Rao sir, any comments on this?
As you said, actually it's not possible to reverse diabetes. But there are so many people trying. We have done all those trials earlier. We have done many trials for reversal. Recently we published on yoga also. June last year we published a national study on yoga. It's not possible, at least in Indian context, to reverse diabetes, but of course you go on talking about twin therapy, stem cell. Actually, we are the first people to start doing stem cell in NIMS hospital way back in 2006. So I'm sort of a frustrated man with all these experiments. We have done so many experiments with diet, yoga, low-fat diet. We have so many PhD students who are working on low-fat diets. So as of now, in my experience, it is not possible. But of course, people have been trying so many things, and I hope that in some time in future, we may have some advantage with one of the therapeutic modules to reverse the diabetes. I'm also familiar with what is happening in AAG hospital in this direction. So it is still not conclusive enough to talk about reversal. But there is of course remission, there is of course resolution, remission, but no cure. And okay, thank you.
Sir, I think with the stem cell therapy, etc., we have to take it with, yeah. Beatrice, anything to add?
We're going to open the Pandora's box. I really don't believe in remission. At least the kind of patients that we see, I don't believe in remission.
Yeah. And I think if we push our patients too far as well with the low, very low calorie diets, and now with all the other molecules also, now we are living with, the patients are living with them, coming back to us. We are seeing significant problems with muscle mass loss and vitamin deficiencies, etc. So whatever we do, I think we have to try and see what is best for our patient, not make promises. what we can't do. So are we still having time or we run out? So any, yeah, too many bells. So any last comments about any few frontiers that we are yet to cross?
You just mentioned about loss of
Muscle mass, correct, sir.
Sarcopenia seems to be a problem with GLP-1,
yeah.
And sarcopenia is a problem with many of the dietary interventions. So out of the way, I'm just having some idea about vitamin D. Though it's not a direct treatment for sarcopenia, but tell me something about whether by giving vitamin D replacement, can we treat or at least can we prevent sarcopenia and GLP-1?
For sarcopenia and GLP-1, we need to have adequate protein and the multiple nutrients plus the resistance exercise to maintain that is important. Vitamin D has a role to play in the muscle power. We can go up to 1000 IU per day, and maybe you keep the vitamin D levels above 30. More than that, vitamin D alone will not be able to prevent the sarcopenia, but it can help you to maintain a good exercise plan, or muscle power can be maintained.
Okay, sir. I think that was a very interesting, enlightening discussion into some aspects of type 2, type 1 and reversal of diabetes. At least we should be able to fend off some questions from our patients after this discussion. Any questions from the audience at all about any of these topics or anything we want to ask the experts? Yes, that is very much ongoing topic area? With the MOSH and testosterone replacement. And the other way around also, with the higher BMI, the SHBG and low testosterone levels, whether there is any. So I think most of the guidelines, rather than just going by the numbers, they are saying that do it on a clinical basis. There are studies saying that there is definite improvement in the metabolic parameters with testosterone replacement.
Dr. Deeptata is here. Dr. Deeptata here. We had a very good discussion on this topic, testosterone replacement and the metabolic issues. So all of these studies, whatever has been done on this field, has shown one important thing. So if the patient is hypogonadal and you take care of all the other metabolic risk factors, testosterone in fact helps. But you give somebody testosterone and do not take care of the metabolic risk factors, it worsens. So it's like a soul.
Yeah. So yeah, you have to do everything together. But yeah, that's what the studies I think are biased in, that all the other factors are also taken care of. About it.
Thank you all the doctors. It was really a great discussion. And the next panel discussion was on endocrine disruptors, the silent killers. I would like to call Dr. Srinath A., panel member, onto the dais. Dr. Srinath was a senior endocrinologist at Cloud9 Hospitals, Bangalore, with over 28 years of experience. I would like to invite Dr. Satish S., senior consultant and head of endocrinology department at Aster RV Hospitals, Bangalore. Next, I call Dr. Babul Reddy, consultant endocrinologist at Elite Endocrinology and Diabetes Super Specialty Clinic, Hyderabad. Dr. Arun G., consultant endocrinologist at Idea Clinics, Hyderabad. I would like to introduce moderator, Professor Dr. Rakesh Sahay. Yes. So, Professor Dr. Rakesh Sahay He is a professor of endocrinology department at Osmania Medical College and Hospital, and also consultant endocrinologist at Sahes Endocrine and Diabetes Center, Hyderabad, and also president at RSSDI, DIPSI, and South Asian Federation of Endocrine Societies. So before we begin, a gentle reminder to all our speakers to kindly adhere to the allotted session time, as we have tight schedule. So we'll give short bell before ending up the session, 5 minutes before the session, and a long bell at the end of the session that would indicate the session time has ended. Thank you. Over to Doctor.
Thank you. Thank you, and a warm welcome to all the panelists of this session. So this is a session on endocrine disruptors. So basically, these are substances or chemicals which are being identified to have a significant impact. You know, we see a lot of prevalence of diabetes going up, the prevalence of all endocrine problems going up, and now we are realizing that a lot of these environmental chemicals have a significant impact on our health, and that's what we are going to discuss today. We'll catch up on the time. I will finish it. What time should we finish? Before 11:45 we were to finish. We'll finish by 11:50, I think. We'll catch up on that time. Yeah. So So basically, you know, they are present everywhere. Endocrine disruptors are ubiquitous, we can say. Wherever you look around, you'll find that, you know, right in front of your table you have so many endocrine disruptors. Sitting on the table right in front of you. I hope Dr. Sham is picking one of them and is going to drink water from the plastic bottle. That itself is that has endocrine disruptors. So, you know, you have everywhere you find endocrine disruptors, and we need to see how we need to, you know, how they impact our health. That is what we're going to, our panel is going to bring out those aspects, and then we are trying to see how we, do we have any solutions for this? That's something which is difficult to, you know, bring about a change, but I think we need to consciously make a change so that we can overcome the problems that are caused by these endocrine disruptors. So basically, if you look at what we are going to discuss in this next 30-40 minutes is that we are going to give you a brief idea of what these endocrine disruptors are, what do they do, and where they are. They are present everywhere, as I said, and we just show you how these are, you know, coming into our lives everywhere. And then we'll discuss a few organ-specific effects of these endocrine disruptors, how they are influencing various, you know, pituitary adrenal functions, how they are affecting male and female fertility, how they are causing metabolic disorders like diabetes and obesity. We have a panel on obesity also. We are going to show you how endocrine disruptors are going to cause obesity, and then also the effects on bone metabolism. So basically, if you look at endocrine disruptors, they are all, some of them may be natural, but many of them are man-made chemicals that interfere or mimic with the endocrine system. So either they can have agonistic effects on the receptors, or they can have antagonist effects. And according to the US Environmental Protection Agency, an EDC is an exogenous compound that may interfere with synthesis, secretion, transport, metabolism, receptor binding, or elimination of the endogenous hormones. So thereby, it brings about an alteration in the endocrine and homeostatic system. So it can affect at different levels. You can see that some of them could affect the synthesis of hormones, some of them could affect the transport of these hormones, or they could have receptor effects. And all these ultimately leads to endocrine dysfunction. So as we said, they can exhibit 3 different types of activities. Endocrine activity, they could have, deleterious endocrine mediated activity, and they can have a cause-effect relationship between the substance and endocrine activity should be shown to say that, okay, this is a EDC. So we should be able to, if you want to say that this is working as a EDC, then you need to prove this cause and effect relationship. So as we said, this is a simple illustration telling us that, you know, you have a normal hormone seen in green. You know, it comes to the cell surface, either binds to a cell surface receptor or binds to a nuclear receptor and brings about a action on the different tissues. Now, you could have these endocrine disruptors. We are saying that we are speaking about EDCs. They are something represented in the purple color, which is a mimic, hormone mimic. So it can bind to the receptor and sometimes cause a agonistic action, that is having a action like the hormone, or it could be a blocker also. Sometimes it could be blocking the hormone action. So either way, you have a disruption of the endocrine system. So this is what endocrine disruptors do. So let me invite our panelists to tell us, shed more light on this. We have Dr. Satish will tell us about the various ways in which our various endocrine disruptors that we see and how they cause a effect. We have some mics.
Good morning to everyone. On the outset, I would like to say thanks to Idea Clinics for giving an opportunity to sit in this panel, and I have one more session later on for organizers, everyone. Thank you very much. My topic at the moment is endocrine disruptors. In the first place, we can think about why these endocrine disruptors has become a very big event. We always, human beings, try our level best to make sure that we have something which is manufactured easily and which is durable. That is what it makes a difference. And easily and durable, it comes with some problems and pitfalls and all these things. For example, increasing the food security that led into the manufacture of various fertilizers and pesticides, and plastics, which is very durable, it runs for generations, and various cosmetics to look and increase the longevity and beauty of a human being. And like this, many things which we have been using containing endocrine disruptors. Types of endocrine disrupting chemicals, when you look at, it starts from natural thing, naturally available physical forms like light. We have changed ourselves into a sort of many things in the light itself. Artificial lights, blue lights, yellow lights, laser lights, all these things. We don't know exactly how that is impacting our health. But we have been having more and more of medical conditions, endocrine disruptors, all these things. And simultaneously, naturally, apart from light, it is the heat. And we are readjusting and reorganizing heat depending upon our requirement, our luxury. That also impact on our physiological conditions. We have never thought that what is the impact of those cosmetics and personal use of all these things. And finally, medical supplies. Medical supplies. When you look at into medical things as well, you have a lot of equipments and various medications, hormones, steroids, and and synthetic HRT manufacture. All these things contain preservatives as well as the chemicals as well. So these are all some brief information about classification. When you look at the sources of endocrine disrupting chemicals as such, as I told you, plastic industry, food industry, medical waste, household waste, all these things contain parabens used as preservatives, phenolics used as plasticizers and detergents, phthalates used as plasticizers as well as in cosmetics. And food preservatives and all, when you look at, they are all known and suspected endocrine disrupting chemicals. You have all these things are synthetic. Phthalates, bipheноls, all these things are synthetic material which are used in pesticides and all those things. Once again and again and again, you can see how many things are around us which contains endocrine disrupting agents or chemicals. And as Dr. Sahai was telling, endocrine disrupting agents have various impacts, and it can modulate or cause the mutation of chromosomes at the epigenetic levels, and it can cause congenital abnormalities in the fetus and various other physiological problems. And it can act as agonists in some of the receptors and antagonists in some of the receptors. And it can also impact the mitochondrial action in some of the cells. Like that, it can involve with a lot of other endocrine receptors. These are all the things I was explaining to you. And receptor antagonists, receptor expression, signal transduction, epigenetic alteration, hormone synthesis, hormone transport, hormone distribution or circulating hormone levels, hormone breakdown and clearance, proliferation, receptor ligand, and agonistic activity. Routes of exposure, once again, I was telling you, it can be in soil, it can be in water, it can be in our food products as preservatives, inhalation of gases, particles in the air, skin contact, biological transfer across the placenta, mother's milk. When you look at all these things, you can have, say for example, when you look at any system, for example, musculoskeletal system, and bones are biggest organ in the body, which has been influenced by many, many hormones. Say it thyroid, say it parathyroid, say it calcium, PTH, vitamin D, and growth hormone, estrogens, and all these things. When you have endocrine disruptors which affects all these agonistic and antagonistic effect, you don't know how it is affecting the bones and skeletal system. In the similar way, there are a lot of other aspects which can happen, and I think Dr. Arun is going to take over next.
Thank you, Dr. Satish, for highlighting the fact that these endocrine disruptors not only are causing hormonal actions, but they are also having epigenetic effects, and they are getting central transfer to the fetus can cause early life exposure to these endocrine disruptors, and that can be sort of quite detrimental. Let's move on to understanding. I'll ask Dr. Srinath to tell us something about what is happening, what are all the various sort of endocrine problems that we can expect from these endocrine disruptors. So basically, as we said that we could have effects on obesity, we said we could have increase in diabetes, we could have fertility, effects on fertility and all that, and also bone effects are also seen. So if you look at some of these influences, I would ask Dr. Srinath to take us through this and explain to us how these are actually affecting the reproductive functions, and also how we are seeing a huge burden of PCOS in women. How is that also related to these endocrine disruptors?
Thank you, sir. Sir, I can come there? Yeah, probably. Thank you. Good morning, everyone. At the outset, I'd like to thank the organizers for giving the opportunity to be in this panel. And I should thank Dr. Rakesh Sai for making our modulation very nice. They have given a perfect start. I think by now everybody will be thinking in your minds, what are we doing? Are we worried about our plastic bottles here, or women who are very keen on the washing machines or the other appliances, whether they are using proper fabric conditioners, should we use or not? What is it? The milk, this thing that we are using correctly? How do we advise on our pregnant patients? There are many things like we have thinking about. But our aim at today's this thing is to at least introduce a perfect introduction. That's the first slide. What Sir showed was fantastic. How they mimic and how it disrupts our hormones. So either we are talking about increase in the hormones, reduction in the hormones, or doing nothing in a luckiest of the manner. Can we avoid EDC in today's world? Answer is absolutely no. Can we minimize it? Definitely yes. The big thing for Dr. Sham and their team next time is whether they can bring water bottles here. That is to them to answer. So I think if you are talking about, let's concentrate. For me, EDC is very practical. Looking at the organs, what are the organs that the patients come today? So for example, today, the slides are there for us to have a look at it. Whether you are talking about the thyroid, people are asking in our clinics, why did I get thyroid, sir? Why did I get a nodule, or my daughter got a nodule? Why did she develop early? The answer is it that other than the autoimmunity or the inflammatory origin, is it something that the disruptors are doing it? The answer could be yes, it could be. The exposure goes into like that. And then we are talking about the reproductive organs. So, for example, we are seeing early precocious puberty coming much early into the scene. And also we are talking about the early telarche or early pubarche. These are the conditions which we are seeing. Is it all EDC? You might have to have your view about the EDCs into a broader aspect, not only looking at the pathogenesis, we know what it could be, we need to be looking at investigating and going in that pathway, but is it an answer is simple, how much exposure can it be reduced is another important question. And then now, if you're talking about the later effects, like we are seeing people having later sort of puberty, and also gonadal dysgenesis. These are the important things that we are seeing in the reproductive of women. Now, again, the same thing if you're looking at our children, how the question about the micropenis or some developmental problems or our later puberty, again, we are seeing very common. The obesity is there, the important about the lipomastia, what falsely many people talk about gynecomastia, actually it is not. Majority of them are having lipomastia. And if you see people doing the adolescent endocrinology, you will see if you just undo their shirts or their garments, you will see a lot of things. They already got an early bad stria or so. These are all the important slides we are seeing. So that means, has it got something beyond our hormonal? Is it also the cancers, the obesity? If you're talking about breast cancer, does it make an roads there? You're talking about testicular cancer, sir has given wonderful idea there. So if you look at it is all these EDCs are association between the testicular, because we know the mimics are, is it causing an increase in the testosterone or the estrogen? Like we know higher estrogen loads can cause the endometrial cancer or the breast cancer, or the higher into the testicles, they can cause the testicular or lady cancer. So this is the problem we are facing. Either it's high or low because they compete very much with our endocrine system. Next slide, sir. Thank you. Yes, so I think Dr. Satish has clearly showed us all the three important EDCs that we need to remember when we go home is at least the phthalates that we need to remember, and the polycarbons, phenols, and also the another one is the phenols. Phenols is another important, because majority of we are using the plastics and we are exposing ourselves to beverages and food containers which are covered with plastics, and microwaving too much in a plastic container. These are the things that we can avoid. Of course, we can't avoid the bottles. Maybe a limited exposure might also help. So whatever we talked about, it causes the inflammatory and the pathway, which is the pathogenesis for our hypothalamic, pituitary, or gonadal axis, or even the adrenal axis. We know that even adrenal, which is an important organ which we are seeing from the precocious puberty, or it could be the late, we are seeing the exposure into their system. So this is what we are talking about. Men having a low sperm count into their adulthood. These are the important things that this slide brings in. Again, if you see ovary, uterus or placenta, the end point is the development will be compromised, and we are also seeing small uterus in the initial stage, and a small dose of estrogen, we have seen an improvement in their uterine sort of volume, which we are talking about. So I had one patient who had, she was very young into her this thing. She came to a clinic with her dad. She had a very small uterus. A concern was there was no development of secondary sexual character. That was the dad brought. So she had, majority was the hierarchy she was worried about. So that didn't happen. So small dose of estrogens we gave, and she developed her secondary sexual characters. And interestingly, the uterus was very small volume. We were worried, and we did genetic testing. All was normal. There was slight elevation in the gonadotrophins, so genetic test proved nothing. And follow-up, we put a small estrogens to her. She developed her secondary sexual characters, and also the ovarian volume, the uterine volume improved. So is it that early exposure, is it mimicked by the EDC? Again, the answer, we have to question ourselves. So I spoke about the importance about the breast cancer, the endometrial cancer, or the testicle cancers. So we know they all actually interfere with the normal hormonal mechanism, and there they disrupt, and this is what they cause. High estrogens can cause breast cancers, and high into the endometrial as well. And here we are talking about the involvement into our steroid axis. They are causing unnecessary sort of early hypertension, or could be an early infertility or so. So I think thyroid gland, I'll leave it to Mike.
Thank you. We'll ask Dr. Arun to tell us a little about how these EDCs can affect the thyroid, because Dr. Srinath showed us how they have a significant impact on the genital development and on gonadal functions, and how we are seeing a increase in the problems related to EDCs. Now let's hear about the thyroid also, how they are influencing the thyroid.
Thank you, sir. As previously pointed out, the increased incidence of hypothyroidism could be attributed to the increased exposure to these endocrine disrupting chemicals. The most important mechanism how they cause it, basically these substances inhibit the sodium iodine importer. They are required to transport iodine from the blood to the thyroid cells. So because these cells are unable to produce thyroid hormone, it causes hypothyroidism. And these levels of EDCs are commonly seen in foods such as milk, vegetables, fruits, and also in fertilizers and airbags. Thiocyanate are also, which is commonly seen in cigarette smoking and in the cabbage, cauliflower, brassicas, family of vegetables, can also cause this effect. And even though the main mechanism is NIS inhibition, this EDCs can affect all levels of the HPT axis. In hypothalamus, they affect the regulation of the thyroid hormone transporter, and also the deiodinase, which is required for the feedback effect on the T4 synthesis. And as discussed previously, they also affect the sodium amide importer and the TPO antibody production. One more mechanism is basically these EDCs cause oxidative damage to thyroid gland cells, and this leads to increased development of antibodies. Also, they also have effect on the serum binding proteins, metabolism of thyroid hormones, and also transporters. Ultimately, all of them leads to if initially exposed early life, can lead to learning and cognitive deficit, IQ loss, and sensitivity. In fact, even PTCs, thyroid cancers, has been attributed to exposure to EDCs. Coming to,
would you like to add something about thyroid? Because a very common problem, as we see, many people come with thyroid dysfunction, and they want to know what is causing this. Is there any effect of environmental factors? What we can do about it?
Yes. As we have seen when we were in medical colleges and all, in the clinics and the teaching programs, we never used to see this much of thyroid dysfunction that has been happening in the society. And now, all of a sudden, in the past 1 decade, we see every patient comes with some sort of thyroid dysfunction. Either the TSH is elevated, and either TSH is suppressed. And when you look at the T4 and T3 levels also, of course, there are variability in testing methods and what we are getting in the labs. But still, we know that a number of patients coming with thyroid dysfunction in the recent years, they keep asking, what is the reason? What is the reason? And you have to go and start explaining EDCs. And otherwise, you are not going to get much of information. For that, it could be invisible or invisible radiations which is there in the environment, and it can be due to the chemicals what is present in our day-to-day food products and cosmetics and various hormones and medications which we use. Yes, of course, as Dr. Arun was telling, it interferes with every step of the thyroid manufacture, and also the TPO and thyroglobulin precipitation and suppression and all these things as well.
Next, coming to EDCs and metabolic effects. So basically, EDC exposure has been linked to development of obesity. The mechanism is basically these toxins, they activate the PPR gamma gene, which leads to increased development of adipocyte cells and also hypertrophy, causing obesity. They also act on the hypothalamus, causing increased appetite, low satiety, and also reduce the energy expenditure, causing obesity. They also lead to altered gut microbiota, which perpetuates this cycle of obesity. And other important mechanism is basically they cause inflammatory damage, causing release of reactive oxygen species, causing mitochondrial dysfunctions. In various glands, these can cause basically in the pancreas, low insulin release, the liver and the muscle to cause insulin resistance, ultimately leading to metabolic disorders like type 2 diabetes, obesity, NAFLD, and also cardiovascular disease. These effects are more prominent when the fetus is exposed to these compounds rather than later on in their life.
Srinath, would you like to add something to this? Would you like to say something about how much of the impact you're seeing in terms of metabolic problems?
Yeah. Yeah, thank you, sir. I think very well highlighted by Dr. Arun. I think overall, if you see what is today's world about obesity, there is something called obesinogens. And what that means is there are some EDCs which are disrupting your adrenal. I did mention during my talk that adrenaline being a lipophilic organ, so there is a lot of triggering factors, whether there is the interference from the renin, angiotensin, aldosterone into it, causing hypertension early, or even the obesity, like something cortisol, what diethylstilbestrol was discussed as well. So something of that which is causing the increase in your disruption between your adiposity level. So that means we are seeing the obesity coming at a very early level. Means I'm talking about the even pre-adolescent era. So that's why we are seeing nowadays most of the children, if you see, they are obese. Now, what do you do with them? Do you restrict them in calorie, or do you want to continue to give them higher? Is the biggest challenge for us. So there again the answer is that we may have to reduce the exposure and educate our the parental group to see how much exposure can be reduced, so that all this pathophysiology can be addressed. And when we were talking about diabetes also, we discussed, I think you clearly mentioned a wonderful slide there on the pancreas. Again, the inflammatory process which is actually affecting our pancreatic level, that means we are seeing early diabetes. We are seeing young patients coming to clinic with a hyperglycemia. They get admitted, they are non-ketotic, they are non-acidotic, they don't have antibodies, their C-peptides are normal. They are slowly going off the medications also. I do not have an answer how these people, these young cohorts coming with such a high hyperglycemia, within a matter of few weeks are coming. So again, the diabetes and the obesity, this is what is happening. So the answer is the adiposity level and the muscle level, there is sort of disruptions affecting from the EDC.
Yeah, I think the impact of this is not only in terms of affecting the individual, but also having the impacts through transgenerational effects also expected with because they are increasing the risk for gestational diabetes and various other problems during pregnancy, and this ultimately can actually have a significant transgenerational effect because of reprogramming of organ systems. Babul Reddy, would you like to tell us something about this?
Yeah. Good afternoon.
Speak about the effect on the bone also.
Yes. So, thank you. So, as already we have discussed till now, so effects of EDCs can be in every organ. So almost, and the effects can be seen from the kind of at the time of conception to you can see up to geriatric age. So we'll now look at this transgenic effects of this EDCs. So during pregnancy, it can affect, EDCs can affect through mother, or it can be effects on placenta or on the fetus. The mother, we can see like lot of GDMs now we are seeing. GDM can be expected and subclinical hypothyroidism can be expected. Then because of the disruption, it can be, there is preeclampsias too. And in the placenta, because of placental insufficiency and all, we can see the growth issues in the fetus. And in the fetus, we also can see the congenital anomalies and preterm births. And because we already know that EDs are very subtle substances, we don't know the effect. The subtle changes can be seen, but we may overlook them. And these issues can be transferred not just at the fetus level, then in the developmental stage, in the infancy, we can see like ADHD and autism. Then afterwards, in the adolescence period, we can see a hormonal imbalance. So these changes can be like throughout the phase of the life. So we can see from the at the level of fetus to the geriatric age. Then we also look at the effects of these endocrine disruptors on the bone. So we know that the bone, bone mass is actually affected by various interplay of different sites. So osteoclast and osteoblast. So here endocrine disruptor can affect this osteoblast and osteoclast. So thereby reduction the function of osteoblast. So bone mineralization will be affected, and by stimulating this osteoclastic activity, it increases bone resorption. So these effects can cause osteopenia to osteoporosis. So that's all. So
I think the panel has given you a very good idea about what is happening with these endocrine disruptors. And actually what we are saying is that, these are all problems that have been created by us. And this is having a significant impact on increasing the various problems that we are seeing around us. And I would like to ask each one of them to give their opinion on what could be the way forward. How do we go ahead, and what are the things that we can do? Because although there are a lot of issues involved, it can involve a lot of change in the environment. Cannot be done. All of it cannot be done by us. We need to have a collaborative effort. But what are the things what is the take home that you want to give to the audience? What they can do when they go back home today. What are the things that they can do to sort of reduce the impact of these endocrine disruptors?
Thank you very much, Dr. Sahai. At the end of the day, are we going to eliminate all these EDCs? No, I don't think. And as an individual person, are we going to make sure that these are all not manufactured in the first place? That is also not possible. And I think it is a multi-pronged approach that as individual doctors, how many of them know what are EDCs? When you talk about don't use plastic bottles, and probably they may say that you don't know anything. So as individuals, wherever we get an opportunity as doctors, we need to educate our patients, we need to educate ourselves and our family, make sure that we reduce these endocrine disruptors as much as possible. And wherever possible, as the Doctors Association and NGOs, they can approach the policy makers. They are the biggest people who can make a difference in this country, and make sure that industrial wastes are not entering into soil and water and other areas, and cosmetics are not regulated very well. And so that's how I think the policymakers and government can make a big difference. In the meantime, we doctors ourselves can do our small bit of things to reduce these EDCs in the society.
Dr. Arun, would you like to, or Dr. Srinath, could you tell us your thoughts on this? What should be the take-home message that we should?
I think Dr. Satish has highlighted very clearly. But my practical added message would be, especially for women, how many of you are using the non-stick pans? So that is an important area. We need to be thinking about challenging ourselves. Do we need to use that? Because you can minimize there. And also the plastic bottles, we are not telling we cannot avoid our plastic bottles, but reusing them or increase exposure to sunlight and having it for a longer duration, like 2 to 3 days, and having that is again we are increasing the risk. And people who are into fast life, like microwave ovens or using in a plastic container, again you need to challenge yourself: do I need to use this, or should I move to something else? And finally, the fabric conditioners which are used in the washing machines today, they are actually the highest sort of disruptors which has been quoted in some of the literature. So we need fabric conditioner is the other question. Other than that, majority of the plastics, we need to have our day-to-days. We have to have a luxury in our house. The fluorescent lights, I think Dr. Satish touched upon initially. These are all which we cannot actually avoid. But minimizing is probably the message.
So I think one final message from Arun and Babul Reddy before we close. And
individually, coming to food, basically choose organic foods, avoid canned foods, and whenever you want to store food, use stainless steel or ceramic containers. Don't reheat microwave using plastic containers. Obviously, don't use non-stick cookware. Use either ceramic coated or stainless steel pans. And chemicals, basically use when you use sunscreen, use mineral-based sunscreen like zinc oxide, titanium oxide, rather than chemical sunscreens. And any chemical you want to use paraben or phthalate. Usually I mention the ingredients. Most of us won't go through it. So specifically, we have to use this ingredients which don't contain parabens and phthalates.
Babul, ready for your final words? Yeah.
Number coded, which are EDC friendly and EDC badly. So numbers to remember are 1, 2, 4, 5 are supposed to be good, and remaining whatever follows the 3, which is the 6 and 7, they are supposed. If you see that on the plastic, that means it's warning bells for us. So the message is 1, 2, 4, 5. If you have a properly manufactured, you'll have these numbers. So remember them. That is another thought I will just highlight.
Thank you. Dr. Babul Reddy, your final words.
So only thing
before
is
we close and
leading our way like Lionel Death Dive. That is more important, I think. So where we don't use the cosmetics, and then we go for steel or stainless steel or glass bottles kind of thing. That usage is, I think, more prompt and important.
Thank you.
Otherwise, it is impossible to stop all the things.
Thank you. So I think the panel has given us wonderful ideas. Although this slide is showing that we are becoming endangered, we are also influencing, the EDCs are influencing the environment around us, and the animals around us are also influenced actually by that. Okay, with that I think we'll conclude. I think we had a good discussion on the various aspects of EDC and how we should consciously make an effort to reduce the exposure to these EDCs and reduce the impact of these on our health. Thank you.
Thank you so much, doctors. It's really interesting topic. Next panel discussion was on obesity unlocked. I would like to invite panel members onto the dais. Dr. Sunil Reddy is a consultant neuropsychiatrist at Idea Clinics and Chief Medical Officer for the Telangana State Government. Dr. Kiran Peddi, Senior Consultant Medical Gastroenterologist at Yashoda Hospital, Somachiguda. Anu Acharya, Founder and CEO of Map My Genome, India's first personal genomics and diagnostics company. Dr. Deepthi Thakkar, Consultant General Surgeon at FemCity Hospitals, Hyderabad. I would like to invite moderator of this panel, Dr. Lakshmi Lavanya Alapati, Director and Senior Consultant Endocrinologist at American Institute of Diabetes and Endocrinology, Hyderabad.
Thank you for introducing. Thank you. I would like to thank all of you to be here on such a beautiful conference where we all unite to discuss. I especially like Hall A today because of all the interesting panel discussions going on very hot topics or a common day-to-day topics. I think very practically planned by Dr. Shyam and Dr. Bhavani. Thank you so much for inviting me, my good friends. And I would like to thank all the sponsors who made it happen and all the associations, coming together. So it is a multi-specialty problem, obesity, unlocked. So it is quite a casual topic, I think. It's a very casual problem also. Do you all agree with me? Because we all gained weight in a very casual manner. That's because we take ourselves very casual. We become casual. That means we are not serious about it. We lose the attention to detail. We lose the mindfulness. And that is the reason obesity happens. And then we have to unlock the obesity, going more scientifically into it. We are going extempore on this session. I would like to welcome all my co-panelists, Dr. Sunil Reddy, who's a neuropsychiatrist at Idea Hospitals. I would also welcome Dr. Kiran Peddi, a good friend of mine and a colleague who was in the past at Global Hospital, now in Yashoda. He's a senior gastroenterologist who does a very, very good job with many of our patients in common. I know him personally also, and hence I'm able to say that. Dr. Anu Acharya, who has a lab of her own, a very unique, one-of-a-kind lab, Map My Genome, where she studies the genetics, epigenetics, and the genomic studies and lab results, which in fact tell us about ourselves, a very interesting methodology to interpret the genomic hidden secrets behind the obesity and predictors of obesity. So we will talk about that in detail. Also, I would like to welcome Dr. Deepthi Thakkar. She is from Live Life Hospitals. She's a renowned, a good team member of that very, very renowned group of bariatric surgeons. And the bariatric surgery can't be left behind in a panel discussion of obesity. So I would, myself being an endocrinologist, moderating is kind of too less. I mean, I'm not fit enough to moderate a session like this, which is a very, very multidisciplinary. But I would like to put my endocrine aspects of obesity into the discussion, and I would not rather stand here. I would rather sit with them and have a nice open discussion. It's a very casual discussion where audience are very much welcome to pose us questions, because we are not here to take a lecture on a topic from point A to point Z. We are here to discuss the points on obesity. Where are we falling behind? How should we wrap it up? How should we make it practical? When you talk about obesity, we want to rule out. Being an endocrinologist, I would like start my work on it, is to evaluate them properly, see what are the reasons for the obesity, find out the history of obesity. Where did it start? What triggered them? And how worse is it now? So what could it cause next? How can you reverse it? How can you cure it? How can you not do anything about it, but at least make their quality of life more reasonable, more practical, and much more dealable, I would say. Because obesity is a chronic disease. We all agree with that. It is a relapsing disease. We all agree with that. People do fail at it multiple times. They need help in multiple methods, and still they fail at it. Still they come back with obesity, because there must be a lot more hidden things that we don't know and we are unable to help in case of obesity. So being an endocrinologist, I would basically categorize it into two broad categories. Rule out the endocrine disorders from the exogenous causes of obesity. I generally take it into my first points are to rule out the endocrine disorders, which is mostly I would go to rule out Cushing's, rule out hypothyroidism, look for PCOD, look for something else, look for psychiatric problems, look for social issues, look for where did it happen from? And if it's a fixable problem, fix it. If you can't, 90% of the category comes into the non-fixable form, which is exogenous, which comes from the outside world. So it again becomes a very, very multifaceted problem, where it is both familial, behavioral, psychological, social, economic, and emotional, and incapabilities of a person to handle the intake versus the burnout of the calories. So it becomes a calorie imbalance. Bottom line, it becomes a calorie imbalance. So these people choose more calories and they're unable to burn all those calories. And that's why they become obese. From a normal weight, they go into the class 1 obesity, which is 25, onwards it is overweight. But after 30, it becomes obese. After 35, it becomes, serious obesity, where you would call morbid obesity. After 40, it is definitely morbid obesity. And there comes the other specialist in the field. So I would basically think that obesity is not just an endocrine disease, just like how they say 90% of the back pain is psychological. Only 10% of the back pain requires a spine surgeon or a neurologist. So similarly, I would say obesity, 90% of this is exogenous. Only 10% is endocrine. And the rest of the 90% we are here stuck dealing with it. So I would like to talk about my endocrine aspects of fixing them with both lifestyle and medications, and again surgery, and again asking other specialists to help me, psychiatric evaluation, psychological evaluation, the gastro aspects of therapeutics, again then the psychological aspects of helping me with the behavioral modification, cognitive behavioral therapy, again asking the genomic side of the testing to understand what else can we do to find out. So we'll start with basic testing. I would go to Anu Acharya, Dr. Anu. I would want to ask you, if I have a patient who is overweight now and very strong family history of obesity, and this patient could become, obese in the future, or obese already now, like BMI 30 with a pre-diabetic and, little bit hypertension going on with very strong family history, can I order some tests and find out their genome and find out about their epigenetic transformation capacity? And can I also find out about their basic response to these advanced treatments? Will my patient respond to the GLP-1 agonist? Will the patient respond to a bariatric surgery? Will the patient respond to some other medical gastro procedure for? So response to treatment also. So 3 aspects I want to know by ordering a genome test. Is it possible? Is it practical? Is it affordable? Is it available? So you need to give some background on the epigenome, all the genomic mapping. Yeah.
Thanks so much, Dr. Avani. There are many questions in that. So I'll try to make it as simple as possible in terms of how we, at least from a genomic lens, look at obesity. So I think we'll start with the basic thing, right? Your patient who was maybe 30-year-old or anything, you said there was a strong family history, right? So from a genetic point of view, there can be 2 types of obesity. You can have a rare form, which is the monogenic form, which is obviously much more, clearly dependent a lot more on genetics than not. But a larger portion of the people, I think a lot of us, including like for me, for instance, I think you can see that families have a genetic predisposition that is running, right? So you can see that a lot of them will be obese in general, right? So you can look at the genetic predisposition. So there are some genes, and I think the most famous one of them is easy to memorize, is the FTO gene, which is the fat, and so that's the one that will is one of the major ones. But there are many others also, right? So one is to be able to say, can I look at these genes, look at the predisposition to obesity, but also look at predisposition to other factors, right? There are many other comorbid factors, whether it is you're looking at things like diabetes, you're looking at hypertension, you're looking at some of the vitamins and the food and everything else. So you can look at variety of these things. So all of these can be easily done, and you can get a test which looks at the polygenic risk scoring and look at the recommendations that come with it. So this would be something like what we would do in a genome patri or a cardio map and so on. And these are very easy, these are saliva-based tests, can be ordered easily by anybody, and they are very affordable as well. So it's not a problem of affordability for any of these tests, and they give a lot of information. But as we discussed, and I think we've been seeing that there are many pieces to this puzzle. So genetics is one part that you cannot get out of, right? This is the lottery that you were born with, and you will die with that, right? So that's something that you just need to understand, because that's your constant in your equation of all these other pieces that are of the puzzle that are there. Then comes the second part, right? The second part is understanding all the different lifestyle changes that have changed the way your gut behaves, your oral microbiome behaves, and so on. So if you look at like a lot of things, we heard about the endocrine disruptors was one of the things that we heard in the previous session. But there's also things like, what are you eating? How are you exercising? We heard about like resistance training and a lot of other forms of exercise that were there. Those can cause a change in your gut microbiome, right? Which means that the kind of bacteria that you have and things like your short chain fatty acids, right? So you're looking at, we often hear about people saying, eat a fiber-rich diet, right? Why do you need a fiber-rich diet? Because when you have a fiber-rich diet, you have these bacteria that are creating these short chain fatty acids, right? So, and that is directly correlating with what you might see in an obese patient. So that would be one thing that you're looking at. But it's not just short chain fatty acids. There are a few other pieces, right? There are other things that can cause other bacteria that might correlate to inflammation and few other things. So you can order these tests to understand if, one, your firmicutes to a bacteroides ratio is off, which basically means that maybe you have some of the bad bacteria versus the good, and therefore you need to fix that, right? And the fix typically would be with lifestyle changes, but it could also be with things like fecal transplant, could be with probiotics and many other things, for instance. And then you have the dysbiosis in general, and I think that can cause variety of different problems, right? So you're looking at dysbiosis of your gut, you're looking at the ratio of the firmicutes to bacteroides, you're looking at short-chain fatty acids, and you're looking at a few other markers that can be linked to obesity. And then the third part, which is to be looking at what we call as the epigenetic marks, right? And what do we mean by epigenetics, right? So for instance, when you are born, like I said, your genetics is not changing. It is what it is. Your 3.2 billion base pair is there in every cell of your body, so you can't change that. But how your genes respond to lifestyle changes the expression of that gene, right? So epigenetics basically means on top of genetics, right? So you will have many ways of looking at epigenetics, but the ones that are the most common would be things like methylation that you would have heard, right? And what does methylation mean? So if you think about this room and you're looking at some of the lights that are there, you might see that the lights are there, but sometimes you might have a dimmer switch which turns it on or off, right? So you have light, slightly less light and slightly more light. So similarly, I think when you are doing exercise or you're eating the right things, that can cause a change in terms of how your genes are expressing, right? So the genes that I talked about, the FTO or MCR and so on, or many of these, or adipose markers and so on, all these, the expression of those might change. And that is an important piece. So that is one part, which is the methylation. But then there are other pieces to epigenetics, which is histone modifications and non-coding RNAs and many other things that I don't want to, technical details that maybe right now is not the best time to talk about. But I think all these tests are orderable, right? So you can first look at things that don't change, your genetic information, which could be about like your, looking at genome patri, looking at all your different markers that are there. The second could be looking at a gut microbiome or an oral microbiome and be able to understand what's going on currently. And then the third could be to look at an epigenetics marker to be able to understand whether there have been certain methylation marks and so on. And then what do you do about it, right? So I think it's not enough to know, which is the first point, but after you know, how do you talk to your doctor, how do you talk to a genetic counselor, and then actually do. And I think that's the part which is there. So all these tests are easily, they're all can be done at home. Nobody needs to go anywhere. And typically, for instance, when we are doing these are all, since you asked whether they are affordable, they are all typically priced between 7,000 to about 15,000 for the genetics and gut microbiome. Epigenetics is still expensive. That is still, because the science is also still developing. So I think those are the ones that are currently 40,000 and above. So I would say that they are affordable. I think, but where we lack today, I think, is do we have all the physicians who are actually the caregivers of society aware of these tools? I think that would be the part which will make the difference.
Does it, your genome patri, the genome analysis, does it talk about the gut microbiota that the patient is particularly having the problems with? And also, will that be counsel to the patient of how to improve the gut microbiota? Are gut microbiota that important that it will make a decision-making capacity for the patient's psychoanalysis, kind of what to choose, how much to choose, because the portion control, the food choices, and the timings of the food, all that matters for the patient to gain all that weight.
I think, one big researcher in diabetes told me, he said that diabetes is a disease of the brain, right? Because a lot of it is dependent on how we look at some of these factors, whether you are doing some of these lifestyle changes or not. I think you were asking me whether there's a the genome patri is looking at just the genetics, right? So those are things that are not changing. But we have other products like Map My Biome and others, which are where you're taking a little stool sample, and then you're understanding the, whether there is a gut dysbiosis, whether there is, what ratios of the firmicutes to bacteroids are there, and so on. So I think that's a separate test altogether. And you are basically looking at understanding of your what is going on in your gut, and typically that would be done with a test with a little bit of stool sample. There are now other ways of understanding things where you can do even an oral microbiome, right? Which could be just taking a saliva sample. So you could technically look at oral, like a saliva sample, and do both the test. But currently, I think the gut is a better indicator of what is going on. And I think the gut and the brain is very, very closely connected. And therefore, when we are talking about things, like obesity and others, I think we should also be looking at genetic markers for depression and a few others, and then see if they are correlated, and therefore counsel them accordingly. The other question, since you asked, is what happens to these people, right? Once you get a report, and it's a very extensive report, for instance, and you get information of, you have a high risk for something, or you have a dysbiosis, what happens then? So I think ideally, and I think this is where I said that it's important to have either a genetic counselor or a doctor explain to them what next, right? So what we do is typically we look at family history, we look at their current lifestyle, and we are also looking at what is their current nutrition. So a genetic counselor takes this information down, looks at their reports. So let's say somebody did a genome patri and did a gut microbiome and did an epigenetics. We first ask them, what is your goal, right? So if your goal is weight reduction, then we basically say, okay, if your goal is weight reduction, how do you do that? If your goal is getting better, fit better, even though many of them are connected, I think it's important to look at it from a customer's or the patient's point of view. And then we are telling them, okay, this is your family history, this is your current food. You want to be able to alter it based on what they are already eating, because you can't expect a complete habit change by saying that, if you're today eating idli and dosa and something else, you can't suddenly tell them to eat completely different, right? So I think it's important to understand what is it that they're currently doing and how do you build those habit changes in them slowly. So we do that once, and then we typically would tell them, talk to a nutritionist, talk to your doctor, talk to a functional medicine doctor, anybody, so that you can build this habit over a period of time, because it is not enough, like I said, not enough that you know, but it's important to actually act upon it.
So thank you, Anu. Dr. Anu, thank you so much. That was a great input. I think I would want to mention that when we see a patient with obesity, they tell me that I know what to eat. I know I have to eat healthier. I know I have to eat lesser. I know I have to eat at the right time, but I'm unable to do it. Because I know it, but I can't still follow the guidelines. There is somebody in me, like an enemy type of a person, a partner who's like the rowdy partner, who again tempts me, who tells me not to stop, go for the second gulab jamun, or go for the packet of chips in the middle of the night, or crave for that, that one sugary drink, or get some more hot rice and put some chutney in it and just eat the whole thing. So there is something in me that can't stop me. It's always nagging me. So there is something in me. So I want to release my stress. I want to be happy by taking some food. So I release my stress, my emotion, my pain, my sadness, my entire days, the negativity. I just get that relief from food. I know I should not do that, but I have this problem. So it becomes a brain problem now. It's not just an endocrinologist issue. So I would like Dr. Sunil Reddy to comment. Do you agree that there is more like a psychology issue here? It's a brain issue. I would say obesity, they come to me as an endocrinologist, but it's not my problem. It's the problem here. The problem is here, not in the hormones. Do you agree? And what is your idea about it? And what do you do? Where do you pitch in? And how can you help my patient with all these?
Great, madam. Thank you. I'm Dr. Sunil, psychiatrist. So it's particularly not a brain problem, it's a mind problem. So I want to treat that I want to treat your enemy, which makes you obese. Okay. So, as a psychiatrist role in obesity unlock, first I have to brief in 3 points. First, we have to assess the client. So, client means we have to, assess the, depression, whether he is going through anxiety or any mental illnesses. So, what happens with these mental illnesses? They may modify their lifestyle changes. So, they can't control eating. So, they may go to eating disorders, likewise anorexia, which reduces the weight, and at the same time, they may increase the eating. So, they may go to obesity. So, we have to assess first. And the next thing is, on assessment, if they are going through any kind of anxiety, spectrum disorders, or any mental health illnesses, we introduce drugs. Any drug in psychiatry, let it be antidepressant, antipsychotics, even mood stabilizers, may modify their metabolism and may lead to obesity. So we have to encourage them to modify lifestyle with my medication, which helps their mind changes. So every client asks me, how you change my mind? Is drug changes my mind, or you are going to change my mind? So when you, of late you introduced that GLP-1, so I searched about that, ma'am, like how it helps the patient to reduce the obesity. So it directly affects the psychology of the patient. It satisfies. Exactly. So it increases the satiety and reduces the appetite. That's what we are going to encourage people to do. So yeah, likewise my medications, my antidepressants increases their happy hormones, and they helps to reduce their modify their lifestyle activities. And the last part is follow-up. So as madam said, there is every chance of recurrence in obesity. We have to follow up the patient. So luckily they follow endocrinologist or bariatric surgeon for reduction of weight. But after every procedure and every medication, we won't go with the long term. So we reduce and we stop it. Then again the obesity starts. So to follow them, the simple techniques like assessment of weight, girdle weight, circumference, we follow with that things and simple things. And there is a cognitive behavioral for eating disorders and of course obesity reduction. So we do introduce those kind of therapy techniques. Yeah, these are my interventions.
Thank you so much, Dr. Sunil. I think you went over all the good 3 important points here. So I think the GLP-1 agonists, we are resorting to those because it first affects the hypothalamus area in reducing the appetite, in not having the stress eating, emotion eating, binge eating, craving eating, midnight eating, and emotional eating, boredom eating, because hypothalamus has that arcuate nucleus which loves food. There's a loving food aspect of it. And some people have a bit more expression of that. And GLP-1 first thing attacks on that hypothalamic arcuate nucleus. So GLP-1 agonists have been a boon for the patients who have a problem in this area. A natural food liking, a natural love for food, the foodie, the food lovers, the release on the food. Many of us are. I think 70% of human beings are natural food lovers. So I wish there was a molecule, there was a friend in me who would tell me, I don't like sweets. I can't handle sweets. I can't handle sweet drinks. That would be a great thing, isn't it? So GLP-1 does that. And that is why the GLP-1 agonists are going on being discovered. From the last 15 years, we have the latest one, the dual GIP and GLP agonist, Mounjaro. And the higher dosed GLP, the one of the latest studied as Wegovy, and the Mounjaro from Eli Lilly and Wegovy from Novo Nordisk have been in the inventions for the longest time, and now they have been out in the market and very, very helpful for the patient. But still, I think there is a role for many of us to intervene, because there's one more problem of, I eat a lot because food is available. and I eat all that because it's available and I love food. And when I eat, it digests very well. I don't have a GI problem. Let's say my stomach is big and I eat a lot and I digest a lot very efficiently. I digest it very efficiently. No gastroenterological problem is going on. I eat a whole lot of it. All that digests very well. And I'm again hungry in 4 hours. And I'm again eating a whole lot. And that is digesting very well. So the anabolism is going on. So I eat a lot of carbohydrates, protein, fiber, all that, very good food. And I'm digesting very well. All that is becoming fat and muscle. It's being stored and I'm becoming heavier. And I have a great gut health. And I'm just eating like pro. And I'm eating all 3 meals and 2 other snacks. Now, what would Dr. Kiran tell me about the therapeutic gastroenterological procedures or counseling, or what is the role of a gastroenterologist who you see a patient in front of you who's obese because he's eating very well, digesting well, and putting on all that weight? How can you stop it? And what are the complications of all this weight on the belly, the fatty liver or whatever? And how can you monitor the patient, and how can you somehow bring therapeutic changes in him? And if I'm using GLP-1 agonist to cut that hypothalamic pathway, then they end up again in your office with all those GI complications. So what would you do to the end care also? So wrap up the gastroenterological part of it, Dr. Kiran.
Thank you, Dr. Lavanya. Thanks for giving me this opportunity, entire IDEA team. So you're quite right. Previously, the olden concept used to be, if you have a healthy gut, I eat well and I become obese. That's actually, the concept is contrary. If you have unhealthy gut, you become obese. So what is the mechanism behind that? So as you rightly said, if you see the food, you eat. So there are 2 types of hunger. One is what we call homeostatic hunger, where the true hunger is. So if you're hungry, you're hungry. But the second type of hunger is, if you see food, you like to eat. That's called hedonic hunger. So if you look at the physiology of hunger, that's the main pathway which makes you, one, eat more, and that becomes obesity. But besides this, there is a bigger problem. So as Dr. Anu Acharya just told, the microbiome plays a greater role in obesity. That's a relation between gut and obesity. So how this idea came up, if you look at this interesting research, some of this evidence came from observing patients with inflammatory bowel disease, because I deal with a lot of inflammatory bowel disease patients. When these patients go for surgery, when the surgeon operates, when they do laparotomy, what they find is they find something called creeping fat. So the area of intestinal inflammation that attracts the fat which creeps into that area and seals it off. But if you just look at the 2 centimeters above the area of inflammation, there is no fat. So that's very interesting. Why this connection between the gut and the fat? So when the researchers analyzed, they explored the fat, they found that, interestingly, the microbiota which are supposed to live within the gut lumen, they found it in the fat. So why did it happen? There is something called gut translocation, bacterial translocation. The bacteria which is supposed to be sitting in the gut, which translocates after the inflammation, goes and attracts the fat to come and seal it off. So there is a very close connection between the gut bacteria and fat. That's led to a lot of other inventions and all. So coming to various diseases, what you mentioned about is the complication, what we normally look at in obese patients are mainly particularly the fatty liver disease, which is increasing in incidence in a bigger way. That's one thing. And the other conditions like cholelithiasis, gallbladder stones, and reflux disease. When the patient puts on weight, they predisposed to a lot of gastroesophageal reflux, and they lead to Barrett's esophagus. And a lot of malignancies are also associated with obesity. So what do we do in these patients? So we try to refer to, again, it's a multidisciplinary concept. We refer you endocrinologists, and we refer to psychiatrists sometimes to control the hedonic hunger and other things. And we do test nowadays, a lot of gastroenterologists testing microbiome as well. We try to modify that. And if you come to specific treatments where the gastroenterologist can be involved, it's mainly the endoscopic interventions nowadays. So we have things like intragastric balloon insertions, and we do have sometimes ESGs, what you call endoscopic sleeve gastroplasties. And then if not sufficient, we refer to bariatric surgeons. So we work closely with other specialties to diagnose and treat these conditions.
Thank you, Dr. Kiran. I think that was a very good input from you about the controversies of eating well, digesting well. There's also a problem in the gut, and you're in fact digesting, but there is a meiosis going on, and there's a dysregulation of the fat accumulation and all that. So with the GLP-1 agonists, the latest ones we have is semaglutide, the higher dose Wegovy versus the all doses of the GIP, the dual GLP-1 agonist Mounjaro. we are actually seeing a great weight loss. 16% with Wegovy and 25% with Monjaro, used at their maximum tolerated doses at the end of the study, which is about 1 to 2 years. 72-week trials have been out. And then because of that, I think many of our patients are sticking to us these days. It has become more of a unilateral treatment. But still, there is a room for surgery. And I would send my patients for surgery with a BMI more than 40 or BMI more than 35 with comorbid illnesses. And what is the role of a bariatric surgery in this era of GLP-1 agonism, where it is on the top, usable market available for the patients and doctors? What is your thought on that, Dr. Deepti?
Thank you, Dr. Lavanya, and thank you, Idea Clinics, for this opportunity. So, bariatric surgery, yes, with the advent of these newer drugs, probably is going to be more and more utilized beyond higher BMIs of 40, or with patients above 35 BMI and with severe comorbidities where they are unable to exercise, or they have uncontrolled diabetes, or they have uncontrolled hypertension or other cardiac issues. So that is where bariatric surgery is going to be there to stay. And then there are certain patients where we have also offered sometimes as a first choice medications, where there is some resistance to patients when we tell them that you have to take the drug for 2 years. So there are some who don't want to take a medication for 2 years. Another thing is, when we tell them that when you stop the medication, there is a chance of weight regain. So then there is some resistance to that as well. When they know that when they discontinue, they are worried as to how fast and how soon they will regain and how much they will regain. So these are certain concerns. We also use medications as an adjunct to bariatric surgery, where most commonly when we see patients who come after a few years with weight regain, so over 20-30% patients do come over the years with some weight regain, and then we use semaglutide we have been using as a first line, and now we are also starting to use tirzepatide. And sometimes, very rarely though, when they don't have adequate weight loss in the first place after bariatric surgery, so there we use these drugs as an adjunct. So bariatric surgery is, I feel that there is a lot of resistance among physicians, not endocrinologists, but physicians. For bariatric surgery, resistance has always been there, but they are also resistant to the medications, to prescribe them to initial early stage obesity. So I think a lot of education is needed in this regard so that that resistance goes away. Thank you.
Yes, absolutely. Thank you, Dr. Deepti. And what I think is, as I started saying, obesity is a casual disease. It's a casual disorder, which comes very casually, but the complications are deadly. And we can't treat them casually. We have to take each one of them with an individualized plan of treatment, plan of management, plan of follow-up, because it fails, it recurs. And it is a chronic thing, it's a lifelong thing. Patients who are truly obese, with BMI more than 40 or 35, they'll keep coming back to that number again and again and again. And we need to address them slowly and with a lot of compassion and empathy and time. It needs a lot of counseling. I think it needs a heart. It needs a heart. It needs, heartful, soulful treatment, and not just the scientific knowledge, but it is definitely a multidisciplinary approach. And I would, salute to all those teams of doctors who have had obesity clinics with all the specialties going on. A good dietitian, a good counselor, good nurses, good receptionist, in fact, because you pick up the case from the phone call, isn't it? So a good receptionist, good nurse, good dietitian, a good gastroenterologist, good psychological counselor, psychiatrist, the testing available for us, the surgeons who are available for us, the endocrinologist, the physician, that dietitian who's always there behind each one of us. The dietitian is missing actually today in this nice panel discussion. So, but I think this is, put together in a nutshell. It is a multidisciplinary approach, and we all have to put our hearts on it to take care of this deadly problem, to prevent the complications. More than, I would say 30% of Indian population is obese now with the BMI 30. At least let's weigh them, get the BMI calculated. Tell them that you're obese, even if they're here for you in your clinics to get examined for diabetes, for thyroid, for hypertension. At least make it a point to tell them you're obese, you're morbidly obese. At least categorize them. And then, they'll start thinking about it and they'll start coming back to you. So with that note, I'll end the talk. I don't want to keep the VIPs waiting here. And thank you, doctors, for joining us. It's a great pleasure. Thank you so much.
Thank you so much, Doctor, for the wonderful discussion. Next, we'll move to the inauguration and lamp lighting ceremony. Before that, I would like to call, as a guest of honor, Dr. Vinay K. Nandikuri onto the dais, Director of CSIR, CCMB, Hyderabad. It's our privilege to welcome Sri Patel Ramesh Reddy Garu, Chairman of Telangana State Tourism Development Corporation, as our special guest today. Appointed in March 2024, he has been spearheading tourism development across Telangana, upgrading infrastructure, promoting lesser-known heritage and ecotourism destinations, and enhancing visitor experiences with Harita hotels and modern transport services. His presence at international forums like ITB Berlin underscores his commitment to putting Telangana on the global tourism map. Under his leadership, the Tourism Corporation is rolling out a new 2025 to 30 tourism policy aimed at sustainable growth and community engagement. We are honored to have him today, supporting our vision of holistic health and well-being through tourism and community wellness. I would like to invite, as a guest of honor, Dr. Vinay K. Nandikuri on the dais, Director of CSIR, CCMB, Hyderabad, Dr. D. Srinivas Reddy, Director of CSIR, IICT, Hyderabad. Onto the dais, please. Professor Dr. C.H. Mohan Rao, onto the dais. Senior Professor Emeritus, Department of Biological Sciences, BITS Pilani, Hyderabad. Dr. K. Sudhir Reddy, Chief Orthopedic and Joint Replacement Surgeon at Landmark Hospitals, Hyderabad. Dr. Mohan T. Shenoy, Consultant Endocrinologist at Sri Gokulam Medical College and Research Foundation and GG Hospitals, Trivandrum, Kerala. Professor Dr. Rakesh Saha, sir, onto the dais. Dr. D. Srinivas Reddy, onto the dais, Director of CSIR, IICT, Hyderabad. I would like to invite Dr. Shyam Kalavalapalli onto the dais, founder of Idea Clinics. We'll just wait for a minute and then we'll move to the inauguration and lamp lighting ceremony. I request Dr. Shyam Kalavalapalli to have a few words. Dr. Vinay K. Nandikuri onto the dais, Director of CSIR, CCMB, Hyderabad.
Thank you all for coming. The purpose of today's meeting is to involve multidisciplinary approach. We have so many prominent personalities in the city. Right now in healthcare, most of our conferences are all doctor-centric. But for example, sir is from tourism, and we know medical tourism, remote care. We need to work together to see how much can we contribute in helping each other, because after all, healthcare in Western world, 90% of healthcare is driven by Indian doctors. The biggest doctor community in US and Europe are Indians. So I think it's time we understand the use of technology, artificial intelligence and all that, understand how much of remote care, medical tourism we can provide as doctor community. That is one purpose we want to discuss. Other than that, we have so many organizations, Srinivas Reddy sir from, all this, from BITS, so much of things that can be done together. So in that background, we thought we'll get all of you onto the stage. We have Sudhir Reddy, one of the entrepreneurs who runs hospitals, and Mohan Shenoy from Trivandrum, So what we are trying to understand is, how can we visionize a pan-India enterprise for healthcare? That is the concept we are trying to understand. Dr. Hemant will take through the panel once we have the inauguration. I think, are we ready for the lamp lighting? Yeah. I think, sir, meeru lamp lighting cheste, we'll start the panel after that.
Requesting Dr. Hemant Kaukuntla onto the dais, and please join the inauguration. Vice Chairman and Director of Cardiac Surgery, Century Super Speciality Hospitals, Banjara Hills, Hyderabad.
Is in the city. Right now in healthcare, most of our conferences are all doctor-centric. But for example, sir is from tourism.
Requesting Sri Patel Ramesh Reddy Garu to have a few words.
అందరికీ నమస్కారం. గుడ్ ఆఫ్టర్ టు ఆల్. సో ఈరోజు పార్క్ హోటల్లో ఐడియా క్లినిక్ సంబంధించి డయాబెటిక్స్ సంబంధించి ఈ సెమినార్లో పాల్గొంటున్న డాక్టర్లందరికీ, రీసెర్చర్స్ అందరికీ, స్టూడెంట్స్ అందరికీ కూడా నా హృదయపూర్వక నమస్కారాలు తెలియజేస్తూ, మరి చాలా కాలంగా ఈ ఐడియా క్లినిక్ సంబంధించి ముఖ్యంగా తెలంగాణ ప్రాంతంలో హైదరాబాదులో పెద్ద ఎత్తున ఈ డయాబెటిక్స్ సంబంధించి హాస్పిటల్ను రన్ చేస్తున్నారు. మరి ఈరోజు ముఖ్యంగా ఈ సెమినార్కి సంబంధించి ఇంకా కొత్త టెక్నాలజీస్ తోటి డయాబెటీస్ కంట్రోల్ చేసే దాంట్లో మరి రీసెర్చ్ చేయాలనే భావనతోటి ముందుకు వస్తున్నందుకు మరి వారికి ప్రత్యేకమైన ధన్యవాదాలు తెలియజేస్తూ, మరి ప్రభుత్వ పరంగా కూడా రేవంత్ రెడ్డి గారు ముఖ్యమంత్రి అయిన తర్వాత ఈ మెడికల్ టూరిజానికి సంబంధించి ముఖ్యంగా హైదరాబాదును మెడికల్ హబ్గా తయారు చేయాలని చెప్పి దాదాపు 30,000 ఎకరాలలో ఫ్యూచర్ సిటీ నిర్మాణానికి మరి తెలంగాణ గవర్నమెంట్ కూడా పూనుకోవడం జరిగింది. అందులో మెడికల్ హబ్ కోసం పెద్ద ఎత్తున ల్యాండ్ను కూడా ఇస్తూ మరి ఈరోజు ముఖ్యంగా ఆఫ్రికన్ కంట్రీస్ కానివ్వండి, పెద్ద ఎత్తున హైదరాబాద్కు వచ్చి ట్రీట్మెంట్ తీసుకునే పరిస్థితిని కూడా మనం అందరం కూడా చూస్తున్నాం. ఈరోజు తెలంగాణ టూరిజంలో మేజర్ పోర్షన్ మెడికల్ టూరిజం కూడా ఈరోజు పాత్ర పోషిస్తుంది. మరి అందులో మీరందరూ కూడా ముందుండాలని, ఈరోజు హైదరాబాదు ఒక మెడికల్ హబ్గా మారింది. భవిష్యత్తులో ఈరోజు కొత్త కొత్త టెక్నాలజీస్ వస్తున్నాయి. ముఖ్యంగా ఏఐ టెక్నాలజీ కానివ్వండి, ఇంకా కొత్త టెక్నాలజీస్ తోటి మరి దీనిని ముందుకు తీసుకెళ్లాలని, మీరందరూ కూడా కృషి చేయాలని, మరి ముఖ్యంగా మన దేశంలో చూసుకున్నట్టయితే ఎక్కువ మంది అంటే వాళ్ళ లైఫ్ స్టైలు మార్పుతోటి ఎక్కువ మంది మరి ఈరోజు ఈ డయాబెటిక్ బారిన పడుతున్న సంగతి కూడా మనందరికీ తెలుసు. కాబట్టి భవిష్యత్తులో ఇది ఒక పెద్ద డిసీజ్గా మారి మరి మనకు పెద్ద ప్రమాదం కూడా పొంచున్నది. కాబట్టి భవిష్యత్తులో తప్పకుండా దీని మీద రీసెర్చ్ చేసి ముందుకెళ్ళాలని, దానికి సంబంధించి టూరిజంగా మాకు కానివ్వండి, గవర్నమెంట్ నుంచి కూడా ఎలాంటి సహకారం కావాలన్నా వీఆర్ రెడీ టు గివ్ దట్ కోఆపరేషన్ ఫ్రమ్ గవర్నమెంట్ సైడ్. దెర్ ఈజ్ నో డౌట్ అబౌట్ ఇట్. సో నన్ను ఈరోజు ఇక్కడ పాల్గొనేలా చేసినందుకు ఐ వుడ్ లైక్ టు థ్యాంక్ వన్ అండ్ ఆల్. థ్యాంక్ యూ వెరీ మచ్.
Thank you, sir. We now have the honor of celebrating a truly inspiring journey. At just 20 years old, Jayesh Kumar Sinha has achieved complete remission from type 2 diabetes, a feat that takes immense discipline, courage, and strength. We would like to invite Jayesh and his parents to join us on the stage as we present him with Diabetes Warrior Award. Jayesh, please come on to the dais.
Let me tell you that he is a person with autism.
Yes. Jayesh further would like to share a few words. We'd love to hear from him.
So please bear, he is an autistic child. He's 20 years old. And let me share my, okay.
कॉलेज जाएंगे ठीक है कॉलेज जाएंगे ठीक है
So my name is Ashok Kumar Sinha. I'm here with my wife Rinku and Jayesh. Jayesh is a 20 years old with autism. So in December 2024, his HB1AC was more than average. In 3 months later, we again tested, it was very high. The blood sugar, even in the fasting or the post-food, was very, very high, even if I say that it is more than 450. So one of my physicians referred me Dr. K. Shyam, and we reached to the Idea Clinic on 10th of April. It was a wonderful experience. वहाँ पर जाके ऐसा लगा कि डॉक्टर को क्यों कहा जाता है भगवान का दूसरा रूप होता है. So, since my child is an autistic, it is very difficult to really accommodate, but quickly the Idea team realized and made us very comfortable. They have given a priority, required tests were conducted. Dr. Shyam has supported morally and also shared the treatment plan, considering a person with autism, what can be the challenges. I'm not going to detail about the technical things on the treatment plan. Later on, we also met Mr. Gautam. He coolly discussed what is our food habit in the home. And he customized the food plan, and that the journey started with Idea 360 Care. I tell you, when we were in the home, the biggest challenge is, as a patient, when the problems keep on coming, where to get a support. But to our great surprise, the Idea team were in contact with us on a regular basis, monitoring the sugar level remotely. We were sharing each and everything, the changes is happening. And in 5 days, the blood sugar came into the control. 10th April, we were the first day in the Idea Clinic, and for the last 3 months, the sugar level is within the range. We don't know what is the exact technical term, because for some time when we were here in the morning session, reversal or whatever, remission, so I don't know the technical things. But for Jayesh, it was a miracle. Though we are testing now very frequently, despite the fact doctor said, no worry, once in a week, if you test, perfect. But out of fear, even if you go 2 or 3 times, it is perfectly all right. His weight has reduced 6 kg, now it is stable, and that's the journey. So Dr. Shah, really it is our heartfelt regards to you, because it's not only treatment, but beyond the treatment, how doctor gives a moral support to the patients. For us, it is already said that God gives birth, जीवन देता है, but doctor protects the life. That's our experience. Thank you, Idea team, and please keep doing the good work. Thank you. Jay ji, please come.
Thank you so much, sir, for sharing your experience with Idea Clinics. We'll present a memento to Jayesh.
Please come. 10 more seconds. So, Honorable Chief Guest, so taking the advantage, I would like to mention here only one thing, if you can really help us, because a person with autism, I consider a person who cannot manage the funds, it is a totally disabled. Very simple definition. There can be a number of definitions. How you can really help support in getting the disability certificate, even can you organize a camp at the village level, panchayat level, because waiting is a greatest challenge. That would be the earnest request, if you can keep really, if you can help somewhere else. Thank you very much, sir. And thank you, IDEA team, for inviting and sharing our experience. Thank you.
Thank you once again. Next, we'll move to the most awaited and interesting panel discussion and this year's conference theme, Building for Bharat, India's Healthcare 2030, Can We Shift Focus from Treatment to Prevention? I would like to introduce panel moderator, Dr. Hemant Kaukuntla, Vice Chairman and Director of Cardiac Surgery, Century Super Speciality Hospitals. Special thanks to Sri Patel Ramesh Reddy Garu.
Good afternoon to all. And at the beginning, I would like to thank Dr. Shyam. Shyam is a good friend. I have known him for the last 20 years, and then I can see how he is developing his own idea in the form of idea clinics. For today's session, what I thought we will do is that I have about 2 or 3 slides to get the discussion started, because I think it is quite important going forwards how we can shift the focus from treatment to prevention. I think is important both for medical reasons, for ethical reasons, for moral reasons, and most importantly, for financial reasons as well. Prevention is far, far cheaper than treatment. Next slide, please. So how we wanted to plan today is I just wanted to ask individual panel members their opinion on how to prevent or how to create a platform or create an environment where prevention is as important as the treatments which we are doing. Next slide, please. So what are we at the moment in? We are in reactive, expensive, repairing and replacing organs is the time I call today. That is, I am a clinician. I'm a cardiac surgeon. In the morning, I go and then do bypass surgeries. But that is the end result. This is, I call this as an acute treatment. That is not what today's discussion is about. It is about how we can prevent a patient from coming to my operating table. That is the discussion. And at the same time, how to make it affordable. Because I will tell you, patients will come to the hospital and be willing to pay few lakh rupees for bypass surgery. But take their story back 10 years and tell them, get a 20,000 rupees test, they will not get it done. And that is the truth about today. And that is where we need to make some changes is what I think. Next slide, please. The other aspect is India is going to become a big economy, no doubt about that. But if you see the top 10 hospitals in the world, we don't come there yet. Our clinical load is huge. Our variety is huge. In the West, I have worked in the UK for 13 years. I can tell you 25% of the workforce in the UK is Indian doctors. I'm sure the same is the case for the US as well. So we don't have dearth of clinicians and specialists at the world level, but we don't have institutes at the world level. And I think that is another aspect which I wanted to raise. The next slide, please. And how do we integrate? How can we use integration of data, of information, of newer technologies, of preventive models across the country? So this is the reason why I think integration of the existing data, of the existing expertise is also equally important in, again, my first statement about preventing of diseases in our country today. Next slide, please. So from sick care to well-being care, and how can India shift from reactive treatment to proactive prevention? So with this, just the next 3 slides, sir. Next slide. So first question to the panel. How can India shift from hospital care to prevention? Again, mind you, this is a wide variety, and the Sham has done an excellent job in choosing people from different walks of life with very, very different backgrounds to answer the same question: how do we prevent diseases? So how can we use technology instead of hospitals to improve care? And then next slide, please. How can we cannot replace hospitals. That's not the point here. But while we focus on prevention, how can we make our hospitals into world-famous institutes? So this is a slightly a side question, but the main question still to the panel is, how do we improve our preventive strategies? I don't want that patient to come to my table at all. So, but I have to catch him 10 years earlier and then make sure that his blocks are kept at 10% or identified much early and treated so that he doesn't end up having a bypass surgery. So, next slide, please. Next slide, please. So what reforms and partnerships are needed to make prevention a reality? Next slide, please. And how do we integrate? There are so many players who are involved in providing health care, providing preventive care, providing medical care to the patient. So how do we integrate all these for finally the common man to benefit? Next slide, please. So that's my background to the panel. So I would request Dr. Vinay Nandukuri, sir, to first give an opinion about preventing and how you see from your angle, from a scientist's angle, how to prevent diseases itself.
Knowledge. We have to actually focus on knowledge generation. In the context of, if you are talking about diseases, some of them are actually lifestyle, but there are quite a lot of diseases for which there are bases, genetic basis. And wherever there is a genetic basis, such as an example would be sickle cell anemia, where there is a single mutation in your genome, and that single mutation, like somebody, father has single mutation, mother has single mutation, when ultimately when the marriage happens, and 1 in 4 chance that the child will have sickle cell anemia. So those kind of things can easily be identified well in advance. There are many other small mutations here and there which are known to make you disposable, are at risk for heart disease, at risk for breast cancer, at risk for many of the other things. So this particular knowledge is likely to be different for Western world from that of Indian people. So, but whatever most of the knowledge that we have at this point of time comes from whatever kind of, surveillance mechanisms or surveillance things that have been done in the West, not as much in India. So we should be looking at our population. we should be focusing on acquiring knowledge with respect to what conditions they have and what their genomes are, what their epigenomes are, which are modifications of the genomes, and maybe transcriptomes, and like basically generate a map where we actually integrate the conditions people have with their genetic material and how the genetic material eventually manifests in the context of expression of proteins and other things. If we can generate some kind of an atlas of this, that may help us actually in diagnosing people when they, well in advance. And also as the time progresses, we are going more and more towards what we call as personalized health. So I am different from you, though we may have very, very similar kind of things. The change, the differences is what we need to actually map to the knowledge that we already generate. And that in turn will actually help make better predictions. Doctors and researchers and will have to come together to kind of use this knowledge in a better way. Thank you.
Thank you. Thank you very much, sir. So excellent, well taken message, knowledge, and a genetic basis, a thought process like a true scientist. What is the reason for the problem to come? So once you start thinking about the reasons, the preventive strategies are automatic. Yeah. Thank you, sir. Can I request Professor Mohan Rao Garu to give your opinion about how to make prevention a common thing, an acceptable thing, and a regular affair?
Yeah. Prevention is better than the cure, that there is no doubt about that. About 5 years ago, 2017, Government of India declared a national health policy. The goal of the health policy, the stated goal of health policy, I have read out the stated health policy statement, is that the attainment of highest possible level of health and well-being for all at all ages through preventive and promotive healthcare orientation. The key word has been preventive. So in 2017, Government of India already announced the policy and is acting on it. But what we need now, at the moment, in respect of all other aspects, is that money. Now, same policy statement also said that we must be spending at least 2.5% of GDP for this expense, for this purpose. Today, our GDP expense on that is 1.9%. So definitely we are short spending on that. So that is one of the things. Now, what can we prevent? Okay? We can't prevent everything. So what can we prevent? There are 3 types of disease that can be prevented. Infectious disease, that we can prevent probably. To some extent, non-communicable diseases or lifestyle diseases. Genetic diseases, as just now Vinay mentioned. It is very difficult to really actually treat or cure or prevent a genetic disease. You are born with a defect. Okay? So it's a manufacturing defect. So there is very little one can do. But today, now technology is coming up for the last few years. Genetic editing technologies. Okay? We can now edit the gene. Editing gene in the test tube has been there for last 2-3 decades. People have been editing genes. But now there is a possibility of editing a gene inside the human being while the person is alive. It is possible in the plants and animals now. It is still not very comfortably usable at the Indian human level, but it can be used. So it means if we know exactly what gene is causing the problem, there may be methods available for correcting that by gene editing, what we call now the CRISPR-Cas9 technology, which won the Nobel Prize a couple of years ago. This is the possibility, but this is not prevention. This is still, as a matter of fact, real estate issue in the center, a health center, hospital-centric areas. To prevent infectious disease, first of all, provide safe drinking water.
Yes.
Simple thing, to provide safe drinking water. Can we provide safe drinking water? Again, government had a plan. Government says that water problem, there is Jal Jeevan Mission. Jal Jeevan Mission aims to provide potable water to every rural household through tap connection by 2024. So that might have been achieved, I don't know. then they have something called Amrit 2.0, then again they have better. So first thing is that if infectious disease to be treated, we must provide safe drinking water. Okay. Lifestyle diseases, okay. Again, one of the reasons for life disease is pollution. Okay. Now, can we control the pollution? And controlling the pollution is one aspect. Now, increasing the quality of food. We are eating very bad quality of food, all of us know. We are eating quality of it. Then school education. At the school education level, school children are not taught what's hygienic food, what they should do, how to prevent these infections. One of the schools I visited in Hyderabad some time back, they have dining hall, big dining hall. At the wash basin, in front of wash basin, they have put two big posters. One poster is EM picture of all microbes from your hand, before washing, after washing. Okay. Now that picture, the moment every time the person goes to wash hands, he will see how many microbes will be there, so he will be careful in washing hands. I think such a culture of knowing things, knowledge is again, and improving their viewpoints from the education level, school level, is another thing that I think we should do. And as a corporate social responsibility, all the big hospitals and other industries, big hospitals because, again, for the same statistic that I have seen here is that Indians spend about 47% of the total medical expenses is met out of the pocket. That amounts to something like 2.3% of the GDP. That amounts to something like 7 lakh crores. So Indians are spending 7 lakh crores out of their pocket for the medical treatment. Where this money is going? Not back to government. It's all going to private hospitals. So let private hospitals spend some money and put up some places, free places where one can go and test blood pressure, set the eyesight, and like lipid profiles, glucose profiles, let them be monitored at some free places from malls, wherever it is available. If you put them, people will be monitoring. If they monitor, there will be prevention possibility. So prevention is possible by only early detection. That you need to do that. What can we prevent? Again, as I mentioned, infectious disease and things like that. So India's health system is tilted towards curative, hospital-based care, neglecting the foundation of preventing. That's, I think, we try and do that. Okay. Of course, we need very good diagnostics. First of all, if diagnosis is not there, then it's not possible to solve anything. Now, where do we get the diagnostics? Research institutions. Okay. So we need diagnostics which do not require cold chain, because cold chain is a long process that it won't reach the villages. So then we should need a facility which any non-skilled person will also be able to use it. So considering all these things, several years ago, when I was at the director of CCMB, we started a paper microfluidic devices, which are very, very cheap and which can go for diagnostic purposes. That's one such activities can be done. We can use cell phones. Cell phones and digital technology is fantastically usable. As one of the point you said, how we can use technology. Cell phones are fantastic devices for everything, measuring blood pressure onwards. Now you can do blood pressure monitoring by very simple methods. Glucose monitoring can be done. Small devices can be attached to cell phones, and cell phone through internet can be connected to everybody. So that's one of the important thing that I think we should do. For diabetes particularly, because your interest is in diabetes, most important thing in diabetes, which I was wanting to, from mentioning about it for almost a decade now, is that we must have a non-invasive method of measuring glucose. Okay? Pricking is a difficult thing, and people don't want to prick, and they can't prick frequently. So non-invasive glucose detection method is required. There are systems available, ambulatory systems. You can fix on your arm. It will give you, whenever you want, a click on watch on your cell phone, you will get exact value. But that is very, very expensive. Several thousands of rupees for 15 days use only. That's not going to really solve the problem at all. But I saw there's another company in India, I don't know, name is some company in India, I forgot the name. They are making almost like oxygen sensors, okay? Clip on. You just clip onto your finger, it measures your glucose level and tells you your glucose level. Okay? If that really becomes popular and available, I think that's one of the way to prevent. Because if you know what's happening, you will be able to prevent. I think that's one of the things. And there are a few other points actually. Better thing that, just to conclude, let's say, we need more primary health centers, because primary health care centers should be there for preventing at the local, the initial first level. I know for certain that there are many primary health care centers in India which are not manned. There is no doctor. Doctor lives in a city. His appointment is at the village, but he lives in a city. Once in a while, he goes there and signs all the register. Okay, this is fact. This is not any. Now that has to change. We need to have all your medical doctors must go to villages and to your PHC centers. If you're asking me for what to do, this is the thing we should do. Okay, should go and work at the medical those centers, and we should try to decrease the pollution, and we have to improve the food quality, and do useful research so that very simple, non-complicated, non-destructive methods of diagnosis can be developed, use a lot of digital systems. In addition to this, of course, India needs to catch up on the first rate research. We are doing research, we are very good at research, but we are still a fringe player in the globe in terms of research. Okay? For example, diabetes, all of you are experts in diabetes. What is the problem in diabetes? Insulin is only one molecule. The glucose is remaining in the blood. It is not going inside the cell to provide energy. Cells need energy. Glucose has to go inside the cell to provide energy. It is not going in. Because it's not going in, blood glucose levels are increasing. Why is it not going in? The transporter is not functioning. Why transporter is not functioning? Insulin is not triggering it. Now, why do we have to stick with the insulin and transporting system alone? Can we repurpose other channels in the cell to push the glucose inside? Okay? Can we develop an alternate way of sending the glucose inside the cell? This is an open, basic question. So such basic questions can be addressed by scientific community, either in India or abroad, and we should be able to make breakthroughs in diabetic control. Whatever we have been doing is managing, but population of diabetes is increasing, so our work is not sufficient. So we need to have a breakthrough approaches. I think that will be possible. So scientific community will take care of this, but the medical community should go to villages and do what they want. And the money that you are earning should be given back to society by whatever the means is possible. If you do all these things, I think we'll be able to prevent quite a bit. Thank you.
Thank you very much, sir. I think you have nailed it quite well. I just wanted to say you spoke about money, and I think that is important. Money drives everything, and it is needed for prevention as well. You eloquently spoke about water, food quality, changing the cultures in the children, the CSR for basic rates. I think the government can come in and then say CSR, a part of it has to be towards health and prevention. Diagnostics which are cheap, like a true scientist, you have gone into the reason of the problem. And as scientists, I think you can find out cheaper and easier methodologies to go to the remote areas and then use technology. Thank you very much. Now, can I request Dr. Ramesh Reddy Garu to give your opinion?
Ramesh Reddy, he just left. This is Srinivas Reddy.
Sorry, Srinivas Reddy Garu,
okay,
sorry.
That's fine. Okay. First of all, let me thank you and let me thank and congratulate Idea Clinics for this initiative to making awareness and also connecting with all of us here. And just before my points, I think let me tell who we are. So we are coming from CSIR, not CSR. Don't get confused with CSR. CSR is Corporate Social Responsibility. Our organization is CSIR, Council of Scientific and Industrial Research. So I'm coming from IICT, one of the, we have 3 labs. One is IICT and my neighbors are CCMB. That is and other one we have NGRI. Okay, we both, particularly IICT, CCMB, we work on healthcare mainly, and we focus on more chemistry and chemical biology. Our colleagues will, CCMB focuses on mostly on biology sector. So basically, coming back to your question, how can we shift from hospital care to prevention? And Dr. Mohan Rao Garu mentioned big list of things. I'm sure some of them will overlap, but I don't want to get into that. These are all things most of us know about it. But just let me tell you a few things, if you look at India today, we call it as a pharma hub, right? So we supply medicines to almost 200 countries. And if you look at even today's statistics in US, 1 out of 3 tablets comes from India. Out of that, Hyderabad plays a major role. So we all should be proud about Hyderabad being like a pharma hub in India, and of course, Again, I don't have to tell about vaccines. Vaccines also a major contribution for us. So just to tell you what we did towards prevention, I think vaccines is one way to do it. In addition to all the lifestyle change and other things, I think vaccines is one way to go forward. And I'll tell you one example what we did recently where IICT contribution made. We all went through tough times of COVID. So most of us suffered a lot and we didn't have much medicines. And Bharat Biotech developed an indigenous vaccine called Covaxin. Right? Many of us took that Covaxin shot and we also supplied to other countries as well. So in that, each vaccine has different components. One of the component called TLR78 agonist molecule, one organic molecule, where IICT made that component and gave it to Bharat Biotech, few kilograms of that material, because it's only require micrograms in each vial. So we gave that, IICT in our institute gave that material to Bharat Biotech. Bharat Biotech used that material and supplied all vaccines. So this is some big contribution we made, and whoever in this audience, whoever took Covaxin shot today, so there is some component of our IICT or CSIR is there in your body. So that kind of contributions we are making. And I think way forward is I look at, again, in addition to what Dr. Mohan Rao Garu told, I think we all can work together, and more than that, I think making awareness people. I think lifestyle changes we need to do. I think lifestyle changes, if you can do, take care of our exercise and food habits, I think most of things can be prevented. I think, of course, if everything seriously followed and in a lighter note, we may not have jobs also. Even I don't have organizations, research organization, you may not have jobs like doctors. But on serious note, I think this is a very serious matter. I think more than like talking in audience like this, I think we need to educate people. And what Dr. Moharam mentioned about that in front of wash basin, some of those things we can do it. Even rural place also we can go there and we can make more awareness. And not only that, even political people also, if you can influence them to basically to inform in rural places, wherever they go in, if they can include in their speeches, I think that will motivate more. I think we should do as from corporates or from education institutions or research institutions like us. I think we'll take more questions. I think probably we can, I'll end here.
Thank you. Thank you, sir. Very well spoken about vaccines, working together, educating people, and engaging political forces. So now I request Sudhir, my good friend, to give his angle. Now, Sudhir he will start in the morning, and then by afternoon, he will finish 6 total knee replacements, and then he will do his other businesses, then he will run, and then he will have an evening for ideas generation. So I'm a great guy. So Sudhir, your thoughts.
Thank you, Hemant. So I think the first question, I think it's not very difficult. So I think everyone knows that good health is a great asset, not only for the individual, but for the society and for the country itself. So everyone should know that, and everyone knows. And they shouldn't confuse cure with good health. Cure is damaged body repair. So good health, there are 3 important prevention. There are 3 important players in it: the public themselves, the healthcare professionals, and the policymakers. Yes. And the least important among them are the healthcare professionals. As long as the people realize that their health is in their own hands, not in the hands of doctors or policymakers, it's easy to focus on prevention. My own practice, when I see 80% of the problems that I treat are preventable problems. They're all related to obesity and lifestyle. It's the same advice we keep giving them to again and again to reduce their BMI and to change their lifestyle. But you see generations after generations of them, they come, the grandparents to parents to children, they all suffer the same lifestyle problem. They all know exactly what caused them those problems. They are aware, but they don't implement. Somebody who is high BMI, they know the problems they have got because of the high BMI, but would they take care that their children do not get high BMI? Most of them no. We keep seeing them again and again. So there are 4 ways the diseases happen. One is genetic, and then your environmental, your lifestyle, and then disease agents. And you can prevent. Prevention can work all of them. On genetic also you can work. You can induce mutations over generations. Say I've been told, my parents, my grandparents, my father, my grandfather, they all had diabetes by the age of 30. They all had heart attacks by the age of 50. So I was determined not to have diabetes, not to have heart attack, heart diseases, and I don't. So you can prevent. You can work on environmental factors. You can work on the disease agents. You can detect early. You can vaccinate. You can work on lifestyle. So prevention, as long as you realize, it is easy. So it is in the hands of the public, and it's mainly in the hands of policymakers. So the policymakers can work at every level. They are the ones who can create environments. They can bring the changes to environment, to disease-modifying agents, safer water, vaccinations, and to lifestyle also. And I would disagree with your earlier statement. Money is not going to bring you good health. US per capita spent on health is $16,000, and their health index is not much better than ours. Europe spends 3 times less, 1/3 of that. Their health index is much higher than US. Israel spends 1/5 of what US spends per person, and their health index is far, far higher than these. And the happiness index is also correlates with health index. You take all these Scandinavian countries, where they spend less on healthcare, but the people are educated. They take health into their own hands, and their health indexes are far higher. Their happiness index is far higher. So I don't think money is going to make you healthy. It is your education. There are good examples. When I was a child, when I was a teenager, I used to see 50% of men used to smoke in my places. In any bus, you used to go anywhere, you stand, anywhere. And I think the education, the public, the government policy of creating awareness on smoking. No, I hardly see 5% of men smoking. Very less. So there are very, very good examples. Prevention of cancer. Campaigns by the government. So it's the individual who take responsibility and their health into their. Of cars are much higher than ours, but their countries make people walk. We walk much less than those people. So like that, government's policy is much more important. And we healthcare in prevention, our role is only to enable, maybe contribute to education. But it's the public that have to realize that and take their health into their own hands. And I think technology, I'm not really good. Sham is already doing it wonderfully, and Dr. Shanai will probably talk about it. And how can we make our hospitals into world famous? We don't need to. I think the more important is our healthcare is so non-uniform. We have some of the best hospitals in the world. We have some of the worst practices and also in the society. We need to standardize. We need to bring standardization into this. We don't need to be the best. We just need to be reasonable and good enough. And our hospitals are actually, I don't know who gives these ranks. Our hospital should be world famous. And some of our hospitals, I think, do world famous work and do far better than them. When I was in UK, an average orthoplasty surgeon does, in a year, a person who is labeled an orthoplasty surgeon in a year does about 100 to 150 total knee replacements. We have people here who do thousands in a year.
You do that in a month. I know that.
We do with a much lesser infection rate and at 1/10 the cost. Okay. So maybe we don't publish them that much. Maybe, we don't rank our own hospitals, but I think we have. And with the development, that ranking will come automatically. So more emphasis should be on the disparity on the level of care that is given, on the malpractices that are there. I think we need to educate more on that. Thank you.
Thank you very much. See, when I was talking about money, I was talking about money to be given to people, programs, projects, institutes, which talk about prevention. Not individual money. Not about prevention. So my point is, we get care. So that's the difference I was talking. But very well spoken, and I think you have put the point very clearly. Our health is our issue. If I cannot look after my health, why will the country or the neighbor or the teacher or the scientist look after? So I think that is a very important point. Public, healthcare, policymakers, these are all important. And as you correctly said, there are genetic factors, there are environmental factors, lifestyles and disease agents, and we have to address them ourselves. If I have a problem, I need to ensure that my child and my grandchild don't have them, as you said. So I think very well taken. And disparity, yes, it has to be addressed. And I think, as you rightly said, time and when we become a big economic power, everything else will come with it. So, last...
Hemant, can I make one complimentary comment from here?
Absolutely.
So, sorry. So, he made a beautiful, I think, observation and comment about smoking. Definitely, we all agree that that is actually because of policy makers and also a lot of publicity and putting on the boxes that injurious health and other things. I think that is one of the best example we can take that clue from there. Actually, one day my wife and me, we are talking about this to stop this diabetes and obesity. Can we think of basically banning all the sweet shops in India, or put some kind of labels there on the sweet shops or sweet packets and something we can think of doing something? Because seriously, we can think about that one. I mean, like basically making awareness that sweets are very bad. So that's one thing we can do. Higher tax or whatever that would.
See, the policy is coming. Yeah, so this is interesting. You see, that's why I think Shyam has chosen a different variety of people, because the prevention needs a variety of solutions. Yeah. Can I request Dr. Mohan Shenoy to give his thoughts on this?
I come from a medical background. I am a medical doctor. I mean, I don't practice surgery. So I am from the pediatric plus endocrinology background, and I am into the societies as executive committee member. So I, as a society member, as a task force person, I try to implement whatever communication gaps we face, because we are facing a lot of barriers in the community. So for this, I think we should all have our own individual website. So I would like to ask you, show of hand, because all of you are on the mobile or somebody in the back. So how many of you have your own personal website? Dr. Deep Datta sir has. I think very few will be having on the panel personal website. Everybody will have. But I think the first thing and foremost, I think as doctors, we should all have our own individual websites where we can show what we are doing for the society. That is one thing we can do as a doctor, because I think your government may not agree to that, but your public time, whatever you blog, whatever, but not the Facebook or social media I'm talking. Your own website where you can document what are you doing in your own way as a way to communicate with the public. That's one way. That will help technology to move away from hospitals. That is second, because nobody has taken that question, because the same question has been handled. So second question, I will take, it's a tough question. Moving away from hospital does not mean moving away from you. That means they are going towards health. And when they were seriously ill, they will come to you anyway. So you should not make them perpetually patients, because I think person living with diabetes is they call. We don't call it diabetic patient nowadays. It's a person living with, there's a lot of stigma with patients. We should work with them. I come from Kerala, where transgender health policy is there. We have got Zumba implemented in the school syllabus. We have got a lot of student-friendly initiatives being made. All the initiatives, the government is really doing it as a public-private partnership. Because as Kerala is having a good literacy level, we asked them, we have developed the rural health center into community health centers. And we have got family-based health policy. That is what we are trying from Kerala side. I'm in a private center. I work in a rural medical college. As a government person, I will go for government policies also, integration. So we all help each other to grow. So I think the old times, the textbook of Park, which we call, today we are sitting in Park Hotel, textbook of Park is community medicine. So we are all listening to community medicine today in this panel, public health policy. So I think we should all use technology from our mobile, use websites, create awareness through social media, integrate them into government policies, make our family policy also in there, and work-life balance, because finally, I think we are all running away to each place. We should have a family time, work time, and we should divide them very intelligently and smartly That will help us in the long way. Thank you very much.
Thank you. Thank you very much.
Hemant, I just want to cover one point which has not been covered at all. We all know that we all take antibiotics and it is supposed to actually help us cure infections. But we also misuse antibiotics in a big way. So that if we can stop the misuse, which is both an awareness issue as well as even doctors tend to prescribe them, over-prescribe them. And also it is used in other aspects such as animal health and various other aspects, right? So if we can actually look into implementing, a policy is already in place, implementing policies where antibiotics which are always prescribed are judiciously used, we will prevent one serious problem going forward, antibiotic resistance. And that is going to be, antibiotic resistance is going to be one of the biggest things. That's called AMR, antimicrobial resistance. It's going to be one of the big.
Age of 40, if they have even one risk factor, meaning high blood pressure or diabetes or high cholesterol, or they were or are smokers, and more importantly, if they have a family history. So if they have one of these 5 risk factors, whether they had any testing done or not, I actually do a completely opposite methodology. I actually get a CT coronary angiogram if it is not indicated, because that tells me about present problems and potential future issues also, so that I can prevent a heart attack. So that's what I do at my clinical level. But I agree with you, there are many steps before in which prevention can have a bigger role. So in few final thoughts, how to move from real estate, that is hospitals, to data and technology, saving organs and not just replacing them, and condition-based rather than specific-based care, condition-based. So somebody talks about sickle cell anemia, somebody talks about smoking, somebody talks about diabetes. So at a policy level, individually, each condition has a different methodology of prevention. So I think somebody at a bigger level will have to say, okay, this amount of money will go towards diabetic prevention, or this prevention for vaccine preparation. That might be one way forward. Healthcare at home. This has to happen. Health has to come to home. Only then the country will be able to afford the increasing costs of treatments. And who should own healthcare in our country? Again, it's a big discussion on its own, just like how a different panelists have different ideas about that same concept of prevention. Who should own healthcare? And I think this is a big debate. And insurance, why I said I wanted to put that is because I wanted to make sure we talk about insurance. Insurance gives money for treatments. But if insurance started giving money for prevention, I think more people will have an incentive, so to say. Okay, free mein aa raha hai test, so kara lenge. At least 100 people will get the test, 2 people will know that they are going to have a problem in the future. Maybe that is one methodology of prevention. Thank you very much once again, Shyam, and to all the panel members. It was an excellent and great discussion. Thank you. Any questions from the audience? There.
Let me ask you a question. Can I ask you a question?
Sir, please go ahead.
No, but this insurance, just to elaborate this one, insurance for prevention care means like most of the tests, I thought some tests are at least covered in insurance, right?
Yes, they are. But from a preventive nature.
No, preventive. Suppose I want to go and check it, my blood profile and other things.
Not all insurances give it. Some insurances give it. So what I'm saying is to incentivize, or the government should come with a policy that insurance sector should have at least this much of coverage. So it is in a way it will make them money. If they offer 10, 50, 100 people tests, 10 of them will become insurance patients also.
The insurance payment actually, if you pay the premium, maybe part of the premium is used for preventive tests.
Yeah.
Yes, sir. That's what some of the companies do it also, I think, but that can be made generalized, that everybody has a preventive assessment done. All those who are going for having insurance, they should have this preventive assessment done. And that takes care of the burden.
Absolutely.
Even now we have insurance for below poverty line. We have what is called as Arogyashri scheme. Maybe, some amount of expenditure should be earmarked for prevention in that. So that will actually make it better in terms of early identification and also promoting awareness about disease amongst the community.
I think much more than that, if you compare Americans and Europeans, they don't spend a penny on their care, medicines, for preventive health. The problems, now we are worried about the cost of the molecule, whatever it is. So preventive care, insurance should cover similar to what happens in Western world.
Absolutely.
See, Western world, nobody spends from their pocket.
Yeah.
Why should we spend from our pocket?
Agree. So it has to become a financial model. Prevention has to be a part of some financial models so that it is not burdening the end common man. But I still take what they have said. You still have to take priority. You have to take your own health into hand. Yeah. Thank you. Thank you very much again, once again.
Thank you for the wonderful session. Now we'll have a moment for felicitation. I request Dr. Rakesh Sahe, sir, Professor Dr. Rakesh Sahe onto the dais. Dr. Vinay K. Nandukuri. Dr. Shyam Kalavalapalli onto the dais. Dr. D. Srinivas Reddy. Professor Dr. C.H. Mohan Rao. Dr. K. Sudhir Reddy. Dr. Mohan T. Shenoy. Dr. Hemant Kaukuntla. So now we'll take a quick lunch break. Lunch is being served outside of the conference hall. We'll take a 15 minutes quick break and we'll be continuing with the sessions.
which we are providing to the patient to the last mile. Not we cannot reach everybody personally, but the technology perhaps can help us reach to a larger number of patients in a shorter period of time. And how if we can improve the decision making, because many times we are stuck up what to do, we go by our gut feeling. So can AI help us in taking care of that gut feeling to bring more objectivity to the clinical decision making? So I think why we need to AI, I think these are very basic slides just to show that a lot of research is happening on this. And if you see, AI takes a lot of energy, it's a lot of energy consumption. Hardware part, we don't realize, we just think of the software part of it. There's actually physical hardware involved in it. So, yeah, so I'll directly go to the questions instead of just boring with. The one key thing ma'am just told while having lunch was that AI is as good as the data we are using. So if you're using wrong data, useless data, the output will also be useless. It works on the same principle, the garbage in, garbage out principle. And a bit of AI is not just AI, a machine learning part is a part of it, and language learning model is how AI makes itself comfortable with us. We are comfortable interacting with language learning model and not using the 0 and 1 code. So yes, so over to you, Dr. Kiran. Yeah.
So, Anu, so you come from Genomics, you run a genome project, right? So what is your experience in predicting and preventing the lifestyle diseases like diabetes, obesity, and PCOS according to your project? And you can share your experience.
Sure. So we actually started with this about 12 years ago, where we started actually with exactly these things, right? So we said, how do we help predict diseases like diabetes, like heart diseases and obesity, and all of these pieces were there. And I think it took a long time for the medical community to understand that this can be useful. So I think in the beginning, more people thought that why should I know about it, right? Because you typically will classify a disease as like somebody as being diabetic after they reach a certain HbA1c, but the reality in the case of all diseases is you're getting there, right? You're not necessarily on and off switches. I think it's the same thing. So I think what you can do with genetics is to say, if you're looking at the wiring and you have 3.2 billion base pairs, we are basically saying that you can't be looking at those individual pieces. And that's where when you look at genomics and you look at how it can be, you can predict diabetes. And we actually published a paper in Nature not long ago on how do we predict these type 2 diabetes. So there basically if we looked at data that was there for both the cases and control, we saw that there was a 6 times as high a propensity for people with those variants to develop type 2 diabetes. And then we basically did that experiment even in our own database, and we found that that was true, right? So for instance, somebody like me who genetically is highly predisposed to diabetes, it's important to understand those risks from genomics. But I think as all of you as endocrinologists and others sitting over here know, that it's not just that one piece. That is your piece which is easy to understand because that doesn't change over your lifetime. But there are many other pieces, your microbiome, your epigenetics and others that will ultimately play a role in your overall, the disease actual
Prediction.
Prediction.
Yeah, excellently put. So you are going to predict the disease earlier and sending the patients to us a decade later. Okay, so Dr. Suresh, so how do you see AI guiding in a remote area, so where doctors may not reach to that places, very remote like villages? So how do you see AI helping in reaching that remote areas?
AI is the buzzword, but we'll forget that for a second. If you look at chronic disease, I'll give you maybe 2 + 2 examples. Let's say hypertension, diabetes. But there are also other types of chronic disease, infectious diseases which are also chronic. For instance, like leprosy, lymphatic filariasis. The difference is that it takes a long time versus acute conditions which are fairly short-acting. So if you kind of look at all these diseases, they take at least 10-15 years to develop. And perhaps like the management is lifelong. The challenge here to manage any kind of a disease is I should know what status this patient should be in. Yes. It looks like a very simple thing. But location plays a very critical part. And if the person is not in front of me, I need to so-called capture a slice of reality on the other side and then push it this side. Again, it looks very easy. But there are so many small challenges in this process. Now, let's say I take an image. Okay. Now, if I take a radiology image, it's standardized. Anywhere in the world, I take a similar image. So that's one of the reasons why you have a lot of US FDA approvals in AI for radiology.
Radiology, yes.
But if I take a regular image, there are millions of variations because people take, and that's the challenge that we actually have. I'll also quickly give an example where we are doing this remote service in perhaps like a taluk in Bihar, 500,000 people, where we screened everybody. Took around 20-30 images per person.
Like images in the sense? Like which part?
Head to toe.
Head to toe. Whole body image.
Yeah, whole body, not parts of it.
Okay, using X-ray or
Photos.
Photos, okay.
If you again remember third-year medicine, examine the body, identify the signs and symptoms, don't bother about the diagnosis. So that's what we are trying to do. 70% of signs and symptoms can be seen. Look, listen, and feel. These are the only 3 things. Look constitutes 70%. So we are looking at the person entirely, taking imaging. Sounds easy, okay? But this is where the challenges actually lie. Unless you standardize it, structure it, all the data that comes in is extremely unstructured. And this is where things become very challenging. Hypothetically, I can actually manage remotely if a person is sitting next to me or remotely because there are platforms for communication. But unless we structure the data and standardize them, operationally it becomes extremely challenging. And it all adds up to time and cost. So if I'm not able to do it at a particular time and then particular cost, then even if I'm able to do it, and if it costs 3 times more, it doesn't make much sense. Okay. So we are actually upskilling people in the field itself. And then we are providing them with service. And a lot of things are actually happening. So when you say remote care, it has to be delivered locally, supported remotely, but has to be standardized and structured. If you can do all those things, AI can be an enabling platform, but there are lots and lots of operational challenges that you actually need to address.
Yes, sir. Yeah, so nice point. So you have to streamline the data which you are getting from the remote areas. So that's a big task. So maybe you should have all the devices, like you cannot use multiple phones to get images. So maybe same pixel image, so that you can take and then.
I'll quickly expand on that. So it's not just the phone. When I say ask a person to take a photo of an eye, now I could take a photo from here or go very close and then you could only see half the eye. So we are actually developing AI algorithms which checks for lighting, checks for certain very high level features, checks for orientation, and then perhaps like checks if those features are actually present, and then comes the what we call another algorithm which identifies if it is normal, then not normal, types of not normality, grades of not normality.
That's a lot of work.
Yes.
Okay. So next question I would like to ask Dr. Hemchandran. So which healthcare tasks do you think robotics can automate today? And so what should stay with the human and what should be given to the robotics?
Yeah, if you see in the question which we can look into the robotics, because ultimately nowadays if you see that one technology now becomes interdisciplinary research into that. Like if you take the problem statement is in healthcare, but giving a solution using a technology perspective. But in that case also, if you see that when you talk about the robotics, the precision is very important. That's the reason they are incorporating the AI into it. Now, recently, like for the past 3 years, we've been working on one project called neck robotics. It's kind of a robotic for, especially for the medical procedure, we can use it, especially when a patient is affected with a brain tumor or any eye infection or something happen. Then if you want to use a medical procedure for that, medical equipment has been used for it to remove the infected tissue or the infected region from it. Where when you use the medical equipment, might be there will be some infection or side effects may occur. So to avoid those things, where we use dead spiders' legs as a grippers to remove the infected tissue from there. So we use robotics, AI and dead organisms, especially the spider legs as a grippers. So this helps them in more precision, and then the side effects and infections will completely reduce in that. So this was the project which we have been doing with University of St. Thomas, USA. But in India, the problem is we cannot be able to do the research on the dead spiders and those kind of things. That is the reason we have been collaborating with the US university, and then we have been focused on, and almost we filed the patent and we are done with this. So from this, what I want to know in this is like, human is the first person we have to validate, and all those things has to be done, even if you are implementing AI or any kind of thing in that. But ultimately, there should be every quarterly or yearly, the monitoring has to be done, the precision, how the accuracy, all those things has to be validated properly. Then only we can frequently use those kind of models. Any kind of thing can be used in healthcare. Yeah.
Okay. So thank you, sir. That was a balanced outlook you have given. So now coming to the next question, Professor Deva Priya, sir. So as you're from the drug discovery background, so I want you, so the simulation-based AI models which you are using from the drug discovery, so how you can apply it in predicting the endocrine and metabolic disease risks?
Yeah, so I think these are two different things, right? Maybe I'll start with the original question of your panel. Will actually AI and robotics replace doctors, right? On one hand, yes, it will. What it will, because every routine thing that we do in the hospital today, right? Everything will be replaced by AI and robots. That's the hope, at least, right? So basically, when you move, the routine things away from the doctors whose times are much more valuable than doing the simple things, right? That it will replace. Where it will remain, of course, one is the empathy part of it, right? So the human part of it, whatever machines and do or whatever the reports say. Nowadays, looking at the report and then saying, okay, this parameter is okay, this parameter is not okay, it's still
not so difficult. But then you still, if the doctor says that everything is okay or this is the issue, that makes a huge difference, right? Orders of magnitude. So that way, I think the AI and robotics is going to be a major factor, right? So what will differentiate, in terms of what differentiates doctors in the future is, doctors who adopt AI versus the ones who don't want to, right? It's not the question of AI replacing anything. Anyway, going back to your question, I think these are two different aspects. So one of the areas that I also work in collaboration with many industries, the AI algorithms applied to drug discovery, where we see that at least in the last 2 years, the number of drug candidates that go into clinical trials, right, that has increased by 60%, which is unprecedented, right? But still, there is no success story, right? I think that will be, we will have some success.
So maybe it may take some more time for.
Yes, I mean, clinical trials anyway takes
yes.
much longer,
Yes.
but in terms of the time it takes to get compounds or fail early, or that pipeline has become much more efficient, and then we see that many preclinical candidates now moving into clinical trials very fast. As I said, 60 to 70% increase in the number of such molecules. Right, so that way, of course, if you can see in terms of funding, in terms of the number of startups, so number of technology companies which are doing drug discovery now, including Google or Facebook and so on, right? So, that means that there is enough opportunity and enough, enough scope for making an improvement using these modern technologies.
Okay.
So, yeah.
Okay. So thank you, Professor. That's a nice, good insight. So coming to the next stage, so multiple articles were published. So
one question I'd just like to take as an extension of that last question, if the AI and robotics will take over. So what happens to the accountability part? As of now, if something goes wrong, God forbid, you can go and ask your doctor. When the AI is an association, it's an organization, it's a company, where does the accountability end up? Has this been thought over by the experts in the AI? The medico-legal part of it.
See, when we say AI taking over, or perhaps let's say AI doing robot surgery, it's usually not one single service. You need to look at it as, let's say, 100 microservices. Now, there are a lot of non-serious ones. For instance, let's say, automated machine just cleaning up. Now, is there any issue with that? No. In fact, it would actually make it more reliable also. Perhaps suturing after the surgery. If that's the only single part that a robot is doing, again, I think it brings in a lot more reliability and structure to it. Now, you need to look at each of these separately. And then you will see that certain parts, perhaps AI is actually good. It is better for AI to do because it's a monotonous job. And then there is a so-called decision-making part. Now, ideally speaking, if you look at the so-called principles of responsible AI, now, if you have all the input data without any kind of what we call gaps, then if you have one-to-one correlation, then human being or AI, it's pretty much going to be the same outcome. Now, the challenge comes when AI differs from a human being. That also happens. Now, if that's the case, who has the upper hand? As of now, human being. Now, there could be potentially, as you go into the future, if you are going to get data from hyperspectral imaging that human beings can't see, can't understand also, then are you going to take the decision? No, I can't take the decision because I don't understand. So I need to let AI to take the decision. So instead of asking a very singular question to say, is AI going to take over or AI going to do a surgery? You need to split it up into multiple. I'm an academic, so I need to have a structure for everything. So this is how I would try to approach an answer.
That's very beautifully summarized. I appreciate the input.
I just want to add a point to it. As a developer or the manufacturer of any kind of a AI model is going to be built or inbuilt in any of the robotics, where first of all we have to look into that AI transparency. What kind of model is used, what kind of data is used, and whether the data is validated by any of the experts like humans, like how your doctors has to be validated and those kind of things has to be done. And second thing is a proper framework has to be developed, especially like for example, in India we have DPDP. It's mainly for the data privacy concerns. Same like when you build kind of any AI model where we have a clean framework to implement those kind of things before starting or working towards it.
See, ultimately, I think it will come back to the doctor, right? Like, for instance, I think if you look at the Air India crash, yeah, people are still looking at the pilots, even though maybe that was not the case, right? So I think that if you are in the medical field and the person who is actually giving the advice, I think where AI can help is that the doctor who already knows a lot more than the average person looks at the data that's coming from AI and therefore makes a much more intelligent decision versus a consumer who went directly to, let's say, Gemini or ChatGPT or something and got some answer. And if they did it themselves, then they are to blame, obviously. But if they went to a doctor, then I think the accountability will always come back to the doctor or the hospital where they have gone, right? So I think we need to be very careful about where this whole thing is going, because I think it's a very important question. And ultimately, whether technology companies will take that liability, I don't think so, because they come with lots of disclaimers. So I think that's where one needs to be careful, especially on the advice front. On the technology front, on the robotics and all, I think it might be different. But I think when it comes to actual medical advice, you still are the last stop.
I just want to add one more point in this. Like, as she said, as doctors are the first person to validate it. Even if you're using AI, where the humans as the doctors has to validate it first, and then you have, if every frequently, as I said, that it has to be monitored properly, what kind of accuracy you're getting it, what kind of errors you've been presenting in that. So those kind of errors has been taken as a feedback and has to rework on it so that the model performs well in future. But as I suggest, even if it performs well in the future or two, the doctors as the first one to validate and take a better decision compared to AI.
So the key message coming from all the panelists is AI plus doctor. It is not AI versus doctors. AI is going to help us in small activities which can simplify, save time, bring more standardization. Where the decision making, the critical decision making comes, the doctors are more empowered to handle the AI data in a better way to help patient reach a more informed decision. So it is doctor plus AI, that is what's happening. So I think if you look at... Yes.
Although we think robot is doing the surgery, it's not actually. Robot is essentially an extension of a surgeon who is actually performing the surgery. And in a way, the robot helps to steady the surgeon's hand. And obviously, your fingers are like a centimeter across. And if you want to have something very minute, your robot can actually change. So here, although the perception is robot doing a surgery, it's a human being doing a surgery. So we are still very far where you are actually going to be seeing a bunch of robots around you, cleaning the patient and then scrubbing and then making the incision. No, it's very far. I mean, this is where we assume things are going to happen linearly, but it doesn't actually happen that way. So the perception and reality are two different things. We are not yet there where robots are going to kind of take over and then do things. Very far away.
So robotic surgery is an augmented surgeon with better vision, better precision, and more sharper hands.
Surgeon is fully in control.
Yes.
Yeah, I remember several years ago, right? Someone said, in 5 years from now, all pathologists will be out of job, and nobody will be driving. This is several years ago, maybe a decade ago or longer. We are like, 15 years later, pathologists still relevant and they are important, and we all drive. The same pathologist drives and comes.
Great way to take things forward. So I think if you talk of endocrinology point of view, I think type 1 diabetes, type 2 diabetes, if you see, they are highly variable disorders. Although it may appear to us that type 1 diabetes is like very simple. You just have insulins, only 4 or 5 types of insulins. And when we look at type 2 diabetes, it has so many medicines. There are at least 30, 40 different types of medications available in different doses And of course, you use insulin also in type 2 diabetes. Of course, the clinical decision making which a clinician makes at this point using the vast experience of medical school and actually seeing patients. Now, what's happening is that when AI can handle the large volume of data, every time we are using patient entering a data, we're using a printed prescription, you're using some platform or software base, and that is going to record your patient's data. So say over a period of time, you have to give patients of 10,000 patient data, and if the same software is used by thousands of doctors, that software is empowered to handle lakhs and lakhs of patient of data. And they, for example, can look at it, okay, after analyzing data of lakhs of patients of particular HbA1c, particular BMI, particular lipid parameters, particular blood pressure, and particular burden of end organ damage, what was the most predictable pattern of medications used, what were the OADs used, insulin. It sounds complex for a mind to handle, but for a computer it is very easy to handle. And I'm very sure in the next few years, at least in diabetes, you'll have very good predictive models to tell you which form of prescription pattern might suit that patient. So we are sitting in a clinic, again, as a clinician, if you're having that laptop in front of you, you might get pop-ups suggesting, okay, this might be the suitable pattern. Ultimately, the decision of the doctors, you're just having an additional input from the AI, which is not there. And same thing, I think, if you talk of type 1 diabetes, we tell our patients carb counting, but trust me, if you ask me to do a carb counting of the lunch which I had, I would fare pretty badly. And here is also one thing, we have a lot of apps coming in. If you take a picture of a plate of a food, based on that particular part of the world, it can very nicely tell us about, very accurately, the amount of carbs, amount of proteins and fats. And these are small ways, I think it can really help us in improving the glycemic control in both people living with type 1 diabetes and type 2 diabetes. So I'm not going into details of this. I think we should go on to the next. This slide just shows how, just to pictorially represent what are the calculations which the AI is doing at each step, at each point of time to select, looking at the data of hundreds and thousands of patients to decide, okay, should the second line be a sulfonylurea or maybe a DPP-4 inhibitor, or should it be an SGLT2 inhibitor after metformin? Looking at the prescription patterns, AI can give us good predictive models. I'm sure we'll have it very soon in the near future. A lot of hard work is happening in this. So this is what about the type 1 diabetes I was saying. So over to you for the round 3 questions.
Thank you, sir. So that's how type 2 diabetes and type 1 diabetes multiple protocols we consultants use for the patients. So based on these things, clinical decision support systems. So now I would like to ask Professor Deva Priyal, sir. So will we ever have AI system that suggests personalized treatment plans? So based on biology, behavior, their symptoms or labs. So how AI systems are going to suggest personalized treatment protocols?
That's a very, very relevant question, and possibly the fastest in terms of the AI and drugs, right? So a lot of work that is happening now is to understand the genomics or genomics and the drug response connection, especially in oncology, right? The patients do not respond the same way with respect to a given drug or combination of drugs and so on, right? So a lot of work that happens is to find out the relationship between the genomics, and maybe Anu can talk further on this, but that association, right? So once you have figured out the relationship between the genomics and basically what is personal to me and the drug responses, right? So it is in that sense the personal medicine becomes successful in terms of using the existing drugs, using the combinations or different combinations of existing drugs tailored to a given patient. I think, in some sense, it is happening right now, right? For example, doctors know this better. If you prescribe me some medicine, you give me a standard dose. Maybe if I'm getting admitted in a hospital, the dose is different. You calculate in a certain way, right? So now, in terms of, complex diseases where the understanding is less, in terms of the dose is not calculated just based on the age, metabolism, and weight, right? Maybe there are other personal factors, right? The AI is capable of doing this pattern recognition once you have this large amount of data, including multiomics data, including, all the other, the vitals or hospital data, and then based on that, you could actually not only modulate or tailor the dose, but also in terms of the combination of medicines, right? So
Yeah.
that's a very, very important area. Right?
Thank you, sir. So that's how AI system will analyze a large amount of data you got from genomics, metabolomics, and microbiome. So all these things can be analyzed, and personalized plans can be drawn from those things. Yes. So next, I would like to ask Dr. Suresh, sir. So can AI assistants become common in primary health centers? Why? Because you work in the remote areas, right? So AI agents in the primary health centers. So how are they going to act? Or support in the clinical region support systems?
I'll change the question a little bit. I'll possibly even push from PHCs, why don't we go to home itself?
Oh, nice.
Because these are all arbitrary boundlines that we actually draw. Once upon a time, your ultrasound machine was like, the size of a big whatever it is, and you have to go to a facility. Now, if you have a handheld device, you could do it in a PHC or perhaps at home. So these are arbitrary divisions. The challenge here always is, how much do I understand the patient? How long it takes for me to understand the patient? So if I compress time, I can do a lot of services. If I diagnose XYZ disease in half an hour, then it takes perhaps another half an hour to understand, and then another half an hour. But if I can screen XYZ disease, 10 of them in 5 minutes, then pretty much I can start treatment.
Yes.
So location and time always plays a critical role. It's not necessarily hospital as in tertiary, PHC or whatever. So going back to the project that I was actually talking about, when we started head-to-toe screening, we took about 2 to 3 hours. Usually that's how much it takes. When we moved to imaging, it took around 20 to 30 minutes. Now we are trying to, again, there are a lot of issues with regard to it. We are trying to address those issues and trying to reduce the time to around 3 to 5 minutes. Now, if you are able to screen a person head to toe, and then perhaps build some AI algorithms which can at least weed out all the normals, forget about identifying disease, all the absolute normals, and say, okay, these are the only areas you need to focus on, then you are actually looking at a much better way to perhaps even understand this person. I'm not talking about disease. Now, any person, whether he is diseased or not, and this is where we always say that prevention is better than cure, but there's actually no platform to practically implement prevention. Everybody potentially is at risk of any kind of a disease. If you are at, say, 40 years, you are at risk of something. If you are 15 years, you are at risk of something. If you are 4 years, you are at risk of something. And we all know what are the top 10 conditions. We all know that you are living in that location. We all basically know what is that you should do to prevent these conditions also. Except that all these things are not happening. It will all happen if there are half a dozen experts or a dozen experts looking at all those things, spending 2 or 3 days. But if all these things can happen in real time or in 5 minutes, then you actually are not dependent on being in a PHC or being in a home. Because I can't actually go to a person and sit there in his home for 2 to 3 hours. There are 5 people in every home. That itself will be 2 days approximately. So if I can actually screen an entire household of 5 people, 5 minutes, 10 minutes each, spend another 5 minutes, 10 minutes to tell this person what to do and what not to do, across maybe 10 or 15 common conditions, then I am actually, forget about treating, at least engaging in prevention in a much better way. All these things are possible. Hypothetically, yes. The biggest challenge is always in sourcing a clean data set. That is very, very challenging. Now, to take your example, yes, there are apps which you take a photo and tell what am I eating. They are not reliable. In fact, you just go around, there are 100 varieties of dosas advertised. The difference between a idli and a teaspoon of ghee on top is 100 calories versus 500 calories. Yes. India is notoriously diverse. And to say I'm going to adjust for everything, no. That's not going to happen. Even if you do it, you're not going to be clinically relevant. You'll be okay for paper publications, not clinically relevant. So these are the challenges that I need to address. To answer your question, I need to use a stereoscopic image to get volume. I need to have a spectral image that will go at least maybe 3 millimeter. It's still not going to go in. And even with all these things, I would possibly having a very bulky device, which will cost maybe 100 times more than imaging. and it's simply not worth it. Versus Western foods, go to a McDonald's, I can be reasonably 90% sure because it's advertised fairly with all this test. So this is where a simple thing of knowing what I eat, which is a very primary input, is extremely challenging. Understanding my ecosystem is even more challenging. So in our project, we are taking about 10 to 15 images of the house where you live. That is where you spend 50% of the time. So understanding your daily life looks very simple, but in most cases, they are the primary contributor of your disease. And to understand all those things, capture all that in data form, we assume that data is all there. It's not. A lot of data that we are simply not at all capturing, we don't even know how to capture. If you are able to do, or perhaps like even make some kind of an advance in that area, then we could possibly use AI to kind of understand fairly quickly. Whatever, if you have a clear data set, what happens afterwards is fairly straightforward. But the sourcing part is extremely challenging. Sourcing or understanding your lifestyle looks very easy, extremely challenging. If you're able to address these issues, yes, I think location does not actually make any kind of a difference. You are there in an Arctic pole, you are there in Andamans, you are there anywhere, you are there in a hospital. That's fairly easy, but understanding is extremely difficult.
Yes, sir. Thank you for stressing the scope of AI agents, both in getting the information and treating at the individual home level, so rather than at the PHC centers. So next, I would like to ask Anu, so can AI help us move from yearly checkups on, from preventive alerts, giving preventive alerts for each person based on the genomic data or based on the AI's personalized approach?
So absolutely, I think you can, right? And I think when we were just hearing about how we can move it to the home, right? Yes. Is this better? This is better. Yeah. So when we are talking about how we can move information to a consumer, for instance, I'll give an example from there. Then you can get data that is coming. So the easiest ones are like your genomic data. You have, let's say, microbiome data, epigenetics, all that is generated, you have the data. Second is you get diagnostic tests, you have sensor data, your CGM, your ring data, you have your information that's coming. If you add to that layer, for instance, also things like social media data, data that is private to you, but you have the ability to, for instance, connect that. I think that becomes an extremely powerful data set, right? But simpler one is, for instance, what we have done, where we said, can we connect the data that is coming from genomics and your blood biomarkers and others to be able to come up with some sort of a risk prediction, overall risk prediction, because you are looking at static data, which is your genetics, and you're looking at variable data that could be your microbiome, epigenome, your blood biomarkers and all that. So there we've used AI to sort of connect the dots, right? So we call that G-biome. And once we do that, then it's very easy to be able to say, personalize that and say, for this individual, do you need to do this more regularly? Or for instance, I take an example of, let's say, getting a gut microbiome. It might be very different for a 18-year-old healthy individual to, let's say, a 50-year-old person who has IBS and things like that, right? But if you combine all these data points, then I think it becomes much easier to be able to say, can I put all these pieces of information in an app and remind these individuals? But notification is not going to be enough because you will still need somebody to drive them, right? Yes. And that's what I think technology has a limitation that, one, it can do a lot of stuff, but the person themselves have to act and their coaches need to act.
So maybe I think overall cost perspective also, one may think, so you can reduce the cost perspectives also. Exactly. If the patient, he individually comes and he asks for only 1 or 2 tests rather than going for complete whole body checkup.
You don't need to do whole, like you don't need for everybody to do everything, right? You need to focus on what is important for that individual then.
Thank you, Anu. So next, Dr. Hemchandran, sir, how far are we from a fully autonomous robotic clinic to a routine care? So are we prepared for that?
Yeah, if you see that in most of the countries, they already implemented these things, especially in US, in Mayo Clinic and all, they have been implemented. But ultimately, the precision which we want to look into is like, all are not completely fully automated, all are semi-automatic. They have been using it for, especially for surgical things, it's been done. So in that perspective, like as I said earlier, where frequently monitoring and precision and the accuracy of their robot has to be measured properly. If it is like a manual work, like kind of, how I can say that, based on the user input, how it's going to work. If the data is going to be automated, then we have to, every quarterly we have to monitor and we have to measure the accuracy and all those things. If the data is like as it is, we know that this is what the data going to come inside the model and the accuracy is going to be in this way, then no need to think much on this. So these are the things which we have to look into it. Frequently we have to validate it, and the humans has to first to validate and all those things.
Yeah, thank you, doctor, for your nice inputs. So that's how we have come to end of the panel discussion. So thank you everyone for participating in this good discussion.
Yes. Can take your questions from the house. Any questions from the house you have? Anybody would like to ask any question to the experts here?
As far as importance of AI in primary health centers, the primary health centers are not well equipped. Even if you provide AI with the clinic or to the doctor, the patient coming to the primary health centers are common cold, URTI, mild traumas. Doctors are not trained. How many doctors are attending CMEs to update their knowledge? Yes, AI is useful to those doctors who are updating their knowledge and those who are working at district headquarters and the places like in metros, big cities. In primary health center, how it is going to help them out? 99 out of, suppose a primary health center doctor is treating 20-30 patients. Out of 30 patients, 90% patients are common cold. Believe me, trust me. 20% cases are minor traumas. Some minor, some sebies or some pediculosis or this and dandruff and all that.
Thank you, sir. I think we appreciate that.
So, AI will help those doctors who are working at higher centers, one. Number two, those who are updating their knowledge, those who are keeping their themselves with the space in the medicine. And after all, even though it is going to solve the clinical problems, the healing touch of doctor cannot be replaced with AI. That is very, very important. Thank you.
Thank you, sir. So I think it's key message coming that we should also be updating ourselves. So it's always the message is going, it's AI plus doctor. It is not AI versus doctor. That's the key message coming. And wherever we are, we can use technology to update, not only sitting in a metro, but in a village or in a tier 2 or 3 city also. Very thank you to all the panelists. Thank you so much.
Thank you, Doctor, for the wonderful discussion. Next, we'll have a discussion on medical education and entrepreneurship. I would like to invite panel members, Professor Dr. K. Manohar onto the dais, Dean of Apollo Institute of Medical Sciences and Research, Hyderabad, senior physician, academician, and healthcare administrator with over 40 plus years of experience. Professor Dr. I. Shyam Sundar Raju, senior general physician with 27 plus years of experience, consultant at Chennai Hospital, Secunderabad. Dr. Sai Prasad, specialist in internal medicine, nephrology, and general medicine, currently practices at Mount Sinai Hospital Medical Center, Chicago. Dr. Harish Gautam Medapati, consultant surgical gastroenterologist at KIMS, Secunderabad. Next, I would like to introduce moderator Dr. Murali Bharadwaj onto the dais, fractional CTO, tech architect, known as the startup godfather, for tech founders who need speed, clarity, and scale. Scale to 2 million plus users. Over to you, Doctor.
It's a great honor today to be in the midst of the teacher who taught me how to examine the cranial nerves, how to take the history, Dr. Manohar sir. And a senior in my med school who held my hand and filled my soul with the right advice, right from how to fall in love with a girl. Dr. Sham, please give a good applause. At the same time, I'm honored to be with the students who took coaching with me for the PG medical entrance among 3 lakh students and became toppers, a nephrologist, Dr. Sai and Dr. Harish. So, and also the August gathering of endocrinologists were here. So, let me start the reality. The reality today is the practice of medicine is the practice of business of healthcare. We have to agree that as doctors, we are not trained about return on investment, long-term value. We are not taught about patient as a customer, consumer, where we are vulnerable to the legal liabilities. And also, how do we need to be an Instagram influencer to sell ourselves that we are the best, and if we touch, the diabetes goes away. So the one who makes all the drama is today a top practitioner. We have to accept the fact that we are no more the so-called the soft, ethically tuned doctors who are like Dalai Lama, very saintful. We are now malignantly marketing ourselves to become that. But are our medical schools preparing the students for the marketing, recruitment, operations, venture capital, fundraising, etc., etc.? Let us examine in this session. So, to start with, I like to ask all of you, what is the biggest lie we tell to the medical students about success? I like to start with Manohar sir.
Thank you, Dr. Murli. At the outset, I would like to thank Dr. Sham, who remembered me after 40 years. We lost in touch from KMC. Thank you, Sham, for giving this opportunity. Now, when you talk about the medical education and the entrepreneurship, the first question, what lie we were doing all these days? I will answer in a different way. So in the next round, maybe in continuation that. The lie, what we answer like, what is the success? Now always when a student joins in medical college, we try to make them a good student, later a good doctor, who is supposed to be good in the subject as well as ethics, and he has to do his job later. But what is the bottom line we were telling? It is a linear thing. So you get gold medal, you get distinctions, and one day you will be success. In terms of now present scenario, that is a lie. So most of the distinction holders of those students, they were not doing well later.
Those are mediocre students, they did well. So where is the flaw? So this, in the first round, I'll answer that question.
Thank you for the good words. I don't know whether it's a compliment or you're pulling my leg, I don't know. It was not a lie I was teaching my students. It was the truth in the beginning. Long back, maybe 1-2 decades back, when I was assistant professor, I used to teach my students, whether you succeed economically or not, you maybe not be successful in earning money, but you will definitely will have a professional satisfaction by choosing medicine. Or you'll be definitely happy, you will get respect. That was my words to my students, even though you don't become rich. But when I was a young practitioner, when I used to go to my clinic, old people, the elderly people, they used to wish me just by bending, but younger people used to get up. But now when I go to my clinic, all elderly people, they stand up, but the younger people say that, "Hi doc, how are you?" So maybe nowadays the profession may be not getting you money and also the respect. We are not as respected as in previous days. But still, the professional satisfaction, I think it depends upon the person who takes it. It may be lie that this profession will give you professional satisfaction and the respect.
First of all, I would like to thank Shyam sir and also Dr. Murli sir. So let me start off with the answer. So we've been taught and we even associate academic excellence with success. And we spend most of our quality time, work hard, get good grades and achieve. Learn how to be a team player. So these are some important qualities that you need to learn so that you will be successful wherever you go after your med school.
First of all, I would like to thank Murli sir for inviting me here. I think I'll be going in a non-classical, non-traditional way to answer this question. I think everyone would have heard this thing, you cross this phase, life is beautiful. You just finish your 11th and 12th, then it's going to be very smooth. You just have to clear that. Then when you are in MBBS, you just have to clear the NEET, get a post-graduation seat, then you're happy. In post-graduation, there's another NEET came, that's super specialty. So during all this process of at least 10 to 12 years of your medical education, you would have forgotten about your sports, which are very good in your school. You would have forgotten about the cultural activities, all the extracurricular activities. But then, once you cross all these phases, you realize your non-medical counterparts are like, they would have enjoyed all these parts of the life during this phase. And then when you want to go back and start those things which you have missed all these years, the train is already gone and now you have to start clinical practice. You have to run for the patients and cases. The biggest lie I feel is life is going to be tough in all the phases. And you have to be prepared and don't leave any chance you get to enjoy or live the life. Thank you.
I think one of the biggest lies that we tell to medical students is we diagnose murmurs with stethoscope. We don't. We discover pneumonia with stethoscope. We don't. We wear apron to be called as doctors. No, we are not wearing aprons anymore. And we also tell the lies that after MBBS, at least somebody will give us a girl to marry, considering our degree. That's the biggest lie. Because if there is no MBBS degree, easy to get married by a prospective father-in-law. Because after MBBS, you are just MBBS. After MD, you are just MD. And we think that all problems are over by doing MD. No, sir. It is the RMP Sinu and PMP Raju who are also giving prednisolone and dexamethasone outside, even for Braxton Hicks contractions also. So that's the reason, that is the biggest lies, in my opinion. But anyway, thank you. And I'd like to ask Manohar sir, why so many brilliant medical students feel like they're failures? Because if you ask a first-year student, topper in NEET exam, he will tell, what do you want to do? He will say that, I want to be the next Nobel laureate. I want to change the human world. And I want to be the messiah to heal. But in final year, when you ask him, what do you want to do? I'm praying, God, how will I pass my medicine exam? So why do you think many so-called brilliant medical students feel like they are failures?
Yeah, it is true. When they joined in medical school, +2, 10 +2, they are in a different mindset that we have gone through the exam, board exam. We got 10 by 10 or 9 by 10 like that. So in that euphoria, when they join the medical school, it's a different curriculum. Unfortunately, the present scenario when compared to yours, see, our batch was 6 years course, the universe is 5.5, now it is 4.5. So the biggest failure they feel right from the day one, because thanks to all the NMC conducting the examinations and the delayed of admissions, by the time the university exam is fixed in the August month, their duration instead of 12 months, it is 8 to 9 months. So there is a lot of curriculum, short time, new one, which has not taught in the intermediate at all, and they feel so much failure right from the day one. They are not confident. When it goes to the para and pre-clinicals, again the same story. His foundation is not good. The basic sciences, his foundation is not at all good. He could not cope up with the subject in the second phase. That continued till final year. Every time he postpones, maybe I'll do better in the final year. By the time final year comes, again all 6 subjects they have to pass. Same stress and strain. Then his mindset, I have to just pass. Then maybe in the postgraduate I'll improve. No, during postgraduation, I have 8 pages in a year every time they join. They are not confident in treating an acute case in emergency. They cannot just handle the status epilepticus. Again, he thinks that one day I'll do the DM neurology, maybe I'll read thoroughly, I'll treat it cases. So where the flaw is? Is it the medical education? Is the mindset of the students which have not been confident? Is the way of the inefficient teaching? So it's the multiple factors. So the student is facing, apart from this curriculum, the competition. Competition right from the beginning, he enters into the medical school, the competition in his own class now, he compares with his students, sometimes he compares with his seniors or previous students, again he is depressed. Unfortunately, when I was in faculty in KMC, hardly I used to see any patient who was in depression. Here almost 5 to 8% have screened all the students, are there with the depression in medical college. It's unfortunate. Too much of pressures, too much of ambitions, and this way they feel insecure. Lastly, when they have passed, they did internship, then again NEET. Always he is not confident. Which subject? When I ask which subject you want to choose, is it by chance or it by choice? He is not sure. He thinks about what is the background, the market, who is doing the better. sir, I'll choose the medical stream, or else I'll go for the surgical stream. So they are not confident. So it is high time. Either all the teachers and seniors, the government policy makers should think that where went wrong. Is the medical education system itself wrong? With reducing the time duration of the course, making them more suffer in the same syllabus? They have to redefine the medical education system at all. Otherwise, this will continue and more insecure graduates will come out from the medical colleges.
Absolutely. So when the students are going for their NEET coaching in 11th and 12th, there will be a teacher who will be on their side and say, देखो बेटा राजू, वो एप्पल देख रहे ना, वो गिर रहे हैं, इसलिए इसको न्यूटन्स फर्स्ट लॉ बोलते हैं. क्यों अफसोस है बेटे? That's what you have the teachers in 11th, 12th. When you enter into medical college, oh no, it's a complete paradigm shift, right? So nobody cares what you are, right? So once upon a time we used to read Davidson. After that somebody said Davidson is too much for medicine. So that's the reason he wrote a short notes on Davidson to pass. After that another junior came and said that is too much. It is a short notes to the short notes on the short notes of Davidson. So ultimately only 10 pages you read to get distinction. So that's how our exam passing has become, right? Obviously they are depressed. So that's wonderful. So now I like to ask Shyam. Dr. Shyam is not only a physician, he is also a philosopher. He reads Upanishads, mastered a lot of treatises on Vedas and commentary on the Vedas. So this is an appropriate question for Dr. Shyam. Do you think our medical education system kills creativity? Because medical students are once upon a time known to be the most charismatic guys, right? We only know how to sing, how to dance, how to write a love letter, everything, right? So what happened to all that creativity of that Shakespeare who was there in the first year when they passed to the medical school?
Medical system and creativity, they are absolutely both on the two sides of the spectrum. So we have to see the system. Who is the consumer? The consumer is a medical student. What is the product? The medical education system. Who comes into the medical school nowadays? The person who is afraid of maths. Actually, I represented state Olympiad in National Olympiad exam. And when after finishing my 10th, I asked my neighbor which subject I should take, either MPC or BPC. He told, take BPC. I represented Olympiad in maths. But he told, because I was drawing all pictures on the walls, he thought that because of that, it may help in the botany records and other things. I took the medicine. But nowadays, why people take medicine? The good students, nowadays, they don't come into the medical education. Either they go to IITs, or they do engineering, and after 4 years, they go to US. People whose parents are doctors, are people who are afraid of maths. After studying in MPC or BPC in Narayan and Chaitanya, where the structured education, it will kill the creativity. So the people themselves who choose medicine, they are less creative than the other faculty, other specialties like engineering students and art students. Then the medical education system. There's a very little scope in medical education system because the time is short. Within 1 year, you have to read about all muscles, origins, insertions, bones, primary center, secondary center, physiology, biochemistry. So all these subjects he has to finish in 1 year. And the examination system, it doesn't examine how much you learn. So the examination system is only fact-based, how much knowledge you gain, rather than how much analytical power you got from this education. So when the system itself, when the subject itself is less creative, the student who is entering into the medical system, he himself is a less creative person. So you don't expect creativity in medicine.
Thank you, Shyam. Now we talk about entrepreneurship, right? It's correctly spelled? Entrepreneurship. Okay. Because once I was recruiting a student who came from a management school, I asked, I'll give you a job provided you write the correct spelling of entrepreneur. So, yeah. Now my question to Dr. Harish, right? Dr. Harish is a top-notch surgical gastroenterologist. So every day he takes out the knife. Our SG guys are using knife? I thought only
Sometimes,
keyhole, no?
Both, sir.
Still, okay. So he not only used the knife in the theater, he also knows how to use the knife in the kitchen. I don't mean that every day he cooks, madam doesn't cook. I don't mean that. So there is a very popular, only vegetarian restaurant called Itlu in Hyderabad, Jubilee Hills. All of you can come to the Itlu restaurant and you can tell I met Harish and it's a free meal right there. So now the question is, why are the doctors afraid of calling themselves as anything other than doctors? That is, entrepreneurs. Why they are afraid to be called as entrepreneurs and they only like to be called as doctors? Yes.
So this same question came in my mind a couple of years back when we are entering this food and beverages industry. So it was a discussion like within our family, like whether I should be entering the business. There's no one from our family with a business background. It was a friend who suggested that you should be entering business because back in 2019 when I was doing my MBBS and post-graduation, I used to be a food blogger. So then when my friend is going into this F&B, he wanted me to be the part of that the parent company. So when I had this question in my mind, like why I shouldn't be called as entrepreneur, the traditional way of thinking what a doctor is. When you think about doctor, the first thing that comes to your mind is empathy, humility, service, and being a God complex. But on the other side, when you talk about the business and you talk about the profit, loss, benefit, the money. So I was very much confused, like should I be actually entering into the business side? Or should I plan an alternative source of saving or diversifying my finances? Then I had this clarity in my mind. I'm a businessman outside my hospital. When I'm in hospital, I'll be treating my patients. And even now, even though I work in a corporate, when it comes to the finances, I'll tell directly to the patient. Finances, you'll be talking with the management, not with me. If you ask me what is the best treatment, I can suggest you the best treatment. I'll be doing the best as a surgeon what I can do to my patient. And being a surgeon, it's not the surgery I do always. Because I believe in the one basic line which my professor taught me. When you are operating, you are giving a scar to the patient. And let the scar be worth it. So when you go by these lines, I separate myself. I live two lives. When I'm attending a business meeting in my company, I'll be a completely different person. And when I'm being in a hospital as a surgical gastroenterologist, I'll be completely a different person. So maybe the one reason why I'm scared at the beginning is like, I don't want my name to be associated with some company so that my patient will think he's a businessman, he'll be thinking about the money. So I have separated my life completely. My business is not on my name or like, I've been part of that business holding a major share, but the name of the company is a Feel Good company. It is owned by 5 friends from school. And I don't talk about my business or my company in my hospital premises. And I make sure my patients are aware that Dr. Harish Gautam is a surgical gastroenterologist and nothing more than that. You can just diversify yourself. You can live two ways to make sure that the conflict of an interest is being answered.
Great. So,
now, to continue in that, why medical students are not entrepreneurs? It is personal. How the individual forms his future and he thinks of it. The best entrepreneurs are here, right from Shyam, Murli, Harish, Sai, and etc. See, these were the students 30 years back. The same stream of students. I have seen nearly 4,000 students in KMC who was passed through medicine, whom I was taught. We never introduced the leadership qualities in the medical schools. Or forget about the leadership. Even when we are presenting or when they are presenting, there are no interactive sessions. Hardly they feel shy to ask a question. So this timidness goes only limited to their subject, nothing else. So it is individual, the personality development that you choose the entrepreneurship. But present scenario, we require this quality is essential to practice nowadays because of the high technology you have to use. You have to well verse with that. So it should be the more communicative, his attitude towards the developments. He has to learn the entrepreneur qualities. Maybe he, after MBBS, let him choose for the business schools, one of the MBAs or technology courses. But this is a must for the future medicine.
So my next question to Dr. Sai. Sai is a wonderful nephrologist in America, and it's very boring to do dialysis every day. Am I right, Sai? Yeah? Because the same AV fistula, same dialysis, same sad story, nobody ready to give the kidney. So then Sai one day decided that, let me do something big, right? So he built a platform which is very popular in America that will basically conduct the virtual conferences. One advantage of virtual conferences is we don't eat pro-diabetic food in the conference after talking everything about how to prevent diabetes, right? So that is one advantage of attending. At the same time, we get the CME points. So that's what he built, and it is very popularly followed by a lot of conferences every day. So Sai, what we need to unlearn from what we, if at all we learn anything in medical school, unlearn to become a successful entrepreneur. At least we will learn an attitude by going to medical school, right? We think that we are the most brilliant, we only can be able to do, no one in the world is as good as us, no one is hardworking, all that, like Adolf Hitler, European race is the only race, German race is like that. So what do we need to unlearn in our attitude to humble down from the academic heights of being a doctor to become a hardworking entrepreneur?
So, yeah, I would say two things, rules and risks. So we've been taught to follow rules and mitigate the risks. And even when we take care of patients, we try to identify risk factors and try to prevent or mitigate it. And the biggest thing to unlearn is, as an entrepreneur, you need to break some rules and you need to take some risks. So that's the major factors in deciding to be a clinician and plus entrepreneur. So that will be my shortest answer.
Great. Thank you, Sai. Now, once more to Manohar sir. Let us assume Sir is director of Nizam's Institute of Medical Sciences for almost a decade, and now Sir is the dean and of Apollo Medical College. So, Sir, if you were redesigning the medical education from scratch, let's assume, right? So, what is the first thing that you love to throw away?
Yeah, it's a big question, but I'll try to do justice. There should be a big change in the medical education system. Redesigning in the sense, initially I was sharing with you the duration of the course and the burden, curriculum and the competencies and the competence the later he is facing should be redesigned. First of all, the teaching qualities. It should be an efficient teaching to drive the message, what is the basic need for the society and where he has to build up his career. For which the curriculum has to be changed. Either to all unnecessary syllabus was there, right from page 1 to end of the Davidson, Harrison, whatever textbook you say. It is not at all necessary for all those things. What is our needs to serve the population it needs? So first thing, redefining the syllabus. Number 2, the worst system is assessment. It is a rotten system. What is the assessment? He writes some theory questions, some essay, some short notes. The assessment is totally wrong. So redefining for the betterment. There are 2 things. First, the quality of education. Second, the assessment has to be done in a proper way. Third, what should be driven to them? Think of what are the problems. So education should be oriented towards the case-based discussions, more of small group discussions, or problem-oriented discussions. Then the problem has to be understood properly, not on the mugging type that what they are doing now. Reading those, I'm sorry to say that most of the students, they are reading only guides. They do not know the names of textbook authors. So that is the now present scenario. So if the chance is there, we have repented to the NMC when the curriculum is being changed. Now it is CBME, curriculum-based or competency-based medical education. I hope partly it is changed for the betterment. If it is strictly compliant to each medical college, the quality of medical students after 4 or 5 years will be definitely improved. So if chance is given, first we have to the proper assessment, proper syllabus has to be given for that. The types of teaching should be case-oriented, patient-oriented and problem-oriented, rather than just a theoretical lecture gallery where they could not understand anything. When I was taking theory classes, I questioned myself, what did I learn in Usmania Medical College for those 5 years? I recalled. None of the lectures I never recalled. But if you have a short group, then give a problem and make them understand, thorough reading, then the quality might improve it. So too many things can be taught in the redefining the medical education. So we hope for the better.
Rightly said, Manoj sir. In fact, today in the ward rounds as a professor of medicine, if I ask the students, hey, what's the Glasgow Coma Scale? What's that? Glasgow or Ireland? The student will say, no, Glasgow Coma Scale. Earlier days, we used to all carry Harrison and all that, like preterm babies carried by the mother who delivered, right? Nowadays, nobody is carrying. Okay, prof, no problem. Don't lose your cool, okay? Tuck, 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 tuck. ChatGPT will tell what is Glasgow Coma Scale. Why do we need to bloody remember eye-opening is how much and all, blah, blah, blah. So there is a paradigm shift. Then today you ask ChatGPT, the patient is of this age and this is abdominal pain. What shall I ask next? It will ask which quadrant. Okay, which quadrant? Yeah, next what? It will only guide. So the other day I went to Dr. Sham's clinic in Idea Clinic in. I really fascinated by the way he's taking care of patients. You know, a lady asked, "Sir, what should be my ideal weight and what should I eat?" Oh, is it? He opened the ChatGPT and said, "What is your weight?" Oh, okay. What's you want? All right. You only read. So ChatGPT is explaining everything. Okay, for your weight, this is the ideal, for your height, this is the ideal weight. So today information is all not a big deal. It's not the mastery of information, right? It's all the nautanki of how the art of medicine is practiced on how we empathize and how we talk. So that's the reason definitely we require a huge paradigm shift because we are in the crossroads of the generation. And today, students are not reading books at all. Their Gen Z is all about watching and learning rather than reading, right? They're watching Instagram, they're watching YouTube. How do you ask them to read Harrison and Davidson? That's impossible. Oh man, that drains, right? So shortly, AI should be introduced, computing should be introduced right in the class 6 they are going to introduce. They should also introduce in med school. And also they should introduce marketing, management and all these subjects instead of will superior gluteal nerve or inferior gluteal nerve, which nerve is supplying, which gluteus medius is available on the ChatGPT, no point in mugging them, right? So that's a modification, that's great. Now, I love to ask Shyam Sundar sir, what is the one skill not taught in medical school among many things that are not taught? Can you be able to tell more, and which is most critical today?
At least I'll take two. So, in my clinic, half of the patients who comes to me, they come from going to a gynecologist, and they come to me and ask, "Sir, she is writing LSCS to be done. Shall we do it or not? And she's advising this treatment. Shall we take it or not?" And they go to most famous cardiologist in city. He advises CT, CAG, or conventional CAG. They come to me and ask, "Sir, shall we do, is it right?" Because they don't nowadays believe doctors. They think that we write unnecessary tests, unnecessary medications. So one is a communication skill. Maybe in the medical schools, maybe we are not teaching, we are teaching the subject, but we don't teach them the communication skills, how they should talk to the patients and how they convince patients regarding anything. I mean, one is that, and second thing is documentation. Many times, a patient bring the other doctor's prescriptions. One, it is very difficult to read, and second thing, apart from investigations and treatment, there's nothing is written on the case sheet. I mean, prescription. So documentation is important. Luckily, still most of our patients are not really bother about it. But if a prescription taken to a consumer's court or anywhere, writing too much of details is also sometimes problematic to you because it is very difficult to prove your points written in the prescription. But documentation is important. So documentation of writing a case sheet or a prescription is also maybe one of the things we have to teach the students. So communication skills and documentation, these are the two things I think.
Yes. Absolutely, so Dr. Shyam.
Sir wanted to.
What is not taught is, what we taught was, it was meaningless, honestly speaking. What is given in a textbook, we used to prepare and spell out in the 1 hour lecture. But of late I realized that, for example, I just give you an example. See, instead of in the questions when we are assessing the student, he will say what all metabolism of carbohydrate, all steps he will tell, Cori cycle he will tell. But one question you ask, what is the role of this Cori cycle application in a diabetic ketoacidosis or during fasting? This application is not using his brain, neither we are giving a clue that this should be applied, whatever you have learned. This is the basic thing I realized after so many years.
Thank you, sir. In fact, at 40, I stopped practicing. For 10 years, I enjoyed a holiday of entrepreneurship, starting the startups, and then technology. I'm hands-on coding in Java, Spring Boot, and Python, Node.js, and all. Then at 50, I once more, by a promise I made to myself, I got back into clinical practice. So I went to Dr. Sham to do observership for a while, because almost 10 years as a physician, I stopped practice. Then I learned on the first one. I'm a very fast learner. In first 1 week, Sham taught me the clinical medicine. You know what he taught me? There are two kinds of patients. Patients who want to be evaluated, patients who don't want to be evaluated. And it's your job to evaluate that in the first 5 seconds when the patient comes to an encounter, right? Second, there are patients who have a complete disrespect and no trust at all on the doctors, or the other group are borderline personalities. That is, they will think you are God, you have the healing touch, you will touch and all HbA1c will become 12 to 6, right? So, to assess the emotional and economic ability of a patient to comply with the therapy is in the first 10 seconds, the one who makes an assessment, right, is a good clinician. That's what I learned by doing apprenticeship with Dr. Sham. So, I think these are those finest skills that are the ones which are needed to be taught for a student to learn more than knowledge. So, now, I like to ask Dr. Sai Prasad, what is the boldest risk? You're a nephrologist. That in America, nephrologist means at least $500,000, right? Which is about 4 crores of annual revenue. From there, you said goodbye to that and took a decision, let me start a startup, let me try entrepreneurship. So I love to ask you, is it the first time you took such a risk, or you had been risk-taking right from the MBBS first year? Let me try marijuana one day, that kind of risk also. I would like to know, yeah?
So I think you have answered most of my question. So yeah, I mean, I'm kind of a person who likes to take some risks. So that helped, actually. But if you sit back and think about it, so you spent something about 15 years to work hard and achieve something you've been dreaming of and you dreamt of. And when you feel like you finally arrived, and then you completely stop or even pause of what you have achieved and start all over again on something that doesn't exist. Like during the journey, you see some things, and one of the major issues in healthcare is healthcare accessibility. So to build a platform where that can improve specialty care, accessibility to people, and start from the scratch, you don't know what's going to happen, is the boldest and terrifying risk, actually.
Thank you, Sai. Then, once more, a last question before we go to concluding question to Dr. Harish. There are two kinds, the one who track the path which is being laid, and the others who will take up the paths which are other than a standard path. Have you ever felt yourself betrayed yourself by following the rule book because your dad asked to become a doctor and the fiancé asked to become surgeon and somebody else asked you to become, maybe sometimes you might have been inspired also, right? So have you felt betrayed by following the rules? Because becoming surgical gastroenterologist is like becoming president of Bolivia. I mean, you need to cross so many stages of bloodless coup and finally become that, right? So that means so many hours you might have given up studying MCQs, remembering the high-yield facts, then spending time in the operation theater while your fiancé is waiting at a candlelit party on the poolside, waiting that you will come and slip the ring. You might have made a lot of sacrifices, right? So have you felt betrayed that, following all these rules when my friends are all enjoying the nuptial evening, I'm being stuck up inside the operation theater? What do you...
My ex-girlfriend. I was getting pediatrics, that's my branch of choice in APPG. It was APPG at that time, not NEET actually. And I was given a JIPMER exam. She was like, no, you take in JIPMER. It gives like, you are from National Institute. I'll talk with my parents that you are. So that's the reason I took surgery, which is like third or fourth in my list. And I felt betrayed like after following the traditional path most of the times. When I was in that phase, that particular phase. But down the lane over 5 to 10 years, I'm really glad that I followed the rules. That taught me the discipline, sir, actually. So once you know, when you go by the rule book, even though you feel betrayed at times, at the end of the day, you will be reaching your end path safe. It may take some time, but you'll just reach the end path safe. But then again, I learned after reaching the place where I thought, okay, this is the time I can actually break the rules. I started tweaking the rules. That is how I entered the entrepreneurship. So following the rules taught me the discipline, and now I'm breaking the rules in a disciplined manner.
Thank you, Dr. Harish. One question I like to ask all of you is, of course, there are many patients who changed our life. Definitely for very senior Professor Manohar sir. So can you please tell us about one patient who changed your life and how that shaped your choices? I like to ask that question to all of you.
I think they have given a bell, we have crossed the time, but I'll take 2 minutes. It was 66, 67 when I was in 5th class. The school headmaster was my father. He was very strict. Then there was a prayer session before we start the classes. All classes, 4th, 5th, 6th, like that, in line. So my junior class, when they were going, there are 2 boys. So people used to make fun of them. They used to throw, like, push them. They fall on the ground. They were very difficult to get up from the ground. I was fabulous. Then one of my classmates asked me, Manohar, why don't you read, since you are first in the class, become a doctor and see that these fellows are treated properly. Then I was struggling to know what it is. So during my pediatrics posting, I came to know that is DMD. And that changed my decision in the 5th class to become the medical doctor. And the same thing, it was haunting me. And during my stay in NIMS, we started the genetic lab, a big project on how to go with the CRISPR technology, single gene therapy. We were doing on thalassemia, but later one group came and said we will work out in DMD, and that work is progressing on.
Wonderful, sir. And one patient, I'll tell you, I was a MD general medicine resident in first year. I used to be most difficult resident to make work for my professors. Because if they discover 100 ways to make me work, I used to discover 101 ways to escape, right? So once I was writing the discharge summary, so suddenly one professor of, he's a professor of Urdu University. Doctor Sahab, aap kya kiya? Ye sahi nahi hai, he said. What did I do? I asked. So he gave, मेरे बीबी का HbA1c value आप wrong लिखा. Oh, is it? Sorry, fasting blood sugar value. Is it? How much did I write? I said. It was a post-duty time. आप 127 लिखा. Oh, is it? But what is the actual value? I asked. He said 128. I said, sir, there are 20 patients I need to write the discharge, and I am the laziest bug, most intellectual but laziest bug, who is crying and writing it like a postpartum hemorrhagic lady, right? Is 127, 128, is any difference, I asked. Then that professor of Dr. Qureshi was his name. He said, the wind blows on account of truth. The sun shines on account of truth. Because the truth is the Almighty Allah. How will the wind blow? That is only because of the truth. And what you have written is not truth. If what you have written is not truth, how can you be diagnosing the truth, what is happening in the patient? We say that the patient is having enteric fever based on Vidal. But how sure we are that it is the enteric fever? So what is the truth? Is the question. That totally changed me. From then onwards, I stopped giving a false gospel to the patient saying that it doesn't make any difference at all. For the patient, it makes the difference, right? So that's what I always remember, sir. So the truth is what we need to discover in the history and everything in our intuition and all. So finally, I love to ask a question to all of you that we all leave legacy on this planet. What is the purpose? After we die, even that day evening also, nobody will remember. Except they put one photograph and after within another, maximum 1 week, if you are a very popular guy with lot of debts, if we have debts, people remember much better because without paying debts, we died, right? So, what is the legacy do you want to be remembered for and to be written on the tombstone? Is it a title or a company or a change that you created? What should be the last moment legacy you want to leave, sir? I like to ask all of you.
One word, a change for better. One word, a change is required for better.
Great. It's a change.
So, I would say I want to build something basic like a model to bridge the gap of healthcare access so that the coming generations, the future generations can build a better and bigger model than that. And if they tell us that, yeah, we know that and we have a better model to do this, then I've done my job.
But from practicing evidence-based, I just want to remember me for something very innovative, not just being an evidence-based practitioner, be it in the lines of medical education or in the other fields too. And I just want to remember when when they smile rather than when they're in pain.
Thank you for the patient listening And I would like to ask among the audience to talk on the final comments on entrepreneurship and medical education, please. Yes.
It's very nice, sir. Thank you very much. What I noticed is better educate the students about the stress management, and after becoming a graduate or postgraduate, regarding the financial management also, a part of the medical education from MBBS. How to, many practical points already, you people being seniors, you have discussed. Only 2 points, stress management for the medical students or PGs, whatever may be work pressure or personal family problems or whatever may be. Because being the busiest persons, medicos or doctors, our profession is busiest one, we have to manage everything. And if we are balanced in both personal life and professional life, stress management is the first one to be taught in undergraduation. That's what I feel. Okay, sir. Thank you.
Yes.
Thank you, sir. It was really excellent, the panel discussion. Very fortunate to be in this session. I'm myself Dr. Mohammed Sarosh, Professor of Community Medicine, Deccan College of Medical Science. So the need I experience is need for mentors, ideal mentors like you all on the stage. We would like to have mentors like you. So for me, what learning would be to be an ideal mentor for my mentees. That is how medical education and internship, entrepreneurship would be cascaded to our students. Thank you, sir.
For these comments and suggestions, Madam, there is in the curriculum, the stress management is introduced to the undergraduates from NMC, and every year we conduct the yoga classes, and also there will be sessions for stress-free management. 4 hours have been allotted for that. The second, mentorship, right from the first day 1 in the medical college, every phase, each faculty, 5 students have been given for the mentor-menteeship. So I have been allotted 5 students. They are followed from the first year till they have to pass. Suppose if I am there in the service for next 2 years, I'll be following this. So one more I would like to share with the quality of education which we have introduced with previously medical school research is dismal. I have introduced the research for the first year students to take up the proposal. They have to write with the mentor and they will help you. In the second year they have to do the methodology, and third year they have to submit the paper. So make them inculcate in the medical school that research is a part of in their life. Secondly, the applications, what I was telling an example that we tell only theory, but true translation to the clinical side or wherever they are practicing, the applications have been also taught. So stress management, so that no doctor should be suffered with the burnt out disease. So many of us, we have conducted a burnout session for all the doctors. We neglect our health, including me. I have undergone CIBG after so much of stress in the previous posting. See, it is true that we do neglect our health. So it is a high time all of us in the 24 hours allot 1 or 2 hours for your own health. If you are good, you can discharge the service bed in a better way. So thanks for this opportunity. Thank you very much.
Thank you.
Thank you, Doctor. It was a very good interactive session. Next session would be on the workshops. We'll be starting with the workshops. So total, we have 4 workshops. Thyroid, ultrasound interpretation and hands-on training by Dr. Brinda Agarwal. Thyroid FNAC, practical training on techniques and interpretation by Dr. Siddhartha Chakravarti. Diabetic foot examination and wound care by Dr. Ramarao and Dr. Ram Prabhu. Continuous glucose monitoring system and insulin pump therapy by Dr. Kalyan Chakravarti. Announcement. Certificates are ready. You can collect at the reception registration desk. Those who are attending the workshop, even after the workshop also will be distributing the certificates. Yes, sir, you can.
Audio off. Boss, audio off. So we'll be conducting the workshops here. So those who are interested, please stay on. And they will be split into 4 groups for a more hands-on. One will be for diabetic foot with Dr. Ramarao. The other one will be thyroid FNA and thyroid ultrasound. The other one will be CGM and insulin pumps with me, Dr. Kalyan. So I request everyone to divide into 4 groups, 4 in each corner. So the format will be 15-20 minute session at each table. You all will rotate around. Please put a buzzer for 15 minutes once we start, once everybody is ready. And then all batches will rotate around. Everybody will go through the CGM workshop, the insulin, the diabetic foot, the thyroid ultrasound and thyroid FNA. There will be 15 minutes at each slot. So I am Dr. Kalyan. I will be here. Dr. Ramarao and Dr. Ramprabhu will be at this corner. Dr. Siddharth Chakravarti, this surgeon, will be there on the other corner, and Dr. Vrinda Agarwal. Where is she? Vrinda? You will be there? Thyroid FNA, right? So you can just take one of those corners.
So after the workshops, we also have quiz. Please do register for the quiz. Registrations were started. So we are available for the registrations at the right side of the stage.
Low glucose events have occurred. What is the average glucose at any particular time interval in the mornings and the afternoons? Again, this is a daily graph. This is the estimated A1C. So all of it is available. And you have a daily pattern which is like an AGP. Have you heard of AGP, ambulatory glucose profile, where you have 10 days worth of daily graphs. You cannot dissect every day's worth. So the software will do is it will average out all the 10 graphs every day and it will give you as an AGP. So for example, on a particular day, your fasting level was 70, another day 90, another day. It will give you what the median level on that day.
You can't go, your needle can't go like that. You must understand that your needle also should follow this track. So only if it is in the center of this, you will see. If it is not in the center, you can't see. Can you just give me that bowel is there? There is a bowl there. The other one? No, the other empty bowl. Put some water in it. Put a lot of water. Can you just give it to me? We need a thin person.
I'm the patient.
Lay it down.
This will not even take my way. Just sit first, and don't drink, ma'am. Sit only. I think, ma'am, sitting is okay, or if you want to lie down.
Basic minimum requirement if you are doing in a clinic, the handheld down.
Yeah, and that's how you see this black coloration, which is basically a dropout of the signal. This is your break. Understood? Somewhere on the left side, we'll see if we can see it more clearly, but there's going to be your esophagus. When you are not sure whether it looks like esophagus or not, just ask the patient.
100, you will require another additional 1 or 2 units. So it will give 11 or 11.5 units back. The other thing it will do is correction bolus. This is pre-correction. That means before a bolus. After you give the bolus, let's say patient actually had 150 grams of carbohydrate, or he is insulin resistant, he requires more insulin. So when you give the insulin, if the sugar is going up more than usual, it will sense that, okay, this 10 units is not enough, I have to give more correction boluses. That is called correction bolus. That is the additional feature it has. Autobasal, correction bolus, and the third thing is suspend on low or suspend before low. It will not wait for the sugar to go below 70 before it suspends. Because by the time it is 70, there is already a lot of insulin in the system, the patient can go low. If it is sensing that it is actually dropping too quickly, it will stop the flow. So insulin will completely stop. It will restart when it is going back up, just like how our own pancreas works. So these are the three features available in this pump. The smartphone app is CareLink. CareLink is the one where you see it on your system. So I've told you about all of this. Don't worry about the integrity of it. Insulin to carb ratio, active insulin time. It's what again you set in, because how much insulin activity that you want. Like that, for example, for 2 hours, if I give a bolus insulin, if I set that active insulin time is 2 hours for this insulin, the pump will be very careful in giving extra boluses because there is already active bolus inside. If I say 4 hours, for 4 hours, it will be very careful about the correction bolus. So these are the three things that initially I set in, and after that, the pump takes over. You calculate a total daily dose. For example, if somebody using 100 units, you subtract 20% of it. So let's say somebody is on 50 units of basal lantus and 50 units of bolus in 3 divided doses, total 100 units. You take off 20% because this is very.
హలో ఫోన్ చేసినాక కదన్నా హలో హలో ప్రణీష్ ఏ ప్రణీష్ హలో హలో
In round 5, you can third prize. Have you understood the rules? Any doubts? So each question will have 5 seconds. That question has become a dummy question, right?
So, write just the option number? Or
Yes, option. You have to write the option. Okay, so can we start? So each question will be only 5 seconds. Okay, so keep a timer with you. So all the teams have pen and paper, right? Okay. So first question. therapies acts primarily on which nephron segment? A. Ascending loop, B. Distal convoluted tubule, C. Collecting duct, D. Proximal convoluted tubule. 5 seconds. Question 2. So what is the half-life of PTH? PTH is nothing but parathyroid hormone. 30 minutes A, 5 minutes B, 2 hours C, 1 hour D. So what is the half-life of parathyroid hormone? So question number 2. Question number 3. Endogenous insulin secretion is greater after oral glucose than IV. Because of which hormone? Is it because of incretin or because of the Banten, Yamaguchi or Sonogi phenomenon? So which is making endogenous insulin secretion greater after oral glucose than IV glucose? Question 4. What are the OGTT cutoffs for diagnosing gestational diabetes mellitus? At 0 hour, 1 hour, 2 hour, what are the values? Option A 82, 160, 140. Option B 92, 180, 153. Option C 70, 150, 120. Option D 100, 192 and 163. Question 5. SGLT2 inhibitors acts on which part of the kidney? Option A DCT, B glucophenolate, C PCT and D nephron. Which part? Then question 6. SHBG levels are typically. So what are the levels of SHBG? So do you know what is SHBG? Sex hormone binding globulin. High, low, normal, variable. Question 7. So what is corrected calcium? So if you were given calcium levels of 8.4 and albumin 2, so how will you calculate and what is the value? Corrected calcium. You can do 10 seconds for this question. You need to calculate it. What is the formula? Question 8. So what is the triad of chlorometry? Option A, facial flush, abdominal pain, hypertension. Option B, abdominal pain, sweating, headache. Option C, headache, sweating, tachycardia. Option D, hypertension, facial flush, and abdominal pain. Question 9. Maturity onset diabetes of pain. What is the type with renal cyst? And what is the mutation in that? HNF1 beta, GCK, glucokinase, HNF4 alpha, HNF1 alpha. What is the mutation involved in body with renal cyst? What is the first step in correcting hypocalcemia? If calcium levels are around 6, so what will you do? Will you give oral tablet calcium, or will you give vitamin D tablet, or will you give infusion with calcium gluconate, or are you going to combine calcium with vitamin D? Just exchange your answer sheets with your neighbor teams. Exchange your answer sheets with your neighbor teams. You will correct? Okay. Please correct all the answer sheets. Time up. So come back to question number 1. So now each team will try to answer these questions with explanations. So priority will be given to endocrine residents. So question number 1. Round 1 question. So team 1, Rakshika and Krishna, you will answer this first question. What is ADH and where will it act? Mike, please. Mike. Give to team 1. What is team 1? You can answer even without mind.
Collecting them.
Collecting that. Which part of collecting that? Cells. What cells? Taxon.
Principal cells.
Principal cells of collecting that. So answer is C. So question 2. So another endocrine is 7. Subramaniam. So what is the half-life of PTH? Huh? 5 minutes. Right? Question 3. So what is the mechanism? Team length. Ingredient. Right. Next. What are the OGTT cutoffs? Anyone can answer. Diabetologist. No, give the chance to diabetologist team. Yes? 92, 180 and 153. Right? Next question. So SGLT2 inhibitor acts on which part of kidney? Proximal collecting tubule. C. Next question. So SHBG levels are typically low. High? High in thyroidoxicosis. Next. What is this calcium, calculated calcium value? What is the formula? Any endo team? Or even medicine team also can answer. Yes? So what is the value? 10. Next question. So what is the triad of euchromocytoma? Which option? A, B, C, C. So headache, sweating and tachycardia. Next. What is the Modi type? Type? Type 5. Yes. Next. So what you will do? You will give infusion with calcium carbonate. Okay.
చెప్పు